Hello, everybody. Hello, Dr. Pradeep.
Hello, sir. Good afternoon, sir.
Good afternoon. How are you?
Fine,
Hello,
sir.
Dr. Cheese.
How are you?
Good afternoon, sir.
Hello, Dr. Mudita. Good afternoon. Hello, Dr. Cheese.
Hello, good morning.
Good morning. Yeah. So we have got 1:49. We'll start exactly at 2 o'clock with the session on the calcium session. I think the calcium cases are a bit more, but we should be able to focus because other sessions may be a bit smaller. So I think there should not be a problem on that. We should be able to compensate on that. And any other points to discuss just before we start?
No, sir. It's fine.
Okay. Sure. So I've put
Sir,
the YouTube link also in the group. So anybody who can't join, they can join via YouTube. So if you want, I can put here also. You can distribute from there.
Sir, slides will be run through from your side.
From this side only, so that there's no confusion. We'll control it that way. It
Okay.
will not be. So I think we'll start then in maybe around 10 minutes from now. Yeah. Exactly. Yeah.
Okay, sir.
Okay, so we'll be going live in the next 2 minutes. We'll start off with the calcium session first. And Dr. Chisholm is already there. Dr. Pradeep is there. And yeah, hello, Dr. Seema. And we have got Dr. Anamika is also there. Now we've got Dr. Lalit is the only one left. So we'll see, he'll probably join in some time. So we'll start right in a couple of minutes, exactly at the clock of 2, we'll start the program. Yeah, it's already running live on YouTube as well as on the website as well. So Dr. Pradeep, you are not a panelist because then your photos and videos might not come in. Yeah.
So am I supposed to join at the hypoglycemia session only or this session also?
No, you can definitely continue, but your presence in hypoglycemia is absolutely required, but we'll love for you to be there. Yeah.
Sure. Thank you.
And if you want to give some inputs, you can give inputs as well in between once the discussion is going on. Yeah, after that. Yeah. Sure. Okay. So good afternoon, everybody. And we'd like to welcome all of you for this second day of Practical Pediatric Endocrine course. The first day was really wonderful. We had over 500 views, which happened across the globe. A lot of inputs from countries, all parts of India, as well as neighboring countries, Africa, Europe, and even Australia. So it was a very wonderful session. We had discussion on 4 very important topics on growth, thyroid, puberty, and DSD. Today, we're going to take forward towards emergencies. And the emergency topics we're going to cover today include calcium to begin with. Then we will have a discussion on electrolytes, followed by DKA and hypoglycemia. So very important endocrine emergencies to be covered today. We'll start off with the first session on the calcium disorder. And it is indeed a pleasure for me to introduce the participants in this program. We've got wonderful people from across the globe who are part of this program. And this is the schedule for today. So we're starting off with the calcium module today. And in that, we have got 4 faculty experts, Dr. Pradeep Kumar, who is working as Associate Professor at AIIMS Patna, Dr. Anamika Saha, who is from Bangladesh, Dhaka Medical College and Hospital. She's working as a consultant there. Dr. Chisholm, who is very active in pediatric endocrinology from Nigeria, and Dr. Lalit from Balaji Hospital. I'll be joined by Dr. Prateek, our erstwhile fellow and now consultant in pediatric endocrinology at Regency CDER to discuss this session from there. So Dr. Pradeep needs no introduction for our group. He has been involved very closely with regards to MedEClasses and other aspects, and has been doing very active job in terms of setting up a pediatric endocrine clinic at Patna. And welcome, Dr. Pradeep, to the program. Dr. Chisholm has been very actively involved with our program, and she's working as a consultant pediatrician and lecturer in Department of Pediatrics at Awaka, Anambra, Nigeria. Welcome, Dr. Chisholm, and she is head of endocrinology and hematology oncology unit, and very active in terms of pediatric endocrinology. Welcome, Dr. Chisholm.
Thank you very much, Dr. Anurag. I'm very pleased to be here today. I was here yesterday and I'm practically pleased to be here today. I've learned a lot from the program and I've introduced them to a lot of my colleagues at work. You've been an excellent teacher and I'm proud to be here. Thank you very much.
Thank you. We've got Dr. Anamika Saha, who has been with our program for the last 1 year. Dr. Anamika is working as a consultant pediatrician at Dhaka Medical College and Hospital, Dhaka. Dr. Anamika, welcome to the session.
Thank you, sir. Good afternoon, sir, and everybody. And I'm very much pleased to join here. And I would like to say one thing, sir, that this online learning platform created, it's a blessings for the pediatricians who want to see themselves say, as a pediatric endocrinologist in future. So your discussion, updated information, analysis, everything help us in our daily clinical practice. So thank you very much. And I also look forward to join your on-site, any conference or course also. Thank you.
Sure, Dr. Anamika. Thanks a lot for this nice words. We also have Dr. Lalit, who is a consultant pediatrician at Balaji Action Hospital in New Delhi, and he's just joining, I think. So, Dr. Lalit, are you there? He has been part of our program for the last 3 years, very active in terms of intensive care and as well as pediatric endocrinology. So welcome, Dr. Lalit, to the program. And without wasting any time, we'll start off directly with the session. As discussed last time, we'll have a very brief overview of this program so as to allow the cases to run, and then we'll have immediate case discussion, which will start right away. So this session is about calcium, and calcium is in fact one of the most common emergencies which a pediatrician will encounter, both in terms of hypocalcemia and hypercalcemia. There are also issues with regards to bony deformities and rickets, which are very common. So just one slide about basic calcium physiology. We all know that 99% of calcium of the entire body is actually stored in the bones. And it's only the 1% which is actually available in the blood. And it is this mixture wherein we get the supply of calcium, which happens in that regard, which is there in the blood. Now, calcium in the blood is circulating bound to albumin, which is 40%, and bound to phosphorus, which is 10%, but it's actually the free form, which is the ionic calcium, which is important. And this will become relevant when we discuss cases where there are issues in terms of albumin levels and how that affects. So conditions which are associated with hypoalbuminemia, like nephrotic syndrome, chronic liver disease, will have pseudo hypocalcemia, while conditions associated with increased albumin or increased protein, characteristically in the setting of myelomas, will have what is known as pseudo hypercalcemia. So that's why you always have to rely on what's the albumin level, and therein lies the importance of the ionic calcium, which we'll discuss subsequently. Now, the second major determinant of the level of ionic calcium is the blood pH, because pH determines how much albumin will bind the calcium. In conditions which are associated with alkalosis, like respiratory alkalosis, you will have a situation wherein the albumin binding will go up, and therefore the relative ionic calcium will become less. This is particularly relevant when we see functional individuals with hyperventilation. They develop tetany. The reason for that is that suddenly there is increase in the calcium fraction which is bound to albumin, and that causes ionic hypocalcemia. Similarly, if you're hyperventilating a child, you will predispose to hypocalcemia, and that is also something which should be avoided. Conditions which increase the amount of ionic calcium basically include acidosis, and that's very important from a renal failure perspective. So a renal failure individual may be at the borderline level as far as calcium is concerned. It is maintained because the child is acidotic. But as soon as you give bicarb, suddenly the ionic calcium will come down and they will develop tetany. So whenever you give soda bicarb to anybody who has renal failure, always consider giving calcium also in that perspective. Now, what is calcium dependent upon? There are three major organs that regulate calcium levels in the body, namely the intestine, the bone, and the kidneys, out of which the most important acute one is the bone. Intestine is important for chronic function, while the kidneys are important more for a long-term regulation as well. And there are three hormones which regulate the whole process: the parathyroid hormone, the calcitriol, and calcitonin. Now, just without going much into detail, you need to remember that PTH increases calcium while decreasing phosphorus. So in anybody who has hypocalcemia, we should have secondary hyperparathyroidism along with hypophosphatemia. So anybody who has hypocalcemia should have low phosphorus level. Hypocalcemia with high phosphorus suggests that either there is a kidney problem or there is a problem at the level of the PTH. So phosphorus is the most important investigation in any child who presents to you with hypocalcemia, and we'll show plenty of cases to show how it becomes very, very relevant. On the other hand side, in hyperparathyroidism, when you have high calcium, you would expect phosphorus to be low. If you have hypercalcemia with hyperphosphatemia, your PTH causes are out. You're dealing with either vitamin D excess, you're dealing with conditions in which bone is resorbing too much, like immobilization, or bone is not forming, which may happen in the setting of hypophosphatasia. So hypercalcemia with hyperphosphatemia excludes a PTH etiology, and therefore it's very important to look at phosphorus levels both in hypo as well as hypercalcemia. Now, calcitriol increases calcium as well as phosphorus levels. So if you have a calcitriol excess, which may most commonly we see in the setting of somebody who has taken a lot of vitamin D, or somebody who has got sarcoidosis in which the conversion is more, you will get hypercalcemia with hyperphosphatemia. On the other hand, if you have vitamin D deficiency, your calcium levels will come down, PTH will go up, and your phosphorus level will come down. So vitamin D deficiency would have hypocalcemia with hypophosphatemia. But there is one important caveat, and this is what we discuss in the quiz this time. In individuals who have long-standing hypocalcemia due to vitamin D deficiency, the body says, we anyway are not doing much, let the PTH action be blunted. So there is a secondary PTH resistance which happens in long-standing vitamin D deficiency, and that gives a picture of hypocalcemia, hyperphosphatemia, along with high PTH, which people may label as pseudo-hypoparathyroidism. So the big message is, before you diagnose pseudo-hypoparathyroidism, always look at vitamin D level, and that becomes very important. Now, this all is sensed by the calcium sensing receptor. We are not going to do too much because that will be a bit confusing from that perspective. Now, it's very important for pediatricians to know when to think of hypocalcemia. Any child with seizures, cardiac failure, intracranial calcification, all three cases will come up very soon. Children with features of headache, papilledema, raised ICT, laryngospasm, differential of stridor, think of hypocalcemia. Chronic hypocalcemia can cause cataract. So all of this is important to understand. And of course, in the newborn period, you have to be doubly sure that hypocalcemia is not the cause of jitteriness or the cause of apnea. So it's a very important differential to understand from that perspective. Now, how do you assess calcium levels? The assessment basically has to be in a fasting state in a serum sample. As discussed, if your albumin is low, your total calcium will be falsely low. And if your protein is high, your total calcium will be falsely high. This is relevant for myeloma, as I said, because myeloma also causes hypercalcemia. But because of high protein, you may also have pseudo-hypercalcemia. So look at ionic calcium in that setting. This is a formula. So for every gram increase or decrease in albumin, you need to correct 0.8 as far as the ionic calcium is concerned. And this is what we'll discuss in that regards. What about phosphorus? The biggest thing to remember about phosphorus is that it should always be done in a morning fasting sample. Because if you take a carbohydrate meal, insulin will go up and phosphorus will come down. So you should not do in a post-meal sample. It is an intracellular ion, so never squeeze. So like potassium, phosphorus levels will also be high if you have a tourniquet sample or a squeeze sample. And very importantly, don't look at the adult cutoffs, because adult cutoffs are lower. Children have much higher level of phosphorus, and we'll discuss this in a couple of cases. But I would say one thing, as we discussed yesterday, in a short child, the most important thing to look at is actually the weight. In a fat child, the most important thing to look at is actually the height. The most important thing to look at in a child with rickets, hypocalcemia, hypercalcemia is phosphorus. So this is the most important investigation which we'll do in the setting of hypocalcemia, hypercalcemia, and even rickets. Everywhere it is most relevant. Now, another important investigation which you might do is the parathyroid hormone. Now, what you need to remember is that there is a log linear relationship between PTH and calcium. So whenever you are interpreting PTH, always interpret in the light of calcium levels. So if somebody has hypocalcemia, the PTH level should be high. If the PTH level is even normal, that becomes significant. So as we were discussing yesterday, that if your TSH is less than 20 in somebody whose FT4 is low, this is still a central hypothyroidism. Similarly, if the PTH is low normal in the setting of hypocalcemia, this becomes hypoparathyroidism. The biggest problem in PTH assessment is actually the way the sample is taken. Now, PTH is a highly thermolabile hormone. If you allow it to keep, somebody takes in a collection center and it puts it for a few hours, your result will be 0. So often you will get picture that your calcium is low and PTH is low. You haven't looked at the phosphorus and you will say it is hypoparathyroidism. No, that's not the case. Just a bit of approach. So whenever you have a child with hypocalcemia, first confirm that this is a true hypocalcemia. In that setting, also look at other causes like magnesium and phosphorus load. Then based upon phosphorus, if your phosphorus is high, look for renal failure. If creatinine is normal, do a PTH level. And if PTH, you will decide whether it is hypo or pseudo hypoparathyroidism. If the phosphorus is low and magnesium is normal, look for vitamin D. And then mostly you're dealing with vitamin D related causes, either vitamin D deficiency or VDDR. So the most important things include phosphorus, PTH, creatinine, and magnesium. These 4, very importantly, if you use that algorithm, you will be able to make a diagnosis. So we'll now start right away with the first case. Dr. Pratik, kindly come up and start this discussion, please.
Thank you, sir. So we begin the discussion. A 4-month-old boy diagnosed with nephrotic syndrome presented with the calcium of 7.2 mg per dl, but was asymptomatic. So Dr. Pradeep, how do we treat this child? We start calcium?
Okay, so this child is having nephrotic syndrome. So as we had discussion, initially we have to think about any phosphate load or what the actual clinical condition is there, magnesium, etc. So here the child is that of nephrotic syndrome. This child is probably having hypoalbuminemia. So we have to first correct it with calcium, and as the formula is measured calcium, then in bracket 4 minus the present albumin. So if, okay, the albumin is 2. So
Yes.
when we put in the formula itself, so measured calcium was probably 7 point something, yes, plus it will be in bracket 4 minus 2 into 0.8 milligram per deciliter. So if we calculate it, so it will come approximately, if anyone can calculate it, so it will be, yes, so it's coming around 8.8 milligram per deciliter, so which is in range. So overall this child is having nephrotic syndrome who is losing albumin. So this child is having basically pseudo hypocalcemia. So from calcium point of view, this child need not any treatment, just the child has to be treated for nephrotic syndrome. That would I would say.
So the
Yes.
key messages in this case, yes, sir.
Yes, go ahead, Pratik.
So the next child, a 4-year-old girl presented with tetany. The ionic calcium was 3.1 mg per dl. The phosphate done was 8.4 and the PTH was high at 130. And this child was labeled as pseudo hypoparathyroidism. Was this a correct diagnosis, Dr. Anamika?
Thank you, Dr. Pratik. Actually, this scenario points to pseudo hypoparathyroidism, but before going to reach a final diagnosis, we should go for a comprehensive assessment in a systematic way to exclude other causes of hypocalcemia. So our approach should be like this. So during evaluation of hypocalcemia, we should include magnesium to exclude hypomagnesemia. We should include albumin to exclude pseudo hypocalcemia and phosphate load by taking history of formula fit, and features of hemolysis, tumor lysis features, and rhabdomyolysis should be considered. So after excluding all of this, our next step will be serum phosphorus level, which is the most important distinguishing factor which help us to reach the diagnosis. So as the patient has, as I already know, the patient had serum phosphorus level 8.4, that was high. So my next step is serum creatinine. Creatinine was found 2.4 it's quite high. So the diagnosis is chronic kidney disease. Then why the parathyroid level was high? Basically, it's due to secondary parathyroidism induced by hypocalcemia. So key messages are during evaluation of hypocalcemia, serum phosphorus is very important to distinguish causes of hypocalcemia. If high phosphorus level was high, do serum creatinine, and if creatinine level is normal, do parathyroid hormone level.
Yeah, I'll request the participants to mute yourself if you're not active thing because it causes a bit of an echo. So I think this was a very, very important message that we should not get confused. So the main message in that perspective is that we should not get confused with regards to these issues, because phosphorus is high. The first thing is renal failure. The most common condition is always more common. That we have to consider in that perspective. And if it is uncommon, then only we should go for the other rarer disorders and conditions which are there in that perspective. So this was a very important message from Dr. Anamika. I'll request all the faculty members to kindly keep them mute unless they are in the part of the active discussion. Thank you. So we'll carry forward for the next case. I think we already discussed two important cases. The next case, Dr. Prateek. Yes.
So, a 1-year-old boy with neonatal seizures with a calcium of 5.4 mg per liter. The phosphorus was 6.1 mg per liter. PTH was 11, which is low, and there was no response to IV calcium. Dr. Chisholm, are we missing something in the diagnosis?
Okay, thank you for the question, Dr. Prateek. So this is a case of a 1-year-old boy with neonatal seizure, obviously with hypocalcemia. The phosphorus level is normal, and the PTH level also normal, which is not in keeping with hypocalcemia, which we should expect it to be high if it's a vitamin D dependent cause, or if it's a PTH related cause, which is what people will suspect, it should be normal or low. But the key thing here is that there's no response to intravenous calcium. So what the assessment should be like? Can you move to assessment, please? So in the assessment, the first thing to check in any case of hypocalcemia, like Dr. Anurag said, is the phosphorus. It's very important to always check for the phosphorus level. In this case, even though it's low, I would like to also make sure that magnesium level is being assessed. The reason for this is that PTH level being low suggests an impaired PTH effect. And Dr. Anurag also suggested that if you're going to make a diagnosis of impaired PTH effect, it's important to make sure that the magnesium level is normal, creatinine level is normal, and vitamin D level is normal. In this case, the magnesium level was found to be low. Normal level is meant to be between 0.7 to 1 milligram per DL, but in this child, it was 0.42 milligram per DL. And also remember, these seizures, there was a history of neonatal seizures. So this started early on. So it's very important to consider a genetic cause for this hypomagnesemia. In this case, the child was assayed and found to have a TRIM6 defect, which is essentially a channel that is responsible for the active transport of magnesium at the level of the gut and at the level of the kidney. So if there's a TRIM6 defect, if you're going to manage this case, it's very important to give very high doses of oral magnesium. Why? Because you're going to rely on the passive transport of magnesium at the level of the gut and at the level of the kidneys. So if there's a high dose of magnesium, it allows for a higher passive absorption of magnesium, giving rise to a normal magnesium level that will correct for the issues that we are currently having. So coming to the management, everything depends. So the key messages here, obviously, is that for any refractory hypocalcemia, it's very important to check for magnesium levels, because hypomagnesemia can lead to decreased PTH level, can lead to end organ unresponsiveness, and it can even inhibit the action of 1-alpha hydroxylase, leading to decreased calcitriol, leading to decreased resorption of calcium. Net effect being hypocalcemia that is refractory to any form of treatment. Thank you very much.
Thank you, Dr. Chisholm.
I think the big, very interesting, Dr. Chisholm, you put very important, relevant points. That one key issue probably out here is that this child, the phosphorus levels were not high. So if the is low, you expect phosphorus to be high. So if your phosphorus is normal, then you have to think of other causes, and then magnesium becomes absolutely important. Thank you. Thanks for that. Yeah.
Next case is a 3-month-old child with seizures. The ionic calcium was 3.2 mg per dl. The phosphorus was 2.2 mg per dl, and the pH also low at 3.4. And this child was labeled as hypoparathyroidism. Dr. Lalit, is this the correct diagnosis?
Yeah, thank you, Dr. Pradeep. Child's calcium level appears to be 3.2. Phosphate appears to be on the lower side. PTH appears to be still on the lower side. So this doesn't look like hypoparathyroidism to me as such. What are the other hormonal levels?
Yes.
Do we have hypocalcemia associated?
Go to the next slide.
Yeah. Yes. The thing is, whenever there is phosphorus, which is on the lower side, and we have to look for vitamin D. What is the vitamin D level? And
So
parathyroid, yeah,
Yes, sir. Yes.
it was on the lower side, so it is less than 3. So this is basically a vitamin D deficiency. And PTH is a very sensitive molecule. So most likely there was some problem with the transport of the molecule as it is temperature labile. So the key messages that goes is transport PTH on ice and has to be very carefully taken, and low phosphate goes against parathyroid deficiency. Thank you.
This was a very, very important message which came in from Dr. Lalit. Essentially, that this child actually had a low phosphorus. So I think first you have to go get your basics right. If phosphorus is low, how can phosphorus be low if your PTH is not working? So PTH has to work for phosphorus to be low. That was a big message. Now, often as we discussed, that PTH is one of the most labile hormone along with insulin. So if you order insulin or PTH, don't ask people to come to your home and collect it and then take it unless they are doing it on ice. Best to do in the same lab which can run immediately. So phosphorus, as discussed in both these cases, in one phosphorus was not high, so that went against impaired PTH. Here it is absolute. Low phosphorus cannot happen without PTH. So this is very, very clear from that perspective. Thank you. Thank you, Dr. Lalit.
The next case is a 1-week-old boy who had seizures. The ionic calcium came low at 2.4. The phosphorus was 9.1. Creatinine was normal. Dr. Pradeep, how do we proceed from here?
Okay, thank you, Dr. Pratik. Basically, ionic calcium is towards lower side. So phosphate is usually it should follow the calcium, but here phosphate is higher side, towards higher side. And whenever the phosphate is towards higher side, we should always rule out CKD. But in contrary to that, creatinine is also normal. So our next step will be PTH. So what is PTH?
The PTH was 2.
PTH is also, yes, it is towards lower side. So, okay, definitely this case is going to be hypoparathyroidism. And this is, since this is a small kid presenting with hypoparathyroidism, so we should always think about, we should always rule out DiGeorge syndrome, where we should always screen for cardiac anomalies, hearing, and etc. So this should be always kept in mind whenever we are treating a child who is having hypocalcemia and we are diagnosing hypoparathyroidism. So always DiGeorge syndrome should be ruled out. But many times thymus may be absent in a sick child also. So we should take this in account also whenever we are diagnosing DiGeorge syndrome. Yes, so high phosphate all suggests PTH defect, and always cardiac evaluation like conotruncal defect should be ruled out. Thank you, Pradeep.
I think, Dr. Pradeep, very important message. So if you diagnose hypoparathyroidism, that is very rare. So once you have diagnosed, you have to go, what is the cause? You can't just leave it. Like that child which we discussed about the TRMP defect also, if you have such early onset of hypoglycemia, you can't just say that it is normal malnutrition. Similarly, if such a young child is having hypoparathyroidism, too early, syndromic, severe, and family history. These are the 4 indications for genetic testing. So this is clearly a right candidate for genetic testing. And if you can't do it, at least rule out DiGeorge syndrome. That becomes very, very important from that perspective. Thank you, Dr. B.
So the next case, a 10-year-old boy with seizures. The ionic calcium is 3.1, and this is the image that we have. So Dr. Anamika, what do we gather from this image?
Thank you for presenting an interesting case. So this 10-year-old boy presented with seizure, having low ionic calcium, and CT scan showing multiple bilateral intracranial calcification. So I would like to do clinical assessment as well as biochemical assessment of this patient. So on clinical assessment, it was found that a patient had cataract and brachymetacarpia, that is short for metacarpal, and cutaneous calcification also. And on biochemical assessment, it was found that his phosphorus level is 8.4, that is high. So next step is creatinine. It's 0.4, that is quite normal. So next step is parathyroid hormone level, and it's 200 picogram per ml. That's very high. So diagnosis is pseudo hypoparathyroidism. Here I would like to add something, that as the patient has features of renal resistance, that is hypocalcemia as well as hyperphosphatemia, and also have skeletal features, that is patient has short fourth metacarpal. So we can say that this patient is diagnosed with pseudo hypoparathyroidism type 1A. So key messages are intracranial calcification suggests parathyroid defects. So not only stick to neurological cause, so we should think of hormonal cause also, and also assess for brachymetacarpia to exclude pseudo hypoparathyroidism.
Now, pseudo hypoparathyroidism is a rare condition, but what you need to remember is that it is a later onset. The calcium deficiency usually does not happen before 1 year of age. Very, very unusual. If they present to you before 1 year, they will present to you with obesity, with calcification and all, but hypocalcemia typically happens after 5 years of age. If you say typically, and this is a classical presentation. Somebody who had seizures for a long time, nobody thought, then they got a CT scan, they found calcification, and then our astute neurologist will do a calcium and send it to us. So be proactive. Always look for CT if there is calcification, or anyway, any child with seizures, do a calcium level. What's the harm? If you can identify, you can treat it. We have got so many patients who presented so late to us. With that, we discussed that in a big grand round, I think also in that regards. Yeah.
So a 4-week-old boy presented with seizures and ionic calcium was 1.9. The phosphate was 7.1. Creatinine was normal. Dr. Chisholm, what is the next step that we do now?
Dr. Chisholm, are you there?
Please, can you hear me now?
Yes, yes.
Yeah.
Okay, sorry, please, about that. So this is a 4-week-old boy with seizures, ionic calcium of 1.9. So there's obvious hypocalcemia, and there's hyperphosphatemia as high as 7.1 milligram per DL. Creatinine level happens to be normal, so obviously this is not a chronic kidney disease issue. So the next thing is to look at the PTH. And the PTH level here was found to be exceedingly high, above 70 picogram per ml, 240. So there's a situation of, can this be pseudo hypoparathyroidism? Now, if you go to the assessment, it's very simple. First of all, check for the phosphorus level. We've checked for the creatinine, it's normal, so it can be CKD. Now we're at the level of PTH. Again, impaired PTH effect. Like I mentioned earlier, before making a diagnosis of impaired PTH effect, which can either be hypoparathyroidism or pseudo hypoparathyroidism, which is what we're considering in this case, it's very important to make sure that the vitamin D level is normal, magnesium is normal. So in this case, the vitamin D level wasn't normal, very low, in fact, less than 3. And obviously, this is a case of vitamin D deficiency that has led to a secondary PTH resistance effect. So in this situation, I would like to obviously give this child vitamin D, perhaps look at the feeding, definitely improve on the feeding supplements, the feeding with vitamin D, because to correct for the vitamin D deficiency. So the take-home message here is that before making a diagnosis of pseudo hypoparathyroidism, it's very important to make sure that you're not dealing with a long-standing chronic vitamin D deficiency. So that's very essential. Thank you very much.
So I think that's very, very important message. And this is what I was saying. If you have somebody in the first year of life, you're labeling as PHP, think 100 times. Because PHP did not cause hypocalcemia. Why does it happen? Why is HP hypoparathyroidism more severe than pseudo hypoparathyroidism?
Only the renal part is affected and the other part not affected.
Yes. And there are multiple effects of PTH. PTH not only acts through the GNAS1 or the GS alpha pathway, it also has the beta arrestin pathway. It also has got the GQ pathway. Now, if you talk about PHP, it's only one part of PTH goes. So your kidney, and other thing is it's imprinting the further. So your skeleton may still be giving calcium. So pseudo-hypoparathyroidism is a milder disease compared to hypoparathyroidism. So if you have diagnosed it in the first year, think 100 times before you diagnose PHP.
The next case, a 5-year-old child presented with tetany and the total calcium was 5.6. The phosphate was 13.4. Creatinine was normal. Dr. Lalit, how do we proceed from here?
Yeah, thanks, Pradeep. We have a 5-year-old child. He has a hypocalcemic tetany and has a phosphate level which is definitely very high. So, what are the other hormonal levels in this child? What is the PTH, vitamin D? PTH comes out to be 4.4, which is very significantly low, which is unlikely to be there. Either it is due to PTH actually, hypoparathyroidism per se, and we consider it as hypoparathyroidism, and we start calcium on this child.
Yes, this on clinical examination, child had these nail fittings. Can be seen over here.
Okay,
yes.
okay. These are unlikely of plain hypoparathyroidism actually. Anything else that the child has? Any oral lesions?
Yes. So child also complained there were slight oral lesions. They were white in color.
Okay, so where do we go? Where do we go from this? We have a phosphate, I, and a normal PTH, and we have given actually vitamin D. The calcium, calcium. What happened then?
Yes. This child was considered as a hypoparathyroidism, but then started on calcium and calcitriol. But then what was seen is that this child developed hypercalcemia on the same dose and actually reducing dose of calcium.
So what is his? What are now his electrolytes and cortisol level?
Yes, so he developed vomiting and shock around 2 months after he developed this high calcium, and this was his report.
So the cortisol is low now.
Yes.
So he has multiple endocrine disorders now. There are 2 hormones involved. So there is, or we should look for autoimmune disorders. Any fungal lesion in the mouth. He has nail lesions also. So he most likely has polyendocrineopathy, that is autoimmune.
Yes.
So the key messages are we have to consider autoimmune polyendocrineopathy in hypoparathyroidism, and if hypercalcemia goes with cortisol deficiency. So these were 2 paradoxes. So we check for the sodium and potassium and cortisol. So this is actually, sir, please elaborate, sir. Yeah,
I think this is a very, very important message which Dr. Lalit is giving. And it is important not only to be that, okay, this is hypoparathyroidism, end of the story. No, what is the cause of hypoparathyroidism? So in infancy, Dr. Pradeep talked about how we should not miss DiGeorge syndrome because the child will die if there is a cardiac issue. Here, you should not miss APS. Every acquired hypoparathyroidism in a child should be considered as APS unless proven otherwise. Now, you can do an interferon antibody to get a diagnosis. That is there, but if you cannot monitor their calcium very closely. Cortisol basically causes a excretion of calcium. If there is a cortisol deficiency, calcium excretion comes down. So your calcium levels build up. So if you have unexplained hypercalcemia in a child who has been labeled and treated as hypoparathyroidism, always consider cortisol deficiency as a major thing. And that's exactly what Dr. Lalit did. And this is very important because otherwise the child will die if you miss it. So unexplained hypercalcemia, lower calcium requirement, think of a cortisol deficiency in the setting. Thank you, Dr. Lalit and Dr. Pratik. So we have discussed about hypocalcemia. We'll now discuss a bit about rickets, which is an important part to discuss in that perspective. We all know a lot about rickets, so I won't go too much into detail. Very importantly, which investigations to do and how do we classify from there. So these are the most common causes. Of course, the most common elephant in the house is vitamin D deficiency. VDDR will present with early onset hypocalcemic rickets. So if you have hypocalcemic rickets with alopecia, milia, think of vitamin D dependent rickets. If you have late onset lower limb involvement with no hypocalcemia, no hyperparathyroidism, that is hypophosphatemic rickets. If you have polyuria, acidotic breathing, failure to thrive, nephrocalcinosis, think of a RTA. And of course, renal failure will be the very sick. Very rarely, pseudo-hypoparathyroidism can also cause a biochemical picture and a radiological picture suggestive of rickets, but that's rare. Most important thing, again, the most important investigation in calcium assessment is phosphorus. If your phosphorus is high, there are only two possibilities, or I would say most likely it is renal failure. So look for phosphorus very importantly. Then look at calcium. If you have normal calcium, normal PTH, that is hypophosphatemic rickets. So very importantly, low phosphorus, normal calcium, normal PTH. Now, why is the phosphorus low in other children? That is because of high PTH. But here, because you are losing this phosphorus, your PTH is not going to be high in that perspective. If there is hypercalciuria, that suggests renal tubular acidosis and of course acidosis. So the most important investigation is phosphorus. Creatinine, of course, you can't miss. You look at blood gas and a urinary calcium, your diagnosis is done in most cases. So the most important thing is, very importantly, number one, of course, is that if there are no features of refractory rickets, the child is not very short, the child doesn't have polyuria, child doesn't have fractures, give them a trial of calcium and vitamin D. Do not give vitamin D alone, because if you give vitamin D alone, you will have hungry bone syndrome. Your bones are forming, calcium will come in and you will have tetany. Other thing is that in India and a lot of parts of Africa, it's calcium deficiency, which is also a leading cause of rickets. So you need to give calcium as well in that setting. The next step is to look at phosphorus, high phosphorus, renal failure. That's a very simple pathway. If the phosphorus is low, rule out RTA, doing a blood gas. Once you have done that, look at PTH. If the PTH is high, calcium is low, that's vitamin D dependent rickets. If your PTH is low, calcium is normal, that is hypophosphatemic rickets. So I'll say just look at phosphorus, blood gas, creatinine and PTH. These four will give you 99.9% diagnosis as far as refractory rickets is concerned. So we'll start off again, Dr. Prateek, with the rickets cases quickly.
A 3-year-old boy with rickets presented, and this child was given 3 doses of vitamin D. So then this child complained of bone pains. The ALP was still raised at 1100. Calcium was 9.4 and was labeled as refractory rickets. Dr. Pradeep, how do we proceed from here? Dr. Pradeep?
Dr. Pradeep, are you there?
Sorry. So thank you, Pratik. This child presented with rickets and he is rightly given vitamin D weekly. And next, he presents with bone pain and alkaline phosphatase raised. Calcium is normal. And no, we will not diagnose this case as refractory. We'll just go through and see X-ray, how the X-ray is. So if a child is having, yes, so line of healing is there. So at initial phases, after 2 or 3 doses, at the end of 1 month, many child present with bone pain and alkaline phosphatase will be high because bone formation is happening there. So this phase, in this child, everything is going fine. We should give vitamin D and calcium as per protocol, and this child should definitely respond. Yes, this child is having normal response.
Any comment?
No, I don't think no. There's no need for any orthopedic correction. This child will respond definitely.
So the
Yes,
key
definitely.
message,
Yes. So key messages are bone pain and increase in alkaline phosphatase. Whenever you start treatment indicates these are normal findings, and after end of the 3rd week or rather 4th week, you can get X-ray done, and if line of healing is there, so that means the child is responding. Thank you, Pratik.
so the next case is a 4-year-old girl with rickets was treated with calcium supplementation, but there was no improvement. After 30 days also, there was no line of healing on the X-ray, and this was labeled as refractory rickets. Dr. Anamika, is this really refractory rickets?
Well, actually, before diagnosing the case as a refractory rickets, we should ensure that patient is getting adequate dose and duration of treatment. In that case, we find that patient is getting calcium phosphate only 5 ml, 12 only. So, which indicates she is getting approximately 500 milligram calcium and 500 unit of vitamin D. So, according to IFP guideline, during treatment of rickets, we can choose different modalities like daily therapy or weekly therapy or single high dose. As the patient was given daily therapy, in that case, recommendation is at this age, she should get 3,000 to 6,000 international unit per day. In that place, she is getting only 500 unit per day. Obviously, she is getting very, very low dose of vitamin D to get response of treatment. And patient is also getting 500 milligram calcium, although recommendation is 600 to 800 milligram per day, which is nearly close to recommendation. So here key message is,
Dr. Anamika, any comment on the STOS regimen, the parental vitamin D regimen?
oh, yes, if we choose weekly therapy, in that case, dose will be 60,000 international unit weekly for 6 weeks. Or if we select STOS therapy, in that case, at this age, we can choose 150,000 or 3 lakh unit per day. 3 lakh unit. And obviously, oral route are preferred because of increased storage of vitamin D. So key message is refractory rickets is only diagnosed after completion of treatment. That is, patient is getting treatment in adequate dose and duration. In that case, daily therapy is indicated for 3 months. So if there is lack of line of calcification after getting treatment of 3 months, in that case, we can diagnose as a case of refractory rickets.
Thank you, Dr. Anamika.
Thank you.
So, coming to the next case is a 4-year-old girl with rickets, and she had got vitamin D2 courses, no improvement. This child complained of abdominal pain, and on examination, it was seen that she had anemia. Dr. Chisholm, what are we missing here?
And treatment with oral vitamin D has already been constituted and had as distinct 2 causes.
Sorry to interrupt, Dr. Chisholm, your voice coming back.
Can you hear me?
No, it's still cracked.
Can you hear me? That's okay.
There is an echo, but go on.
Okay, so the 4-year-old girl with rickets is receiving oral vitamin D for 2 causes now, with no improvement, and by no improvement, there's no line of healing. Probably the ALP is not increased, as alkaline phosphatase is not increased, the child is not experiencing both pain, these are signs of healing. So if they are absent and the child is not improving, and there's also concomitant history of abdominal pain and anemia, it's very important to consider the possibility of a malabsorption syndrome. In this case, it's suspecting celiac disease. So to convince the gut, which is where the malabsorption is taking place, it's important to switch from oral vitamin D to parenteral vitamin D. And when we did that in this child, this is that the child is improving on the line of physiological healing. So the key important message here is that for any cases of malabsorption, not just celiac disease, biliary atresia, cystic fibrosis, and the last liver disease, any case of malabsorption, and in the case of rickets and there's no healing, always consider parenteral form of vitamin D. And I forgot to mention that in that case, it was confirmed that the child had celiac disease because the physical level was found to be a 100, which is strongly positive for celiac. So the child was advised to take care of and including concerning food, and we can the child improve, as obviously seen in the case. Thank you.
Thank you, Dr. Chisholm. So I think the big message here is that do not give injectable vitamin D to everybody. Only if you're suspecting malabsorption, only if there is no response, and definitely if you're thinking of that, rule out causes of malabsorption. And I would say celiac disease in somebody with anemia and rickets. You think of celiac disease, you think of renal insufficiency. These are the 2 things that are most important to exclude in that setting. Please carry on, Dr. Pratik.
So the next case is a 5-year-old girl with rickets, and she was noted to have polyuria. The weight is 10 kgs, height is 88 centimeters. Now the VBG was done, which showed a pH of 7.1, base excess -12, and urinary pH of 6.8. So everything points toward distal RTA. But is there anything that we are missing here, Dr. Lalit?
Dr. Lalit?
Dr. Lalit, are you there?
So I think if you look at this picture, and we've discussed that RTA is an important cause of severe failure to thrive. This child fits into that picture, very short, not growing at all. There is metabolic acidosis. So what do you think? We should have done anything else? We looked at the tubular part of the kidneys. Have we missed on some other part of the kidneys?
So if we know there's a kid, first of all, we need to see the phosphorus, it is high or not.
Yeah.
So phosphorus done here was 9.
So
first
do you think this could this be proximal RTA?
So most of the RTAs we know has hypophosphatemia.
And proximal RTA will have losing phosphorus. So they cannot have 9.
Yes.
Like I will never be able to build up even 3 or 4 phosphorus if I am giving tons of phosphorus. So this is not RTA. So this is something else. What is causing acidosis with rickets?
The first thing which we should consider a short child, rickets, hyperphosphatemia is CKD. So we have to look into the creatinine first thing that we do before doing anything else. So the creatinine was done, it came high. Yes, so the key message is here at the high phosphorus and rickets, yes, evaluate, but first thing, consider basic things like CKD and look at the creatinine first.
So again, a big message that go for common things. Don't go for unusual things. Rare diagnoses are rarely correct, while common things are very, very important. So if you have, don't go for acidosis, look for phosphorus first. You would have got phosphorus, you would have got that. So this is an actual case, and it was really a sort of a strange for us that why has this been done, but then it happens in clinical practice. So if you looked at stepwise the approach, it would have been much easier. Same with this case. This case actually was diagnosed as osteogenesis imperfecta and referred to us, and this is from AIMS. So must be 15 years ago. You go ahead, Dr. Pratik.
So this is a child referred to us with failure to thrive, polyuria, myopathy. And Dr. Pradeep, how do we proceed now if the child has come to the OPD?
Okay, so as Anurag sir has discussed, what is the creatinine? I would like to know the creatinine. Although this child is having all the typical features of polyuria, then fractures, and creatinine is rather normal here, 0.6, and phosphate is lower side, and pH here what we are seeing is acidosis. So a child who is having acidosis, we should always, and typical presentation of fractures, ideally nutritional rickets should not present with fractures. So any child who is presenting with like rickets like feature and is having fracture, we should always think about pathological causes. And here all the shots, the failure to grow, then acidosis, these all are present. So I will definitely go with RTA. And I would like to know what is the urinary pH in this case.
Yes. The urinary pH was 7.4.
Okay. So urinary pH is here, what we see here, it's more than 5.3. So definitely this looks to me like distal RTA. Okay, so as I said, any child who is presenting like rickets and is having fractures and is not growing at all or is having failure to thrive, we should always think about RTA. And distal or proximal, we can rule out with all other features like nephrocalcinosis, presence of phosphaturia, aminoaciduria, etc. Then seeing the urinary pH. If it is more than 5.5, you will say it is distal RTA, or if it is less than 5.5, I would say it's a proximal RTA. Thank you, Doctor.
So the next case is a 14-year-old boy, diagnosed as rickets, no improvement. He has short stature, he has bowing of legs, and even the X-ray is showing persistent features of rickets. Dr. Anamika, what is happening here?
Well, if we consider these two pictures, there are two important things to be noted. One was the age of the child, who is older boy, having involvement, lower limb involvement is more than upper limb. So if we consider these two pictures, we have to think of rickets except nutritional rickets actually. So in that case, there may be most likely there may be hypophosphatemic rickets. So for that diagnosis, I should approach this patient like this way. So again, serum phosphorus level, that is 1.8. That's low, and base X is low. So next step is blood gas, and its -4 is almost normal. So now next step is calcium and parathyroid hormone level, which are both are normal. So diagnosis is hypophosphatemic rickets. So key messages are, if we find a case with older child with late onset lower limb involvement than upper limb, so we must consider hypophosphatemic rickets.
Thank you.
What will be the treatment, Dr. Pratik, for this case?
So
Any specific treatment?
So right now in India, we can give phosphorus replacement, but I would like to give a try. If it is X-linked, then glucosamab could be tried.
And how does it work?
So it is anti-FGFR23. We can try that.
So I think this is a very interesting case. Late onset rickets with definite issues. We have to consider the possibility of hypophosphatemic rickets in that perspective. So we'll now move forward to the last part of this session on hypercalcemia. And hypercalcemia is basically a common presentation which we see in that perspective from the endocrine perspective. And hypercalcemia is something which is very common, but when it should be suspected. The problem with hypercalcemia is often that the suspicion is not very good, and that causes a lot of problems in that regard. So we need to basically look at the possibility of what the possible causes of hypercalcemia and when to suspect. Anybody, any newborn who comes to you with dehydration, polyuria, and hypotonia, always think the possibility of a hypercalcemia in the setting, because high calcium causes osmotic diuresis. So polyuria, dehydration, think of a hypercalcemia. In older children, if there is severe moan, groan, and abdominal pain. So abdominal pain, hypertension, calcification, and of course, if you have renal calculi, think of hypercalcemia as a possibility. And you can also have a secondary bone disease which may happen in that setting. Now, hypercalcemia, again, if you look at the most common causes and how do we evaluate, the calcium sensing receptor defect is a strange situation in which you have hypercalcemia with hypocalciuria. So if your calcium is high, you should leak in urine. If you are not, this is calcium sensing receptor defect. Hyperparathyroidism, high PTH, and low phosphorus. Of course, Jansen's is a very rare disorder in which again behaves like hyperparathyroidism. Hypophosphatemia, interesting, you have got no alkaline phosphatase. You've got no alkaline phosphatase, your bone will not mineralize. So all your minerals are roaming around here and there, they are not being used. You have high calcium, high phosphorus. Granulomatous disease, you will have increased production of calcitriols. You have high calcium, high phosphorus, and vitamin D excess, again the same thing, high calcium, high phosphorus. So the most important investigation again is phosphorus. High calcium, low phosphorus, PTH related, high calcium, high phosphorus, vitamin D related. Or you can think of immobilization, you can think of hypophosphatasia, or rarely if you have an infiltrative malignancy which is taking your calcium and phosphorus out from the bone. The second is of course PTH, and any PTH which is more than 20 in somebody with hypercalcemia is significant. Urinary calcium is low only in one condition. So high serum calcium, low urinary calcium is a calcium sensing receptor defect. Body is sensing, I've got deficiency of calcium, PTH is working hard, and kidneys are also working hard to preserve. So that's the combination. And vitamin D, of course, will have a help in some cases, and calcitriol rarely. But I would say again, look at phosphorus in PTH and urine calcium. Your diagnosis is done in that perspective. Now, very importantly, as discussed, anybody who has a calcium which is high, the PTH should be low. If your PTH is more than 20, consider that to be a hyperparathyroidism. This is a big message. So normal PTH with hypercalcemia is high. This is what you should understand. Now, how do you approach? Look at PTH. If PTH is below 20, you're dealing with a vitamin D related cause. If vitamin D is high, it is exogenous vitamin D. If it's normal, do calcitriol. If calcitriol is high, this is granulomatous, like the sarcoidosis case, which we discussed recently. And if it is normal, rare causes, hypophosphatasia, immobilization, ALL, leukemia, all those things will come up. Myeloma in adults will come up there. Now, if the PTH is above 20, it means you have hyperparathyroidism. Look at urinary calcium. If urinary calcium is high, this is primary hyperparathyroidism. And if it is less, this is calcium sensing receptor defect. So again, looking at PTH, vitamin D, and urine calcium, three things, diagnosis is done immediately. There's much more complications in the algorithm. We didn't put it specifically because we wanted to be very simple at that point. So Dr. Prateek, you can please start off with the first case of hypercalcemia.
So case 15, a 12-year-old girl, there is noted to be irritability, there is dehydration. So after looking at this clinical picture, a calcium was done, which was very high at 18. So Dr. Chisholm, how do we proceed from here?
Dr. Chisholm, are you there? So this is a classical presentation of Prateek. You talked about hypercalcemia with dehydration. Dr. Chisholm, I think she's
Yes,
back.
yes.
Please go ahead, Dr. Chisholm.
Hello.
Yeah, please go ahead.
Yes, please go ahead.
Can you hear me?
Yes, we
Yes,
can
yes.
hear you. Please go ahead.
Okay, sorry about that, places network. So this is a 12-day-old girl with irritability and dehydration secondary to hypercalcemia by an obvious raised value of 18 milligram per DL. So the question now is, what's responsible for this hypercalcemia? So in the assessment, the first thing to check for is the PTH level. So we checked for the PTH level and it was found to be high. Now, after finding a high value of 120 picogram per mil, the next thing is to evaluate for the urinary calcium to determine whether we are dealing with a primary hyperthyroidism or if we're dealing with a calcium sensory defect. In this case, the urine calcium to creatinine ratio was found to be very low at 0.3 milligram per milligram, indicating the possibility of an inactivating mutation of a calcium sensory defect. In other words, in the midst of plenty, the body doesn't seem to realize that the calcium is enough. So it leads to increased PTH level, which in turn tries to conserve or reabsorb calcium from the gut indirectly through calcitriol and other means. So because this is a genetic cause, we're considering neonatal severe hyperparathyroidism, which is a homozygous variant of the inactivating mutation of the calcium sensory receptor. So in other words, the most important thing to consider here is that for a child, a neonate in particular with polyuria, dehydration, irritability, it's very important to consider hypercalcemia. It's very important to consider a genetic cause to it. There are several causes, very few, chief of which remains causes that can lead to increased PTH level, like hyperparathyroidism, or in this case, neonatal severe hyperparathyroidism. Thank you.
Thank you, Dr. Chisholm. So the next case is a 2-year-old girl with abdominal pain. On the ultrasound, there was nephrocalcinosis. So a calcium was done accordingly, and it came 13.6. The phosphate was 6.2. So Dr. Lalit, what is happening here?
I don't know why the network is so bad here.
Dr. Lalit, are you there?
Okay, Dr. Lalit, I think is not there. So this case basically, Dr. Lalit is there. I think he is in the attendee now. Okay. So I'm converting into a panelist now. So this child again is a very, very important presentation in which you have a child who has got nephrocalcinosis, who has got hypercalcemia and high phosphorus. Now, what does it mean, Dr. Prateek? Could this be hyperparathyroidism according to you?
No, as you had mentioned just now, phosphate needs to be low to be mentioned as a hyperparathyroidism. Here, phosphate is high, calcium is high, so it's probably because of vitamin D related causes.
So, Dr. Lalit, have you joined?
Yes, sir. Yeah. A 2-year-old girl, abdominal pain, ultrasound, nephrocalcinosis, there is excess calcium everywhere with the phosphate, which is definitely okay, not really low. So what is the cause? PTH we've done. What is the PTH level, sir? What is the PTH level? PTH is extremely low. The PTH has reacted to this high level of calcium. So PTH is working fine. There's some other cause. We do a vitamin D, we do a 25-hydroxy. This was high. This was way high. This is overzealous treatment of rickets. So child has vitamin D toxicity. So this happens. So the key message is high phosphate and calcium is vitamin D excess, and the child needs treatment with diuretics and IV fluids and steroid. That's all. Thank you.
Thank you, Dr. Lalit. The next case is a 15-year-old girl who's a preterm delivery. The calcium was 40. The phosphorus was low at 2.8. PTH was low, less than 1. Dr. Pradeep, what is the cause of this hypercalcemia?
Okay, so this is a preterm child, 28 weeks, and calcium is slightly high. I think it's more than 11, so we would call it higher side. But phosphate is low. Phosphate is low, and PTH, as we had discussion, that any child who is having hypercalcemia, if phosphate is PTH is not more than 20, so we would rather rule out hyperparathyroidism. So in this case, okay, so I think 28 weeks, this child must be having on total parental nutrition. So okay, so yes, so here vitamin D is also towards lower side, and calcitriol is 125, which is I think in midway. So maybe this child may be on TPN, which may be lacking phosphorus, which would have stimulated 1 alpha, and that is why this child is having slightly hypercalcemia. That I would say. Definitely, the message is this case is not that of hyperparathyroidism because PTH is lower side, and maybe hypophosphatemia is the cause of hypocalcemia here.
Thank you, Dr. Pradeep. The next case is a 2-month-old boy with fractures. The calcium was 14, the phosphorus was 6.8, and PTH was less than 1. So, Dr. Anamika, what is happening here?
Was a 2-month-old boy having fracture, and he had high calcium and phosphate level. Actually, it's normal, 6.8, and low parathyroid. So I would like to assess him in a systematic way. Next slide. So if a patient has had hypercalcemia, so now I would like to, and parathyroid level is low. So next step is 25 hydroxy-D. And
The 25 was 20 and calcitriol came 20.
Parathyroid level is low. So next step is 25D. And it's found that 25 is normal. So next is calcitriol, and it's also low. So it could be hypophosphatasia. So for that diagnosis, I need alkaline phosphatase level, and it's 24. It's very, very low. So finally, diagnosis is hypophosphatasia. So if when we get a patient, infantile patient with bony deformity fractures, if a patient had high calcium and phosphate, so think of low bone turnover disease. And if a patient had low alkaline phosphatase and high calcium, diagnosis is hypophosphatasia, because it's a disorder of where decreased production of hydroxyapatite crystal due to deficiency of alkaline phosphatase. So calcium and phosphate level is high here in this case.
Thank you, Dr. Anamika. Yeah, thank you. So the next case is a 4-day-old boy with seizures. The birth weight was 3.2 kg, and on history, the child had a low Apgar score. Calcium came 18, and phosphorus was 4.2. PTH was suppressed at less than 1. Dr. Chisholm, what is the cause of this hypercalcemia?
Okay, so this is a 4-day-old boy with seizures. 4-day-old meaning very early in life. Birth weight is 3.2 kg, which is normal. This is not a case of low birth weight. And the child had asphyxia. There's hypercalcemia, which will explain the seizures. And the phosphorus level is low, which is indicative of a PTH-independent cause, most likely vitamin D-dependent etiology. And this was confirmed by the PTH being less than 1 picogram per mil. So in assessing this condition, the PTH level was found to be low. So we're dealing with a vitamin D-dependent cause. The 25 hydroxy vitamin D was assessed and also found to be normal at 30 nanogram per mil. So the next thing is to check for the calcitriol, and that was checked and it was found to be exceedingly high at 250 nanogram per mil. So what might be responsible for this? Obviously, granulomatous diseases. Now, in this scenario where there's beta asphyxia, the granulomatous disease in question should be fat necrosis, because I don't want to go into how beta asphyxia can cause fat necrosis, but it's very possible violaceous nodule that leads to inflammation and necrosis of fat that can lead even to the production of calcium at the level of the skin. But what essentially happens here is that there's activation of 1-alpha hydroxylase, which is independent of PTH levels. So there's no control when it comes to PTH. So it leads to hypercalcemia because at the level of the proximal convoluted tubule, it leads to the increased production of calcitriol, which will lead to increased reabsorption of calcium, and that would cause hypercalcemia. So the take-home message here is that for any neonates with seizures, beta asphyxia, always look out for fat necrosis, because fat necrosis can lead to hypercalcemia because of activation of 1-alpha hydroxylase and even the release of calcium that has been formed within the fat. So that's the very important thing to look out for. Thank you very much.
Thank you, Dr.
And maybe one thing I need to add here, please, is that treatment entails giving prednisolone, because prednisolone will inhibit the action of 1-alpha hydroxylase, and so that's how the treatment goes. Thank you very much.
Thank you. Now we have a 3-year-old boy with bone pain. Calcium was 14.4 and phosphate was 4.4. pH was suppressed at less than 1. Anti-hydroxyvitamin D came 15 and calcitriol was 10. Dr. Anamika, how do we proceed from here?
This 3-year-old boy having bone pain and also calcium level is high, hypercalcemia, and phosphate level is low normal, parathyroid is low, vitamin D and calcitriol both are low. So now I would like to do in systematic approach. Actually, I would like to think parathyroid hormone resistant cases here. So as the parathyroid level was low and both vitamin D and calcitriol both were low, so diagnosis hypophosphatasia maybe, but there are other possibilities like bony osteolytic lesion or vitamin A intoxication or thyrotoxicosis. So as the patient have a X-ray showing lytic lesion, so and alkaline phosphatase level is 650, so this excludes hypophosphatasia, and X-ray showing lytic lesion. So here is the diagnosis is osteolytic lesion, and there may be leukemia or any other disease. So if and bone marrow aspiration showing is a diagnosis of acute lymphoblastic leukemia. So key messages are consider bone pathology with low parathyroid and vitamin D level.
Thank you, Dr. Anamika, for this wonderful discussion. And I think with this, we come to the end of our session on calcium. It was a very extensive session with 20 cases, and we were able to do it in less than an hour. So I'd like to thank all of you, Dr. Pradeep, Dr. Jizam, Dr. Anamika, Dr. Lalit, and Dr. Prateek for this wonderful session on discussion. We'll see if there are any questions there. We can just take it very quickly. I think, does high phosphorus independently trigger pathology irrespective of calcium levels? So if your phosphorus levels are very, very high, you will actually trap calcium, and that can actually cause problems there. And then you can have an ionic hypocalcemia, which may happen in that perspective. So this is something which is important to be there in that perspective. So I think what we'll do now is that we will move forward with the next session, which is on the electrolyte disorders. And this again is going to be very, very interesting session, which is there. And this is going to cover a wide variety of disorders, which we see in the emergency setting. So it is indeed a pleasure to invite the faculty for this session. And it's been quite interactive discussion in calcium. So we'll move forward with regards to this part now. And I'll just launch these slides. And this is going to be very interactive and very lot of issues to be discussed here. So for this session, we have got wonderful faculty. We've got Dr. Sumana, who is very closely associated with us for the last 1.5 years. And she is in the Vivekananda Institute of Medical Sciences, Kolkata, with special interest in pediatric endocrinology. Dr. Sri Durga, a brilliant intensivist working out of Madurai, who has an active interest in the field of electrolytes, and they do conduct annual sessions on blood gas and electrolytes, as I'm aware of. Dr. Chetan Dave, our first fellow, along with Dr. Neha, who is now working and has set up a wonderful clinic at Rajkot Center of Pediatric Endocrinology and Diabetes, and Dr. Pratik Sen, who has just ran away from here to join the second part now as a panelist. So this is like a bit of a sprint race which is going on from there. Sayan will be joining me as a moderator. Just before that, we'll have a very quick discussion about pathophysiology, because this is the crux. And if you understand endocrine physiology, 90% of your work is done. Now, when you talk about sodium levels, you're talking about sodium levels depend upon two things. One is how much is your sodium, and second is how much is your water. Now, the most important determinant of your sodium level is actually the free water and not sodium. And this is something which is important to understand. Major causes of hyponatremia are because of too much free water. Most causes of hypernatremia are because of too little free water. So it's free water which is more important than actually the sodium content. You can have really salt wasting, which will cause hyponatremia, but again, you need to have a high AVP to persist and sustain that. Any person who has persistent hyponatremia will have to have a high level of ANP, and that's why whether it is appropriate or inappropriate, AVP high is absolutely essential for hyponatremia. Now, there are various mechanisms which control your free water, thirst, and of course urine output, how much you drink and how much you take out of it. There is also an important intake and excretion. This is what essentially is. Now, from that perspective, in conditions where tone increases, as soon as, and the most important regulated parameter in the body is actually osmolality, tonicity, or serum sodium. As soon as your osmolality goes above 280, the body really senses it. Really gets, because it doesn't want to get dehydrated and shrunk. So what it does immediately is that you will have activation of the thirst system, and you will also have activation of the AVP system. And what AVP will do, it will immediately go to the kidney, decrease the free water excretion, and therefore your free water levels will go up. And this is the mechanism which works. So there's a very tight control in that setting. Now, there are two major problems which may happen. One we discussed about osmolality. The second is volume. Now, whenever the volume goes down, the renin, angiotensin, aldosterone system gets activated. And this RAS system basically barters sodium for potassium. The body assumes that this sodium is much more important for me than potassium. Even if I lose potassium, my sodium should go up. So if you have any condition in which you have hyponatremia or hypovolemia predominantly, the RAS system will get activated and you will have hypokalemia. Now, as I said, persistent hyponatremia will only happen if your AVP is high. Persistent hypokalemia will happen only if your RAS axis is high. This may be appropriate or inappropriate. That's a different thing altogether. So if you look in a nutshell, conditions associated with renin, angiotensin, aldosterone system deficiency will have hyponatremia with hyperkalemia. Excess will have hypernatremia with hypokalemia. Now, hypernatremia does not happen because as soon as the sodium levels go above a particular level, suddenly you've got the third player which comes into the picture, which is the natriuretic peptide. So RAS excess states do not present with edema. They do not present with hypernatremia. They present with hypokalemic alkalosis. So hyponatremia, hyperkalemia, metabolic acidosis is RAS deficiency. Hypokalemia with alkalosis is RAS excess in that perspective. And this is something which you need to really understand. Now, this potassium, of course, is largely intracellular. And this sodium potassium ATPase activity is activated by insulin. So conditions in which you have insulin excess, like treatment of DKA, like recovery phase from malnutrition, particularly in anorexia nervosa or PEM, suddenly your potassium will be pushed in and you will develop hypokalemia, which becomes important. And if you're using beta agonist, again, the same thing happens. Now, serum sodium can be done any time of the day. It doesn't have a diurnal variation. Very importantly, if you're having a lot of exercise or seizures, the levels may be falsely high. So don't do it immediately from the arm which is scissoring. Otherwise, your sodium will be very high. Falsely low value will happen if there is a problem of hyperglycemia, hyperlipidemia, or protein. Hyperproteinemia and hyperlipidemia cause pseudo hyponatremia. while hyperglycemia is actually not pseudo, it's a true, because you have got osmotic drag of water, but you need to correct. For every 100 milligram per DL rise in terms of glucose levels, you have to correct the sodium level from 1.6 to 2, depending upon certain situations that we decide. If, on the other hand, if you have hypoalbuminemia, your sodium level will actually be falsely high. Normal range, we all aware, 135 to 145. Worry if it's less than 130 or more than 150 in that perspective. What about potassium? It should be, again, not affected by the time of the day, but never squeeze or use a tourniquet, because it is an intracellular potassium, magnesium, and phosphorus. 3 major intracellular ions. If you squeeze it, their levels will be very, very high in that setting. False values will be high in hemolysis and low if you are stored with a high count like thrombocytosis, leukocytosis, polycythemia. Your levels will be low because these cells will eat up that potassium and will go into the cell. If you're using the blood gas, it tends to have underestimation of potassium by 0.4. So this is what is very important to look in that perspective. Now, this is the most important slide. You should keep it in your imprinted into your mind, and it will become much easier. Normally, as we talked about calcium and phosphorus, they go hand in hand. Sodium and potassium go opposite. So usual conditions, if your sodium level is high, potassium should be low. And that basically means you're dealing with a RAS excess. Hypernatremia will not be significant. It will be like marginal or in the high normal range. If you have hyponatremia with hyperkalemia, this is life-threatening. This is what we call about RAS deficiency. Your adrenal insufficiency, cortisol deficiency, you have got pseudohypoaldosteronism, all will present like this. But what about unusual situations? If you have hypernatremia and hyperkalemia, there is only one diagnosis. That is Gordon syndrome, which is again a problem of the sodium chloride symporter. On the other hand, if you have hyponatremia and hypokalemia, you are losing. You're losing both either through your tubules or through your gut. So always remember, hyponatremia with hyperkalemia is RAS deficiency. Hypernatremia with hypokalemia is RAS excess. Hypernatremia with hyperkalemia is Gordon syndrome, and hyponatremia with hypokalemia is tubulopathy. So 2 into 2 table. I think endocrinology is all about 2 into 2 tables. If you draw it, you can make the diagnosis very quickly in that regard. So before we start on hyponatremia, just a few words about how to classify. Now, fluid overload, of course, will be common. You will have hypervolemia. It will be like cardiac failure, nephrotic syndrome, CLD, and other aspects. Syndrome of inappropriate ADH secretion is again a hypervolemic state. So I am saying volume is the most important thing to look at in a person who comes to you with hyponatremia. Now, often this volume is difficult to assess, and I'll give you a very simple clue that the best marker of volume is uric acid. Uric acid is a unique compound whose excretion is dependent upon the plasma volume. High plasma volume, high excretion, low uric acid, low plasma volume, low excretion, high uric acid. So in the setting of hyponatremia, if uric acid is high, it means dehydration. If it is low, it is hypervolemia, quote unquote, SIADH, if you don't have a clinical feature. Diuretic will cause hyponatremia and hypokalemia. RAS defect will cause hyponatremia with hyperkalemia. Renal failure will cause hyponatremia and hyperkalemia. How do you differentiate renal failure from RAS defect? Creatinine, of course, but creatinine may be high if you have dehydration. So whether you are concentrated, if there is hemoconcentration, it goes in favor of adrenal pathology. If you are hemodiluted, so PCV, hematocrit, hemoglobin will give you a best picture. Or uric acid also. If you have got high PCV, that is adrenal, low PCV, that is renal. That's very, very important. And of course, diarrhea will have hyponatremia with hypokalemia with a low urinary sodium. So which is the most important investigation? Uric acid, very helpful. Low means you have got high volume. Urinary sodium, again, everybody should have a high urinary sodium except for a diarrheal or an extrarenal loss. Potassium, and I would say always, like phosphorus, the hero here is potassium. If your potassium is high, you're dealing with a RAS defect. If your potassium is low, you're dealing with tubulopathy or renal or gastrointestinal loss. If it is normal, then of course you can have a different thing. One place where everybody gets confused is a primary adrenal insufficiency versus a central adrenal insufficiency. Primary adrenal insufficiency causes hyponatremia and hyperkalemia, but if you have a central cause, you will not have hyperkalemia because the major regulator of potassium is the RAS axis, and ACTH has a minimal effect on RAS axis. So even if your potassium is normal and you have hyponatremia, please do not forget to do a cortisol level because this could be a central cause, and this is missed every day. We see so many consultations on the same line. And again, hematocrit, if it is low, it means it is essentially dilutional, while if it is high, it is more likely to be a concentration phenomena in that regards. So just to conclude on hyponatremia, look at fluid status. If fluid is too much, very easy, cardiac failure, renal failure, liver disease, you know the cause. If you are euvolemic, it is SIADH most likely. Look at urinary sodium, it will be high, urinary osmolality will be high, but, and this is a big but, exclude cortisol deficiency. Do not do that because otherwise there will be a huge problem. If somebody is hypovolemic, look at urinary sodium. If urinary sodium is low, it's extrarenal, usually diarrhea. If it's high, look at potassium. If potassium is low, it's tubulopathy. If it's high, it is a RAS defect, and do renin, angiotensin, aldosterone, all that evaluation will be done. So look at fluid, look at urinary sodium, your diagnosis is done. So what we are trying to do is that we are trying to demystify all these confusing pictures. Don't do 100 tests right away. Do it stepwise, and that's what our approach is basically in that regard. So we'll start off with the first case, Dr. Sayan, of this child with 12-year-old with DKA.
So coming to the first case in the section of electrolytes, this was a 12-year-old boy who presented to us with a diabetic ketoacidosis. Now he had an ambient blood sugar of 700 milligrams per deciliter, and we had a referral from the PICU because of a low sodium in this case. So Sumana ma'am, do you think that we should advise a sodium correction in this case?
Yes, obviously, this is a very common scenario that we face in our day-to-day practice. And as we can see, the blood sugar is really high as a child has DKA. We need to correct for the sodium level for the given sugar level. And so that the correction, there's a correction formula as shown in the slide. And as we know that for each 100 rise of blood sugar, there is a fall of sodium by 1.6. So by applying the formula, the corrected sodium will be something around, say, probably 135. Yeah, there it is, 135.6. So it is within the normal range. So the child is actually not having hyponatremia. It's very important. We must always remember to correct for the sodium level in cases where there is increased sugar level in blood or increased protein or lipid level. Yes, thank you very much. Thank you, Sran.
Thank you, Shumana ma'am. Now coming to the second case, this was a 1-week-old boy who presented to us with a low sodium level of 128. His potassium was 3.6. Now, Dr. Sridurga, how to proceed with the case? Ma'am, you are muted, ma'am. Sridurga, ma'am.
Yeah, Dr. Sridurga. Dr. Sridurga, are you there? So now this is a very interesting case that you're looking at, Sayan. We talked about hyponatremia, and this is not really hypokalemia, but not high.
Yes.
So do you think this, you have excluded a cortisol deficiency entirely in this case?
Sir, this we have to rule out, sir, in this case. First, the volume status, as you just mentioned, sir. So what was the volume status? So as the protocol goes, there was no dehydration in this case. So next, the blood sugar was low and the ketone was high. So a ketotic hypoglycemia in this case. And so as you just mentioned, we need to rule out two things.
So Dr. Sridurga, are you there? She is
yes,
showing...
sorry for the disturbance.
Yeah.
So let's proceed with the patient.
Yeah.
Am I audible?
Yes, yes, ma'am. So a 1-week boy, ma'am.
So there's a 1 week.
Yes,
yeah.
The ma'am had
1 week old boy who is patient admitted with a sodium of 128 and potassium is within normal limit, that is 3.6. So as we all know, here sodium is normal and sodium is decreased and potassium is normal. So this is something to do with your water. So sodium level is closely related with the fluid status. So whenever you see a hyponatremia, there can be increase in free water, and whenever there is a hypernatremia, there can be a decrease in free water. Okay, so moving on to the fluid status of this child. So this child doesn't have any dehydration. So the common things you need to think of in this child will be a hypothyroidism or a cortisol deficiency. So cortisol is required for the free water excretion. So
And the
what is the
child also
cortisol
had
levels?
ketotic hypoglycemia.
Okay, so along with hyponatremia, this child has a blood sugar of 24 and appropriate response in the form of 2.4 of ketone. So this
Yes.
means that there is something else in addition to your hyponatremia which is going on. So this hyponatremia could be explained by hypocortisolism. So can I have the cortisol levels?
This child also had a micropenis, ma'am, just as the picture shows.
Okay, so now we have one more problem. So there are three problems. One is hyponatremia, second is a hypoglycemia, third is a micropenis.
Yes.
So it is pointing towards multiple hormone deficiency. So probably this could be a multipituitary dysfunction. So the
Ma'am,
cortisol
as you
level is
just asked, the
125
cortisol was
and
also low.
okay. So the cortisol level is low, growth hormone level is also low.
Yes.
So this is a child with hypopituitarism with multiple hormone deficiency.
Yeah. But Sridurga, the only confusion was that the pediatrician called us and said this cortisol is 125. The normal range mentioned is 100 to 500. So this is normal. So how do you comment on that?
Okay. So this cortisol is normal when there is no stress, but this has got multiple stresses, hyponatremia, hypoglycemia. So the normal rest of RB is the cortisol should go up whenever the body has some stress. So this causes inappropriate sodium. Hypernatremia is expected to be high.
Yes, a very good important message.
So the key message in this case would be slide please.
So again, this is a very
please. So the key message is like in this case when cortisol should be in related case. So in this case for hyponatremia, a cortisol level of 125 is low. So anything less than 550 nanomole per liter is considered to be low.
Yes, ma'am.
So I think that's a very, very important message that if you have hyponatremia with hypoglycemia, midline defects, micropenis, think of MPHD and don't go by the reference range. You have endocrinology is all about interpretation, which is done in that perspective, specifically with regards to a situation when you're interpreting in terms of the context. So this context, cortisol should be sky high. A normal cortisol is low, as we discussed for PTH and all those parameters. Please go ahead.
Thank you so much, sir. And thank you, Sri Durga, ma'am. Coming on to the next case, this was a 14-year-old boy who presented to our emergency with drowsiness. He had a sodium level of 116, which was very low. Again, as per the criteria just shown, he was euvolumic, had a urine sodium of 100 and a urine osmolality of 300, was diagnosed as a case of SIADH, and fluid was restricted in this case. So, Dr. Chetan, do you agree with that management?
Though the child very well fits into the criteria of SIADH, that is euvolemic hyponatremia with urine osmolality of 300, but there is a catch, and it is also there in the criteria for the SIADH that the child should have a normal cortisol as well as the thyroid function. So in this case, I think there was no cortisol as well as thyroid profile done. So definitely we should do the thyroid profile as well as cortisol level before ruling any child as the SIADH. So in this case, the cortisol and free T4 both were low in the setting of hyponatremia. So I think first we should look into the hypothalamic pituitary axis rather than labeling them as the SIADH.
So So I think that's a very, very big message which Dr. Chetan has given, is that you should not just label anybody as SIADH, because if you restrict, we just had the same case we saw in the ICU a couple of days ago, that if you restrict, the child will have a lot of problems. So once you start cortisol, there will be improvement. So this is the key message. I think Dr. Chetan, please provide the key messages as well.
Yeah, so the key message is the SIADS, though we see very commonly in the ICU settings, but let me tell you, it is a diagnosis of exclusion, and thyroid as well as the pituitary adrenal axis should be ruled out before any child labeling as SIADH, and fluid restriction will harm rather than doing benefit if it is a cortisol or thyroid deficiency.
And I think the big message again, Dr. Chetan, is that if your potassium is normal, a lot of people say potassium is normal, this cannot be cortisol deficiency. No, this is true for RAS axis, but not true for the center. So again, don't worry if your potassium is low, still do a cortisol. That's a big message. Please carry on.
Thank you, Dr. Chetan, for telling us what to exclude before making a diagnosis of SIADH. Now coming on to the next case, this was a 3-week child who presented to us with complaints of failure to thrive. Had a very low sodium level of 110, had a birth weight of 2.5 kilograms, but gained only 100 grams for the past 3 weeks, was very dehydrated, had a hematocrit of 62, a urine sodium of 100, and a potassium in this case of 8.4. So Dr. Pratik, how to proceed with this case? Kindly enlighten us.
Okay, thank you, Dr. Shan. So let's go stepwise, because every point of this case is important. Can you go to the previous slide? Yeah. So first of all, we have a 3-week-old child and there is failure to thrive and the birth weight is normal. So it's not a preterm child whose tubules are immature. This is a term child who's 3 weeks. The next, what we see is the child is dehydrated. So this is clearly not those euvolemic or hypervolemic hyponatremias. We have clearly a hypovolemic hyponatremia. The next step, what we see is urinary sodium is 100. So with the sodium of 110, if we have a urinary sodium more than 25 or 30, it clearly says that the sodium has been lost in the urine. There's clear-cut salt wasting. Now is the most important point, that potassium. So potassium being high clearly indicates something wrong with the RAS axis. Because if it was low, we would consider tubulopathy or diuretic, etc. But it is high. Now the key question comes, is it just aldosterone defect or is it a corticoaldosterone defect? Now the answer to that question is right in front of us, which is the sodium. If it was just an aldosterone defect, we would have sodium of maximum around 120, 122. But because of the combined effect of cortisol deficiency and decreased aldosterone, we can get a sodium up to 110 and even lower. So can you go to the next slide?
Yes.
So just reiterating what I just said, we look at the fluid status. Go ahead. Yes. Hypovolemic, look at the urine sodium. The urine sodium is high, look at the potassium. And the potassium high suggests a RAS defect. I would expect the aldosterone to be low and the PRA to be high. Now the key question is, what we have here is a child with atypical genitalia. Now, in this age group, the most common cause of combined corticoadrenal deficiency is congenital adrenal hyperplasia, and very, very rarely is a AHC due to DAX1. But since we clearly have a DSD over here, we need to do the 17 OHP, which will expectedly be high. And this is a expected case of 21 hydroxylase deficiency. Yeah, so the key messages over here, go ahead, are basically hyponatremia, hyperkalemia, consider RAS defect, look at the sodium levels to consider combined defect, and consider CH if there is atypical genitalia. And yes, of course, if it's a male child, that child may not have any effect and can present simple salt wasting, and we need to keep that in mind.
So suppose you have a male child and you have got a creatinine which is high. Now somebody will argue that this child with hyponatremia, hyperkalemia is renal failure. Mm-hmm. What point in this case, Dr. Pratik will tell you that this is not renal but adrenal in this case?
So the hyperkalemia, hyponatremia, increased 17 OHP is clear cut towards that.
If you forget about 17 OHP, let's say at admission, you had hyponatremia, hyperkalemia, your creatinine is high. Now, somebody says it is because of renal problem. You got both situations. Adrenal is causing the problem. So you have a very important clue which was there.
Yes, we have to do. We should look at this fluid status. Basically, if it's hypovolemic, uric acid is high, points towards adrenal. If it's hypervolemic, points towards hypovolemic adrenal and hyperadrenal.
62. And we said PCU was 62. So the first slide, as you mentioned very nicely, really made the diagnosis very clear. You can't have any other differential from there. Thanks, carry forward.
Thank you, Dr. Pratik. Now coming on to the next case, this was a 6-month-old girl who was diagnosed as a case of cystic fibrosis, had failure to thrive chest infections, had a sweat chloride of 120, which made the diagnosis of cystic fibrosis much easier. But what was missing was that till 6 months of age, there was no steatorrhea in this case. She had a sodium of 120 and a potassium of 6.8. Dr. Sumana ma'am, are we missing anything here?
Yes, a very interesting case there. And as we can see, there is no steatorrhea even at 6 months. I think as a good clinician, we should always put our lateral thinking hat on. So there is hyponatremia, hyperkalemia, and of course, failure to thrive in chest infections. So as discussed in all the previous slides beautifully, we have a wonderful algorithm there. So the first thing to assess is the fluid status of the child. With so much of salt wasting going on with such low sodium, I assume the child is obviously hypovolemic. So we would go for the urinary sodium levels. I presume they're more than 30 millimoles per liter. And yes, so then we will go for serum potassium. I know that it is already high, it's probably 6.8. So we have hyponatremia, hyperkalemia, high urinary sodium, like more than 30 millimoles per liter. Now we should evaluate the RAS axis, the renin, aldosterone, angiotensin axis now. And as you are showing, the renin and aldosterone both are high in this case. So that, and with the background history and with the urine sodium of 120 millimoles per liter, I think we would have to consider the diagnosis of pseudo hypoaldosteronism type 1 here, the autosomal recessive one, the one that has systemic involvement, which is a close DD. You know, although it's rare, I must say it's rare, but we should always keep that in mind when we are unable to explain all the features in a child who's already labeled as cystic fibrosis. This is something we should really consider. And despite such high aldosterone and renin levels, the sodium is so low, you know, and so this is an interesting one. And I think the key messages here, if you show the next slide, is any child who has salt wasting and pneumonia, as seen in this case, we should think of pseudo hypoaldosteronism type 1, which is a very severe, the multisystemic form is a severe form, which needs a more aggressive supplementation of oral salt, and has a poor prognosis because it is persistent usually. And as you are showing, it has high renin and aldosterone. We should remember that in cystic fibrosis, the potassium shouldn't be that high, but here in cases of pseudo hypoaldosteronism, it can be really high, and it can go up to really dangerous levels. So we should be very careful about that. Thank you very much, Sharon.
Thank you, ma'am, for such a nice explanation. Now moving on to the next case. This was a 1-month-old boy who came to us with reduced feeding, had a birth weight of 3.1 kgs, but now in 1 month gained only 100 grams. Had a low sodium and a high potassium in this case. A 17 OHP was done, just like the case of Dr. Pratik mentioned, but the 17 OHP in this case was normal, and the cortisol was appropriate. A PRA and aldosterone was done, which again came out to be normal. So Dr. Chetan, how to take the case forward from here?
So any failure to thrive boy with or a girl with hyponatremia and hyperkalemia, first of all, we should differentiate between renal versus adrenal. So I think first of all, we should do creatinine. And if the creatinine is normal, then definitely we should be looking for the adrenal axis defect. And we know that aldosterone is such a high level, that is 200 nanogram per ml. And with this high aldosterone, sodium should be coming to the normal, but sodium is not coming up, potassium is still high. Even with the high aldosterone level suggests aldosterone resistance. So this is looking like a case of pseudo hypoaldosteronism, and with this small kid, we should rule out the either urinary tract infection or structural anomalies which can cause the aldosterone resistance. So, and yeah, the case is showing high WBC on urine routine micro, and I had a similar case of a boy with failure to thrive, and that boy also had a culture proven sepsis. So definitely this is an aldosterone resistance. secondary to the UTI, and UTI is due to the defect in the urinary tract. So this is a PHP case, and the key message is, first of all, we should rule out renal versus adrenal. If it is renal cause, then definitely it will be the euvolemic or hypervolemic, but adrenal defect will be having hypovolemia. And any history of UTI, definitely aldosterone level should be done, and this is transient, so it improves with the treatment of urinary tract infection. And if there is structural anomalies, it will go away with the correction of that structural anomalies. Thank you.
Thank you, Dr. Chetan. Now moving on to the next case.
So just before we move ahead, the next case, we'll just have a quick word about hypernatremia. Now, hypernatremia is more of free water deficit rather than sodium load. And the main thing to look at there is that if you have got high sodium, your blood is concentrated, your urine should be concentrated. If your urine is dilute, there is a problem. So if you have got a high sodium, urine osmolality is more than 600. This means it's either an osmotic diuresis or a sodium load. It's a rare situation. If your sodium is high and the urine osmolality is less than 600, do not do a water deprivation test. I have seen people advise hypernatremia with low urinary osmolality, do water deprivation. Patient may die, may become blind, everything can happen. Because your goal of water deprivation has already been happening. So there is no need of that. The second thing is that look at AVP response. If there is a response, this is central DI, and there is no response, there is nephrogenic DI. There are a lot of debates as to what dose to use, how to go ahead. I will say 0.1 unit per kg subcutaneous of vasopressin, and an increase of more than 50% at 1 and 2 hours will be very, very important. We'll start with the next case, very interesting case.
This was a 3-month-old girl who presented to us with altered sensorium. Had a sodium which was very high, 170 millimoles per liter. Urine osmolality was low, at 110 milliosmoles per kg. Was advised a water deprivation test. So, Dr. Pratik, would you do you agree with this?
Yes, so I think sir has very well explained this. First of all, if we have a 3-month-old child with hypernatremia, which is symptomatic, the first thing to do is to treat the hypernatremia rather than doing a water deprivation test. And secondly, this is a form of a natural water deprivation test which is already happening. If the sodium is 170, I would expect the serum osmolality to be of around 340, which is already above the threshold for the deprivation test, and ADH is maximally stimulated. So despite this maximal stimulation, if you have a urine osmolality which is not more than 600 or 800, it means that the ADH is not working. So can you go ahead?
Yes.
Yes. So this girl had seizures. Can you show the algorithm? Yes. So when we do the urine osmolality, we look at the serum with hypernatremia. When we look at the osmolality, when it's less than 600, we give DDAVP. And if there's an AVP response present, it points more towards central DI.
So an AVP response was present in this case?
Yes, pointing more towards central DI. So the key messages in this case are basically do not do a water deprivation test if the child is already in hypernatremia. It is already a water deprivation test happening at that time.
Thank you so much, Dr. Pradeep. Moving on to the next case. This was a 14-day girl who presented to us with failure to thrive. Had a birth weight of 2.6 kilograms, but was now 2.3 kilograms, lost 300 grams. Was being breastfed. Now on laboratory investigations, we found a sodium of 182 millimoles per liter, and a urine osmolality was very high at 1000 milliosmoles per kg. So, Dr. Sri Durga, how to move forward with this case?
So this is a 2-week-old girl who is on exclusive breastfeeding and who has come to us with a failure to thrive. So considering this weight loss of around 300 grams, maybe approximately 20% weight loss, I would consider that the child is dehydrated and with the sodium of 182 and urinary osmolality is 1000. So these two suggest that the total body sodium load is very high. Okay.
Yes.
So as we go by the algorithm, the urinary osmolality is very high, indicating that the sodium load is high. So what is the urinary sodium?
The
Again,
urine
it is
sodium
very
was
high.
110.
Okay, so all these indicate that this child has got a high sodium load. Next slide, please.
So, ma'am,
So
what was the
considering
yes.
So considering this child who is on exclusive breastfeeding, this is a breast milk related hypernatremia. Moving on to the next slide. So let's see few literature on breast milk sodium associated hypernatremia. So this concept has been from 1994. The first was published in American Academy of Pediatrics, the clinical usefulness of breast milk sodium in assessing lactogenesis. So based on this study, it suggests that after the colostrum, when the milk is getting converted into the mature form, there should be a drop in the level of sodium in the breast milk. So if this drop doesn't happen normally and there is a prolonged elevation of sodium, there is an impaired lactogenesis. So this leads to breast milk inadequacy. Next slide. Next slide, please. So the next is from a study from Clinical Medicine and Diagnostics. The previous one, hypernatremia in neonates getting exclusive breastfeeding. So as we all know that when breast milk sodium is high, the neonates are prone for hypernatremia. So why does this happen? So in any product from the body, the osmolality should be maintained. So similarly, in the mother's breast milk, the osmolality needs to be maintained. So when the breast milk is inadequate, in order to maintain the osmolality, instead of the lactose, sodium chloride goes up. So a high sodium just indicates that there is a inadequate breast milk. Next slide, please. So there are few case reports suggesting that there is a neonatal hypernatremia secondary to high breast milk sodium. In other words, there is a lactation failure. So the key message will be elevated breast milk is a rare, but it is one of the causes for neonatal hypernatremia. And in any case of neonatal hypernatremia, especially who is on exclusive breast milk, the breast milk sodium needs to be measured and specific advice need to be given regarding maintenance of breastfeeding. So this is very commonly seen in preemies. Next slide, please. So the key message in this case will be whenever there is a high serum and urinary sodium, it indicates that there is a high sodium load in the body, and in a baby who is exclusively breastfeed, it is breast milk hypernatremia, which is more common in preemie mothers.
I think that's a very, very important and interesting message. And thanks for sharing that report, which was 20 years ago when I was doing my SRship. There we've identified this child, very interesting case at that time, presented with hypernatremia dehydration, turned out to be because of the breast milk inadequacy. I think that was there. Carry forward.
This was a 13-year-old boy who was admitted in the PICU with encephalitis. He was on the ventilator, suddenly started to pour huge amounts of urine. He was having polyuria of 10 ml per kg per hour at the time of referral. On the referral sheet, it was mentioned that his sodium was 180 milliosmoles per liter, had a very low urinary osmolality compared to his level of serum sodium. The post-AVP came up to 200 milliosmoles per kg. So Dr. Sumarna, what is happening in this case?
Thank you, Shayan. This is a very unfortunate case where this 13-year-old boy is on ventilator with encephalitis, and I presume there is widespread brain damage already. And suddenly there is polyuria, so at the rate of 10 ml per kilo per hour, with severely high sodium levels of 180 and urine osmolality of 120 milliosmoles per kilo. So we have high sodium with low urine osmolality and polyuria, of course. And there, after post-AVP stimulation challenge, the urine osmolality goes up to 200 milliosmoles per kilo, which is definitely more than 50% of the previous one. So going by all these, this is a case of central diabetes insipidus, and probably brain death. It's a harbinger of brain death, and there have been case reports like that. And it's a very, very grave situation with very poor outcome. And of course, it's a situation where the parents should be counseled that probably brain death is ensuing. And the management will be either with fluids or with AVP infusion. And if we give AVP infusion, it should be started the range can be 1.5 to 10 millunits per kilo per hour, should be started at a lower dose and then gradually increased, keeping a close eye at the urine output and of course the sodium levels. And there is a high chance that there may be a sudden fall in the sodium level. So it's very, very important to have a very close monitoring of the sodium levels. And basically it's a very difficult situation with a very grave prognosis. But as pediatricians and as critical care people, we need to be aware of the situation. Thank you very much. So the key messages from this case are that we should always consider brain death DI in any child with brain injury, be it infection, be it parental asphyxia and ischemic episodes. And the cornerstone of management will be either fluid replacement or AVP infusion. Thank you very much.
I think that's a big message, that if a child who is very sick in the ICU suddenly starts pouring urine, think of a possibility of brain death. That's the key message. And this is also relevant from diabetes mellitus also. Many times DKA patients, they will develop hyponatremia, think of DI. It also happens there because of cerebral edema in that regards. Just a quick word about this final section on hypokalemia. Now we know potassium is unique, that it's mainly an intracellular ion. And potassium levels can go down because of the intracellular shift, which can happen because of insulin and alkalosis or the use of beta agonist. And there could be some of those rare channelopathies. The major causes are intestinal loss, which is there because of diarrhea, vomiting, or NG aspirations, which will be associated with hypokalemia, and renal loss in the form of metabolic alkalosis, furosemide, thiazide, Barter's, and those syndromes. Now, we have always been trying to see which is the most important investigation to look at. So for hypocalcemia, we talked about phosphorus being most important. For hypernatremia, we talked about urinary sodium as most important. For hypokalemia, the most important investigation is blood gas. Everybody who is hypokalemic will have an increased RAS ascase and will have metabolic alkalosis. If you have hypokalemia with metabolic acidosis, the only possibilities are RTA or GI loss, rarely would be acetazolamide and those things. So again, very important is a blood gas in any child who has hypokalemia. Chronic hypokalemia to happen, the RAS will be more active. This is what we discussed in that perspective. So again, if you go by various causes, diuretic use will basically have hypokalemia with alkalosis. Malnutrition will again have hypokalemia, alkalosis, hypomagnesemia will be there. Bartter syndrome will present with failure to thrive, polyuria, hypokalemia, alkalosis. Along with that, you will have nephrocalcinosis. Gentlemen, the magnesium will not be affected. RAS excess will have hypertension along with hypokalemic alkalosis, which is there. RTA again will have acidosis, and diarrhea will also have acidosis. So basically, the main things to look at in terms of is to look at the volume. If the volume is high, it is RAS excess. Urinary chloride, if it is high, it goes more in favor of a urinary loss, except RTA and diarrhea. But I would say the most important is pH. If you have acidosis, it suggests basically RTA or diarrhea. That's very important. And magnesium, again, refractory hypokalemia, do a magnesium level. That's very, very important. And therefore, these are most important. So if you have blood gas shows acidosis, look at urinary anion gap. If urinary anion gap is negative, which means ammonium is being produced, this is basically a GI loss. If urinary anion gap is positive, it means ammonium is not being produced. It is more like a RTA. On the other hand, if you have metabolic alkalosis, then the workup is more complicated. You won't go much into details, but you think of tubulopathies and RAS disorders in that perspective. So the major focus is blood gas in that regard. So Dr. Sain, please come up with the next case.
This was a 2-month-old boy who had potassium levels of only 2.8 millimoles per liter, had a metabolic acidosis, base excess of -16, but had a normal anion gap. So, Sri Durga ma'am, how to differentiate a GI cause from a renal cause in this case? Sri Durga ma'am?
Sri Durga, are you there?
Unmute.
Am I audible?
Yes, ma'am.
So this is a 2-month-old boy who presented to us with hypokalemia, a potassium level of 2.8. And as the algorithm goes by a pH of 7.16 and a normal anion gap. So can you move to the previous slide? Previous one.
Okay.
Yeah. Could you give me some more clinical clues, like is the child has got failure to thrive?
No failure to thrive, ma'am.
Okay. And how is the urine output?
There was no polyuria, ma'am, in this case.
Okay. So this is a normal child who has no polyuria. Okay. So moving on to the next slide. Next slide, please.
Yes, please.
So as per our algorithm, it's a normal anion gap metabolic acidosis. So we have to differentiate whether this hypokalemia is secondary to diarrhea or renal tubular acidosis. So clinically, this child doesn't have any failure to thrive or polyuria. So in case of renal tubular acidosis, there will be polyuria, though even though the child can be dehydrated. So here the body is trying to conserve the fluid inappropriate for the dehydration, and it is a normal child. So clinically, it looks more like a child with diarrheal loss of bicarbonate. So let's move on to the investigations. What is the urinary anion gap?
And the urinary anion gap was negative in this case.
Okay. So this urinary anion gap just indicate how good your body can excrete the acid. So as sir has already mentioned, this indicates the ammoniogenesis. So your body tries to excrete the protons in the form of ammonium ion. So ammonium is normally not measured. So in order to maintain the electroneutrality, whenever the ammonium, which is positively charged, goes up, the chloride should also go up. So in this case, the chloride has gone up, making the urinary anion gap negative. So this means there is some active ammoniogenesis happening here. So whereas in renal tubular acidosis, even though the body pH can be acidotic, your urine is deficit in excreting the acid. So there is no ammoniogenesis, so urinary anion gap will be positive. So this child with a normal weight gain and no polyuria and a negative urinary anion gap, meaning that the child is able to excrete the excess of acid in the body. So I would like to make a diagnosis of normal anion gap metabolic acidosis secondary to diarrhea.
Ma'am, what are your key messages for this case, ma'am?
So this case clearly shows us the clinical significance of your clinical history as well as the follow-up of your investigations. So both renal tubular acidosis and diarrhea can present with acidosis and low potassium. And a child with diarrhea, clinically it's a normally thriving child and there is no polyuria. And as with your investigation, this child has a urinary anion gap which is negative. Okay, thank you.
Thank you so much, ma'am. Moving on to the next case. This was a 3-month-old girl with failure to thrive, had a low potassium of 2.2, had a birth weight of 2.8 kilograms, was now at 3.5 kilograms, had metabolic alkalosis, had a normal BP of 70 divided by 40 milligrams per mercury. So Dr. Chetan, how to proceed with this case?
So this is a case of failure to thrive with metabolic alkalosis and hypokalemia. So with a normal BP, suggestive of possible tubulopathy, which is leading to the potassium loss. So blood gas is suggestive of alkalosis with normal blood pressure. So this leads to a diagnosis of tubulopathy, likely Bartter versus Gitelman syndrome. And looking to the age and all, if we can see the urinary calcium, what is the urinary calcium?
Nephrocalcinosis.
Yeah, so nephrocalcinosis. So there is a inappropriate calcium excretion leading to the deposition of the calcium in the renal tubules as well. So metabolic acidosis, failure to thrive, hypokalemia, and high urinary calcium creatine ratio or nephrocalcinosis is suggestive of neonatal variety of the Bartter syndrome. So straight away, these 3 points are suggestive of the Bartter syndrome. So any newborn failure to thrive with normal blood pressure with polyuria and hypokalemia This is likely a neonatal Bartter syndrome, and urinary calcium excretion either in form of ultrasound abdomen or a urinary calcium creatine ratio would likely guiding towards either we are dealing with the Bartter or Gitelman syndrome. Thank you.
Thank you, Dr. Chetan, for explaining to us this very rare case and how to make the diagnosis by just a urine calcium in this case. Now, moving on to the next case, this was an 8-year-old boy who presented to us with concerns of early puberty. He had a height of 134 centimeters, had a pubic hair of staging 4. Again had metabolic alkalosis, but here with the low potassium. Urine chloride was 100 and a BP of 120/74 for an age of 8-year-old. So Dr. Pratik, how to move forward in this case?
Okay. So here we have an 8-year-old boy and has achieved early puberty. Now the peculiarity in this is that the height is he's tall and pubic hair has grown to a 4th stage. That means probably some sort of a peripheral precocious puberty. Now next, when we look at the VBG, there is hypokalemia and alkalosis, which is expected. It's not RTA, it's not DKA, or it's not gastrointestinal loss. Then the third point, which you look at the BP. So this is hypertension is there. So either there is increased aldosterone, or there is some sort of aldosterone effect increase, or it is some sort of variant that is DOC, etc., metabolite increase, which is there. So can you go to the next slide?
Yes.
Yeah. So if you go by the algorithm, we did the blood gas, there was metabolic alkalosis, the blood pressure was high, and go ahead, the aldosterone. Okay. So
Yes.
the next, yes, go ahead. So the next step seen here, yes, aldosterone is low. So there's probably some sort of a metabolite which is causing the increased aldosterone effect. So
now, Dr. Pratik, after the child presented to us, there was cryptorchidism in this case.
yeah, so probably on examination there was cryptorchidism and probably the ultrasound did not show any testis. So this is actually an XX DSD with hypertension and virilization at the time of puberty. And the diagnosis is very clear in front of us, which is probably 11 hydroxylase deficiency. What are the key messages? Yes, so the key messages is basically hypertension, alkalosis, think of CAH. Go ahead. And XX DSD is 11 hydroxylase defect. Now, one point here is it's a XY DSD. Like if you see the XY DSD, you can consider 17 hydroxylase defect with a similar clinical picture. Thank you.
Thank you.
Thanks a lot, Sain, for this wonderful discussion. And this was absolutely time appropriate. We are at the right time in terms of that. And I'd like to thank all the panelists for this wonderful discussion, right from Dr. Sri Durga, Dr. Chetan Dave, Dr. Sumana, and Dr. Pratik, along with Dr. Sain for conducting this session wonderfully. We were able to cover all the aspects of electrolyte disorders, ranging from hyponatremia to hypernatremia to hypokalemia in that regard. So I think this is going on very well, and we have got 2 more sessions. So we are in the midway of our session today. There are 2 very important sessions on DKA and hypoglycemia, and one very, very important session which is there with regards to the quiz that is going to happen at the end of this program. So this quiz is quite exciting and quite interesting. Just to give a sort of a overview as to what is going to happen and how we came to this quiz. This was a prelims round which happened, which was there basically a couple of days ago. And in that prelims round, we were able to actually select number of people for the quiz. There were 120 participants which participated from 12 countries in the quiz. This was a highly competitive quiz which was there. And this was a very interesting experience, and we were able to connect to people from across the globe. We'll just share as to how people performed and what we're going to do in the quiz soon. And so basically in this quiz, we, as discussed, there was 12 countries, 120 participants. And as you can see, this was like a normal distribution that we see in terms of any statistical parameters. There will be a few people who are on the other side of that bell, but there was a normal distribution which is there. We got 3 big categories of people who participated. One were, of course, the trainees, endocrine and pediatric endocrine trainees. The second group was, of course, the postgraduate trainees, and the third was the pediatrician. So considering that there will obviously be differences in terms of the exposure, there were variations, but we got a very good people for the finalists. The finalists today are Dr. Debaditya Das, who is doing DM Endocrinology from Kolkata. We've got Dr. Ramiz Raja from Madurai Medical College, again DM student, Dr. Ahmad Alam from BHU Varanasi, DM resident. We have got Dr. Sawar Agarwal, who is a very senior pediatrician working from Ekta Hospital at Raipur. Dr. Sanju Joseph, again a pediatrician from St. Thomas Hospital in Kerala, and Dr. Arun George, a senior resident in pediatrics from CMC Vellore. So we've got a good mix of people, and we're going to go through a number of very interesting case scenarios. Now, clue for all the finalists, many of these questions have already been discussed today, and they will be discussed subsequently also. So keep your eyes and ears open, you will get that. Now, we've got very attractive prizes for that. The first prize is a free subscription to our advanced pediatric endocrine course, both online and on-site, along with the books, the application which come with that. The second prize is for a basic pediatric endocrine course, online and on-site, again with the basic combo and the application. All the other finalists, the 4 finalists, will get a free subscription to our third biggest course, that is the adolescent endocrinology, which has got over 25 modules along with the app subscription. Now, this is not the end of the story. We also had very dynamic participations from postgraduates. So we have selected 66 top performing postgraduates. The name will be released at the end of the quiz, who will be given a significant discount in terms of the pediatric endocrinology for postgraduate course, which is a 3-year course with a lot of modules, books, applications along with that. Another category of best performing pediatricians will get a 30% discount on a basic pediatric endocrinology course. And for the endocrine trainees also, because these 3 groups were quite distinct in terms of exposure, level of training. So we'll be giving special discounts for these individuals as well. So watch for the space. We'll have the quiz coming very shortly after these 2 next modules. And all those who are participating in the quiz, just remember that a lot of these questions that we are discussing now would essentially be part of the quiz. So be very careful in that regard. So for this session, on the diabetic ketoacidosis, we have got a very eminent panel which is there with me, and we'll start off with the initial part and then we'll go forward on the DKA in that regards. So diabetic ketoacidosis is by far the most important endocrine emergency that you will see, and it is the leading cause of death in anybody who has type 1 diabetes, and that's what we need to have a rational evaluation and rational assessment which happens in that perspective. So the session today, we have got 4 very eminent panelists. Dr. Vijay Jaiswal, who is the head of department at Lala Lajpat Rai Medical College, Meerut. Dr. Jaiswal has been very closely associated with us right from the onset of practical pediatric endocrine course for the last 10 years. Very dynamic individual. He's done fellowship from Dr. Vaman Khadilkar's unit at Bharati Vidyapeeth. Dr. Prema, who is the head of department at Rajeshwari Medical College, Bangalore, again, very interested in pediatric endocrinology, particularly in diabetes. Dr. Vikas Mehrotra, a close friend, colleague, and he has also been involved, like Dr. Vijay, right from the offset with regards to the different aspects of Grow India, MedEClasses, and other aspects. And I'm really proud to have Dr. Hemang also as part of our team. Dr. Hemang was working here as an intensivist fellow, and he is the brain and a lot of other brain and brawn behind the MedEClasses DK application, which is a wonderful application which really helps you do precise management of DK. And we'll discuss how this came up and how it will go forward. I'll be joined by Dr. Naveen, our fellow, who will carry forward with regards to the cases. But before we go, we'll basically have a quick word about the basic pathophysiology of DKA. So we all know that DKA is predominantly because of 2 things. You have insulin deficiency and you have counter-regulatory excess. Now, both of this is important. Individuals who have a multiple pituitary hormone deficiency will basically have an issue with regards to not having DKA because they don't have a counter-regulatory excess. Insulin deficiency will cause increased lipolysis, producing ketones, ketogenesis, and this ketogenesis causes all the features: acidosis, rachypnea, abdominal pain, and rapid breathing. While the counter-regulatory excess along with insulin deficiency causes release of glucose, causing hyperglycemia, which then causes osmotic diuresis and massive loss of potassium, sodium, and water. So there is a huge deficit of sodium, potassium, and water in anybody who has diabetic ketoacidosis. And because your volume goes down, you will again have this counter-regulatory hormone going up. So this is like a vicious cycle carrying on, and this is something which will ultimately lead to death if you don't treat it appropriately. And of course, your RAS axis will go up, and once RAS axis goes up, your potassium will come down. That is, I think, something which is again going to be very contributory. Now, what does it do? In the setting of DKA, you have 7 to 10% dehydration, but the clinical assessment of dehydration is not very accurate. So be careful. Don't over or underestimate dehydration in DKA. Go one step lower. Sodium is always low, but you will tend to overestimate sodium deficit because there is pseudo hyponatremia. So for every 100 milligram per DL, your glucose goes up. You add 1.60 of sodium, and that will be the corrected sodium. And corrected sodium is by far the most important parameter to follow in anybody who has diabetic ketoacidosis. Potassium again will be low, but you will underestimate the deficit of potassium because you have got insulin deficiency and acidosis. Potassium comes out of the cell. And again, in this setting, basically, once you start treatment, you will have severe hypokalemia. So if you mark my words, if you have a very, very low sodium at diagnosis, if you have got a low potassium at diagnosis, you have got something to worry about. This is not your day run-of-the-mill DKA case. There are some issues which are there, which you have to be careful in that perspective, and this is very important. One simple formula by which you can understand what potassium level is, that for every 0.1 decline in the pH, the potassium should go up by 0.6. So if your pH is 6.9, you should decrease potassium by 3 in your blood. So potassium of 5 will become 2. So this is a rough way of looking at how much metabolic acidosis can impact the potassium level in this perspective. Now, how do we treat? Of course, the first thing is fluid. Now, as soon as you give fluid, the volume comes down, the volume goes up. So there is dilution of the concentrated glucose and the counter-regulatory hormone goes down, and there would be a rapid decline in glucose by typically 100 to 200 milligram per DL. If you give insulin now, your glucose will rapidly fall, and that could be very, very dangerous. So do not give insulin in the first 1 hour, but after that you need to give insulin, which will then decrease ketogenesis, and that will result in improvement in that perspective. But you need to be cautious. If you give too rapid correction, you can cause problems like cerebral edema. And if you give too much fluid, there could be a problem of hyperchloremic metabolic acidosis. And often we tend to treat hyperchloremic metabolic acidosis with insulin. Insulin is not the treatment for hyperchloremic acidosis. And this is what you need to understand. If you give too much insulin, you will cause hypokalemia and other problems. The major complications to watch out, of course, number one is cerebral edema, which usually occurs with severe disease, giving too much fluid and giving bicarbonate and osmotic shift. It is a bad condition. This is the major cause of death in DKA. Any child with DKA, altered sensorium, check sugar. If it is normal, think DKA, give mannitol. That's pretty much end of the story. Do not wait for imaging. Do not give too much fluid, give a slow correction, and that's how patient will improve. Hypokalemia, the second most dangerous thing, usually occurs with insulin. So give potassium. If your potassium is low at diagnosis, that is a serious issue to worry about in that perspective. And of course, if acidosis is persisting, think of other diagnoses like lactic acidosis and infection and hyperchloremic metabolic acidosis. Do not give soda bicarbonate unless the pH is less than 6.9. There is a cardiac arrest or there is life-threatening hyperkalemia. Do not give it as a bolus. Always give other infusion if you have these 3 conditions in that regards. Be wary of infections which may be there, thrombosis. So do not put central line. If you put central line, give low molecular weight heparin. Do not intubate, because if you intubate, there will be a CNS pressure which will go up. And very importantly, if there is a sudden shaking of the muscles, if there is a muscle pain, if there is hematuria, and this was part of the quiz also, think of rhabdomyolysis and your CPK levels will go up. You will have oligouria and renal failure is what is going to happen. Now we'll start off with the first case. Dr. Naveen, please come up and carry forward from there.
Good evening all, and let's move on to the case discussion with diabetes. We had a 3-year-old boy who was a known asthma patient and was admitted in the pediatric emergency department and was on steroids for a very long duration for around 1 year or more. And part of routine ICU protocol is blood sugar was done, which was found to be high, and it was found to be 220 milligram per deciliter. And a part of respiratory distress is VBG was done, which showed acidosis with pH of 7.22 and bicarb of 18. So we have hyperglycemia.
Thank you.
Yeah, hyperglycemia and acidosis. So do you think is it really DKA, and what are the various features of necessary for diagnosing DKA, Dr. Vijay?
Thank you. This is really a very good case scenario, and it is very common in the diabetic patient. So since he is having steroid, blood sugar is hyperglycemia that is beyond 200. You can see here that pH is on acidotic range. So whether this is qualifying for DKA, so I should go more elaborate that DKA is a diagnosis of the triad. At least there should be three things. That is diabetes, it means that blood sugar should be beyond 200. Ketosis, that is ketones, either blood ketone is more than 3 millimole or that urinary ketone should be positive, and the pH should be acidotic. So all the three components are there or not, we have to see. So if we are going to collaborate in this case, probably it is not so. Can you move further? Yes. So yes, please go back. Please go back. Yes. Yes. So whether this case was having two things, that is, one is acidosis and the second was that glucose was beyond 200. But acidosis and ketone body is what. So whether this is a sick day child, so we can't say that this is diabetic ketoacidosis. On the second case, what you are going to see here, that blood sugar is beyond 200 and acidosis is there or not. So depending upon that, if there is only high blood sugar, then probability of stress hyperglycemia will be quite high. So we should take the account of all the three parameters.
Yes, sir. And the ketone level was done, it was found to be on the lower side.
Yes, so we can see here, yes. Yes, so since the child was on beta-2 agonist, so it is also going to add up some more blood sugar, and he was unwell, so it is not prudent to qualify for DKA, but yes, stress hyperglycemia was there, and this was due to a sick day. So basically this child requires sick day management and more frequent blood sugar monitoring should be required.
So thank you. And unfortunately, the patient developed type 1 on follow-up. So moving on to the next case, we have a 1-year-old boy who came with a complaint of failure to drive since birth. And on exam investigation, he had a pH of 7.12 and bicarb of 15 and anion gap was 20, which was showing moderate to severe acidosis. And his ketone was found to be very high with 3.2 millimole per liter. And his blood sugars were fluctuating between 80 to 200 milligram per deciliter. So do you think this is a case of DKA, Dr. Prema?
Good afternoon. And I thank Dr. Anurag for giving me this wonderful opportunity to be here. And coming to the case, this is a 1-year-old boy and the history shows there's a failure to thrive. And we have seen the ABG, which shows that a pH of 7.2, way less than 7.3, which shows its acidosis. First, we consider the pH in an ABG, then we see into whether it's a respiratory or metabolic. As a bicarbonate is 15, we know it's metabolic. And coming to anion gap, as it is more than 12, we know there's an anion gap acidosis in this child. And also the ketones are definitely more than 3, as you have shown the triad of diabetic ketoacidosis, where the ketones have to be more than 3. So we have fit in the things of acidosis and ketosis. Next, coming to the blood sugar to fulfill the other criteria of decay, that is hyperglycemia. Here you are telling the blood sugar is between 80 to 200, which I'm not really, we are not sure whether it is hyperglycemia or sometimes it is normoglycemia. So I would like to see if there is if whenever I'm unsure about this hyperglycemia, it is always better to do HbA1c. So what happened to the HbA1c in this case?
We got
I think it is
HbA1c done and it was 5.4.
5.4. Okay, so the HbA1c is 5.4. Definitely, it is not diabetes. So we are seeing here that the two components of the triad is fulfilled, that is ketosis and acidosis. So if we have only hyperglycemia and and ketosis as the previous case, that fits into a stress-induced hyperglycemia. Here in this case, there is only ketosis and acidosis, which we should think of organic acidemias. So if you are thinking acidemias, especially in a neonate or an infant with then we have to go back to the history to find if it is autosomal recessive, whether there's history of consanguinity, any developmental delay or seizures. So any other history has to be taken for diagnosis of this organic acidemia. So in this case for a DKA, we have to be very sure that we should not start off with medication for DKA without completing the triad, because we would be unnecessarily putting the child with fluid and insulin, which is not the right treatment. So to come up with
what are the messages, key messages from this case?
Yeah, the key messages from these two cases could be like, because this child, the first one had hyperglycemia and ketosis, we should always suspect an infection or a bronchial asthma in a child. And especially hyperglycemia, as we have seen nowadays with COVID, especially in young adults, who many of them have had hyperglycemia and stress induced all these problems, and they later on also developed diabetes. So that and hyperglycemia, ketosis and acidosis, you should keep in mind of organic acidemia, and always do the blood ketones rather than urine ketones, as we know that beta hydroxybutyrate will be detected from blood ketones itself, and you should always be looking for stress hyperglycemia in these cases.
Thank you so much, ma'am, for the detailed explanation of how to rule out diabetes and the importance of starting insulin with a correct diagnosis of diabetes. So moving on to the next case, we have a 4-year-old girl who was actually managed out from outside in view of diarrhea. And at the time of admission, we had a pH of severe acidosis with pH of 6.8. Her bicarbonate was found to be very low of 4 millimole per liter. And she had a very high ketones of 7.1. On clinical examination, she was found to be drowsy and had anisocoria, and reflexes were brisk. So what went wrong in the management of this case, Dr. Vikas?
Vikas, are you there?
Okay. Good. Thank you, Dr. Naveen. Am I audible now?
Yes, sir.
Hello. So, Dr. Naveen, thank you very much. And at the onset, I'm thankful to the entire team Grow India as well as Dr. Anurag Vajpayee to be the part of this extreme panelist. If you consider this case of a young child, 3 to 4 year of age girl, she has been managed as diarrhea. And if you see the pH and bicarbs and ketones, we are dealing with a case of severe diabetic ketoacidosis, rather ketoacidosis. We cannot be sure about the diabetes. If you examine the child, she was drowsy, and isocoria was there, and reflexes are brisk. This is very, very important. Brisk reflexes in a child with ketones and severe acidosis. And considering the entire situation, we are dealing with a case of, can we have the previous slide, please? Just for 1 minute over. Considering the entire situation, there is a strong possibility of that this child of severe DKA might already developed cellular edema, which is very, very unwanted acute complication of diabetic ketoacidosis. It carries very high mortality and morbidity. Since she has been referred from a center and managed diarrhea, so a very strong possibility of inappropriate, rapid, and inadequate fluid management. This might be the triggering factor for cerebral edema in this case. So whenever you have got a child of diabetic ketoacidosis, if she has got any of the reflexes brisk, or she is drowsy or anisocoria, or if you are having unstable hemodynamic parameters of a child, think of cerebral edema. And unfortunately, cerebral edema is present in most of the cases of DKA to start with. So don't waste time. Just rush for mannitol in a dose of around 0.5 gram per ml per kg, and it should be pushed as early as possible. There's no need of any imaging, but Secondly, which is very, very important, is as we have already told by Dr. Vajpayee, fluid management is the mainstay of treatment of DKA. And so if we had a patient who has been referred from the outside, we have to go very slow. We have to undercorrect the dehydration and take care of the fluid which has already been given to a child. If you can find out from the parents how many bottles are there, try to reduce it, and should we go very slow and give mannitol, mannitol, and mannitol. Next, plus.
So what are the key messages with regards to the treatment of cerebral?
So, Dr. Naveen, whenever you receive a child in any of the ICU, PICU, and if you are suspecting cerebral edema, try to find out what the amount of fluid has to be given, and it has to be subtracted from the fluid which you are already given. You might be giving a less amount of fluid. It is okay with you, but you are not supposed to give extra fluid. You might not correct dehydration per se. You should go slow and under correction. Cerebral edema, always be alert. Any child who is doing otherwise well, sudden deterioration of clinical status, think of cerebral edema. No need of any imaging. Don't waste time of any imaging. Any localizing sign, think of cerebral edema. Any bradycardia with hypertension, think of cerebral edema, and always go slow and slow and slow. This should be the key message for anybody who is managing DKA. Thank you, Dr. Naveen.
I think that's a very, very valid point mentioned by Dr. Vikas. The one key message coming out of here is that in India, if you have treatment outside, be wary about cerebral edema at diagnosis. Typically, we talk about 12 hours being the typical time, but we do see in our study, which Neha had done, we found that cerebral edema at diagnosis was very common in that regards. Yeah.
So thank you. One last sentence.
Yes,
you have to be very, very careful about cerebral edema because mortality is very, very high. It's almost 40%. And even if you are able to take the child out of PICU, you have got a lot of morbidity. So morbidity is also challenging, which might be the consequence of cerebral edema. So you have to be very, very careful as far as DKA and cerebral edema is concerned. Thank you, Dr. Vajpayee, for chance.
Thank you so much for the detailed explanation regarding the diagnosis and management of cerebral edema. And moving on to another complication with regards to DKA. We had a 3-year-old boy who was diagnosed as a case of severe DKA, and he was managed for a period of 6 years. And after 6 years, he got this investigation done, which showed severe acidosis with a pH of 6.9 and bicarbonate 5, and ketone was found to be high of 6.4. And when we got the potassium levels done, and it was found to be on the very lower side, which was 2.8 millimole per liter. So what do you think and what went wrong in this case, Dr. Hemant?
Dr. Hemang, are you there? Yeah, please unmute yourself.
Sir. Yes, sir. Sir, am I audible?
Yes.
Yes.
Yeah. So this is a case of severe decay, and now at the 6th hour of timing, he has a persistent acidosis, low bicarb, and persistent ketosis, and very low potassium level. So at this point of time, my main focus would be on this low potassium level. Potassium should be between should be more than 3.5 in any child in which we are giving insulin, because insulin pushes the potassium inside the cell, and hypokalemia is the second leading cause of death in a patient with DKA. So as such, as a part of treatment protocol, we should start potassium we should add 10 ml of the potassium in 500 ml of the pint in hydration phase only, and that will prevent the occurrence of the hypokalemia. So in this case, I should decrease the insulin, and I should recheck the potassium after 4 to 6 hours.
I think the big message again here that this child actually came to us referred at that point of time. So he has already been treated. So whenever they come, in most cases which come to us would have been treated outside. And often people miss potassium. If you miss potassium, you will have this situation. And that's why you have to be very careful in that regard.
So what are the key messages, Dr. Hema?
So as I told earlier, in DKA treatment, if we give insulin, it will cause intracellular shift of the potassium inside the cell. Second thing, dissolution of the acidosis will also lead to shifting of the potassium inside. So potassium falls with the DKA treatment. So always start replacing potassium in whenever even after 1 hour of the whenever you are giving hydration to the child, hydration phase. Okay, but one more thing, whenever we usually receive the patient outside receiving inappropriate fluid, so we should keep a watch on potassium level at the time of admission, because hypokalemia at diagnosis is a dangerous thing, and if you start insulin in this child, the child might have a serious hypokalemia and cardiac arrest. So we should start at 10 ml of the potassium in hydration phase, and we should
Yeah, I think that's a very important message, Dr. Hemang. And the other question is that every time I talk about DK, the pediatricians say, okay, why are you making it so complicated? Why we calculate potassium is this much, give that much. If your fluid is this much, give that much. So many calculations. We can't do that. We just follow a typical protocol. Can you improve the quality of care from there? How can you help on that?
Sir, as you say, sir, there are various protocols available, and we usually follow the ISPED protocol. But this is the study done by me and my team with the guidance of Anurag Bajpai sir, which says that only 18% of the patient we have managed correctly as per protocol, and in 5% of the cases we miss fluid boluses. In 12% of the cases we have given less or more fluid, and in 5% of the cases we have not started potassium in the hydration phase, and whenever glucose level will go down, there was a delay in addition of the dextrose. So ultimately this protocol deviation are quite common, and along with Dr. Anurag Bajpai sir, we were thinking that how could we prevent this error. So this is the another chart which says that almost 42% of the hypokalemia can be prevented if we stick to the protocol. 68% of the clinically significant hypoglycemia can be prevented if we stick to the protocol. So these two are the deadly thing, and it is a preventable, and it is a huge number. So for this, we have came with a mobile application in which we have three different things. One is a just general guideline. What guideline says how to manage a DKA patient. That is a general protocol. Second is a diabetic ketoacidosis initial management part, and third is a diabetic ketoacidosis follow-up part. So if we feel weight, his potassium level, his blood gas, his sugar level, and his weight, it will give its interpretation like this, that this child has a DKA and we should follow this protocol. We should give 0.9% of the normal saline at this rate for 1 hour, and the hydration should be at this rate with we shouldn't forget adding potassium in a hydration fluid, and correct insulin dose for this patient would be this, and how should we monitor this patient. And in follow-up also, it will say hourly, it will ask for sugar, it will ask for electrolytes, it will ask for pH, it will ask for ketone, and give the inference that you should continue with the same fluid or change the fluid, increase the dextrose level, whether child is at risk of cerebral edema, and how to immediately manage cerebral edema using the mannitol, and what is the dose, and what are the another things which needs to be done in hypokalemia, decrease the insulin level, and close monitoring of the potassium, like this. So this application will help pediatrician to stick to a protocol, and by this way we can prevent almost 40% of the cases of hypokalemia and 60% of the cases of hypoglycemia.
That's a wonderful initiative which Dr. Hemang did. Yesterday we were talking about the bone age application and how a pediatrician can do a bone age in 2 minutes. And today we've got this DK application, and this application is available as part of our MedEClasses app in both iOS and Android store. All you have to do is to put some inputs and you will get exact prescription. It's like your Dr. Hemang is always on call. You just put the data and he'll give you information what is to be done. And the wonderful part is that both of these are under publication in terms of the various journals. And the most important part is that both are the power couple who have done that. So one has made the bone age very easy, one has made the DK very easy. So I think hats off to the great couple who have done this wonderful job. Thank you, Dr. Hemang, for that.
So moving on to another case where we come with the management part of DK, a 10-year-old girl with a blood sugar of 540 milligram per deciliter and a base excess of 18 with a potassium of 5.8 and a pH of showing severe acidosis of 6.9 with dehydration of 10%. So how do you classify this patient and how do you manage Dr. Vijay?
Thank you, Naveen. So you can see the three parameters that this is the blood sugar is very high. That is 540, base excess is -18. So severe acidosis, pH you can see 6.9, and potassium is at borderline, that 5.8. So it can be tricky that at one point of time you are thinking that 5.5 potassium is a bit higher. But I want to say that previously we have already discussed that even in this case, after fluid resuscitation, we have to give potassium in the maintenance fluid unless and until the patient is having de-raised renal function test. So how to go about the case that first we have to, without any insulin, we have to do dilution method, that is normal saline fluid bolus 10 ml per kg. Then since this is a very severe disease, so we are going to manage in a very slow manner, that is about 48 hours. And we have to calculate the deficit to be fulfilled by 48 hours and the maintenance fluid by as SPAT protocols. And you can see here that 40, that is first 10 kg, 4 ml per kg, next 10 kg, 2 ml per kg, and the next that is 1 ml per kg. So maintenance fluid is coming to 70 ml per hour, and the deficit for every hourly maintenance is 65 ml per hour. So it is going to be 135 ml per hour. I'm not going to talk about the Braced Society Pediatric Endocrinology guidelines or say NICE guideline, because the inclusion of the patient were not so severe patients. So I'm not going to discuss that. So first, that is we have to give fluid therapy, and along here we have to take care of the precaution that our patient which can be.
Dr. Vijay, this is a very interesting aspect, because we always talk about fluid, how much fluid to give, normal saline or N/2, a big debate. Now in Western countries, especially in US, Nicole Glaser is a person who has done a lot of research on that, and they've come out with this study which basically says whatever fluid you give, whatever rate you give, doesn't matter. It doesn't have an impact on cellular edema. Do you agree that this is true for Indian setting as well?
No, definitely. I am not going to agree, because you can see that, and I really thank to Anurag sir and his team, that even if you are going to see that most of the cases are either in severe decay or maybe at the time of presentation, they are already in cerebral edema. So that thing is not going to see. And if you are going to see the children, that how they are going to, so younger the age, they are more prone to develop cerebral edema. Newly diagnosed patient, depending upon the setting, probably 30 to 70% cases can present with DKA, and blood urea nitrogen, that is high blood urea nitrogen, are surrogative to indicate that this patient might be in DKA. And the last, you can see that hyperventilation, that is low carbon dioxide, can be indicative for potential danger for cerebral edema. So all these things has to be seen, not only the fluid, because our patient setting and the presentation is quite different from the Western world.
I think that's a big message, that we cannot just blanketly follow the study, because if you look at the mean pH, here the mean pH was around 7.1. Our mean pH is around 6.9. That is the sort of thing. So in severe DKA, I would say still SPAT protocol is the best. Do not use N/2. You will have a rapid fall. Do not give too much fluid. That is not good. If you have a mildish DKA, you can manage in that protocol. It doesn't make a much difference. But remember, we have a high prevalence and a lot of people who got fluids outside. So you have to be cautious. That becomes relevant. So I would say outside treatment, pH less than 6.9, CO2 less than 10. Think of cerebral edema very importantly in our setting.
Thank you so much, sir. And moving on to the next case. Now, how would you monitor this case, ma'am, Dr. Prema?
In all cases, we know we have made the diagnosis and we have started the treatment. And we all know that the complications of decay are going to be, that is the one which is going to cause mortality. So monitoring becomes a very key part of our management. So if we just start the treatment and not monitor, we are going to land up in a lot of trouble. So the most important complication is, as we know, cerebral edema. So to monitor that, we have to keep an eye on the GC score. So we have to look into the sensorium of the patient, look and actually calculate the GC score every hour. So you have to see. And to look for cerebral edema, we have the early indicators, like you watch for the vitals. They could be increased in blood pressure, that is hypertension with bradycardia. So if you're seeing hypertension with bradycardia, you should be very alert about the cerebral edema. So that is one of the clinical signs. And the other clinical signs is, as I told you, the neurological signs. The neurological signs is you have to look in for the pupillary disturbances. You look for any cranial palsies or brisk refluxes, which also will suggest, or if the child is conscious, any headache, vomiting, those could even indicate signs of cerebral edema. So monitor early for neurological signs for cerebral edema. Then you look into the hydration status every hourly, so that you look like whether the child is hydration is okay. Look into the input output chart and also look for the urine output. It should be definitely more than 1 ml per kg per hour, because if there is a reduced amount of urine output, you have to look in terms of renal failure. Coming to the metabolites and electrolytes, very, very importantly, as we are correcting, we are giving a lot of fluids. We have to look into sodium and potassium. As we know, the next major killer is hypokalemia. So, and we know that the acidosis correction will be pushing the potassium into the cells. And as Dr. Anurag just told in the initial slides, that we have to give the correction for acidosis as 0.6 for every 0.1 reduction in the pH. So we have to be very, very careful about potassium. So you have to monitor serum potassium and sodium even secondarily initially. Then sodium, you have to, as already said, we have to look for the corrected sodium and also give. If you're seeing the reduction in the corrected sodium, that should also alert about cerebral edema. So these are the important things. The last thing is the ketones. So we know during monitoring, the blood glucose is going to come down, your acidosis is going to come down, and later your ketones are going to come down. So blood ketones are very important in monitoring. So we have to do the blood ketones in these patients, at least initially 4th hourly, then 8th hourly, it's mandatory to do. So by monitoring this, I think we can prevent the major complications, mortality from cerebral edema and hypokalemia, which are the most important things. And we can also rule out the other complications.
Thank you so much, ma'am. And moving back to our case, after 4 hours, we found that the blood sugar still remained high of 650 milligram per deciliter, and also acidosis was persistent with a base excess of 22. So what do you think went wrong with the management here, Dr. Prema?
Okay, as I told, like we are supposed to monitor any of these children with decay in the PICU. Here I'm looking at the blood sugar, which is still very high, which should have come down within quite quickly. And the acidosis also is almost is worsening. So probably we have to look into whether we have given the proper treatment. So whether the insulin has been diluted properly. So most of the time what we do is we instruct the sisters, and she might have not given diluted the insulin properly. So whether the insulin has been given appropriately, so we give 50 units and 50 ml. So whether they have diluted it appropriately, or whether it is insulin the tubings have not been flushed. And also we have to see if the child has other complications like infection and shock. So in these cases, we will not be able to correct our decay as quickly as we are anticipating. So I think in this, the pediatric PICU protocol we usually do at our centers, we do this vitals and then Frischmann type of monitoring the cases for all the emergency cases where you look into fluids, your F for fluids, and then R for respirations, I for injections, insulin or antibiotics, whatever injections you're giving. Then C is for cardiovascular system, H is for hematologic, M is for metabolic, A is for abdomen, and N is for neurologic system. So like that, if you just go through this pattern, we will not be missing, and we have to look into if we have left any of our management. Is there any fault in our own management of these cases? So I think if that is there, if it is corrected, we can achieve a better control in these children.
Yes, ma'am. And the flushing was not done properly, and it was done later, which the sugars improved after 8 hours, where the sugars came down to 190 milligram per deciliter, and acidosis also improved with the base axis falling down to 12. And now, how do we have to proceed in this case, Dr. Vikas?
Dr. Vikas, are you there?
Yes, thank you, Dr. Naveen. Am I audible now?
Yes, sir.
Hello. Basically, I was muted. So, if you look at the progress of this child after the admission of 8 hours, the sugars are 190, and still child is acidotic. Now, this is a tricky situation. As we have keep on discussing the thing, adequate hydration will lead to correction of hyperglycemia much before the acidosis. So your sugar will go down if you are addressing the issue of hydration very well. Even before insulin, your sugar will go down, and your acidosis will correct later on. But here, if you discontinue the insulin, you will have a case where the acidosis will be persisting. So you are supposed to continue the insulin, and you have to add the dextrose to avoid another complication, that is the hypoglycemia. So whenever you are managing a child of DKA, always have dextrose and mannitol at bedside. It should be handy with you. Without dextrose and mannitol, do not manage a child with DKA. Always add dextrose if your sugar is falling without discontinuation of the insulin, because if you discontinue the insulin, you are going to have a persistent acidosis and a problematic child. So continue with the insulin infusion, and if you have got your glucose more than 300, no need of doing anything. Between 200 to 300 milligram percent, add 5% dextrose, and 10% dextrose if sugars are less than 200 milligram percent. So addition of dextrose, and keeping handy with mannitol, reviewing your blood sugars, reviewing your pH, and continuation of the IV infusion of the insulin is the key message with this slide. Dr. Naveen?
Thank you, sir. Thank you for the wonderful explanation. And 10 hours later, his blood sugar slightly increased to 220 milligram per deciliter, and the base excess was on the same range of 11, and his potassium found to be fallen to 2.6. So what do you think went wrong, Dr. Hema?
In this case, I would like to check that whether potassium was added in the hydration fluid or not, first thing. And second thing, if it is added, then this potassium level is truly low. So first thing I would do in this case would to reduce insulin by half. And if it is less than 2.5, I would rather give potassium correction. I would check for the ECG changes. If it is there, then we must correct it immediately and stop the insulin.
Okay, thank you, sir. And after 14 hours, the child went into coma. So what could have happened to this child, Dr. Vijay?
Dr. Vijay? This child now had an improvement and then became worse. So this, of course, is something which we already talked about, a very serious condition. You have to think of a possibility of a cerebral edema. So what were the risk factors? He was severe, rapid fluctuation. Now, the key message here, which already has been discussed a lot with regards to the previous discussion, is that we should not wait for imaging. Do not give, we should immediately rush with mannitol. So cerebral edema is a common condition which we encounter, and this is Neha's paper which we were discussing. Most of presentation in our center were actually at the time of admission. And after that, we had very few. So it is something which can be prevented if we do a good management, but you should be aware that it can happen at diagnosis. The major risk factors, as I said, included three things: outside treatment, which was the biggest odds ratio, and the other was new onset versus follow-up. So new onset, because they were presenting late, had a higher chance of cerebral edema happening. And the key messages are that if you have severe metabolic acidosis, pH less than 6.9, CO2 less than 10, prior treatment, think of cerebral edema, and that becomes very, very important from that perspective.
So 20 hours later, the blood sugar were in range of 190, and we found that the acidosis was still persistent. The base axis remained to be 12, despite giving insulin and treating the blood sugar levels. So what could be the cause of this persistent acidosis, Dr. Prema?
Well, I think the blood sugar has come down very well, and thinking that in terms of we have given the right treatment as the sugars are coming down, but why we are having a acidosis still persistent. To think in those terms, we should think of the complications, as we were seeing like cerebral edema is one of the complications. So the other complications, as we are giving a lot of fluids in this patient, we should also think about the chloride load. Suppose if it is other causes like lactic acidosis or excess chloride in these patients. So if we are going to look into, next is the ketones. So if the ketones, how much was the ketones in this child? So if it was ketones are more, then we could.
Okay. It was 1.4.
1.4. So suppose if it was ketones were more, that means we are not still appropriately treating our decay. We will go in those terms. But if the ketones are less, that means our management of decay is fine, but there are some other complication. So we should look into the chloride level. So if the chloride level is about 32, then we should think of a hyperchloremic acidosis. If it is less, then we should think of lactic acidosis. So we should look into the chloride load only to change the fluid. We can think about in case if there is a hyperchloremic acidosis. So this is important message that if the patient persists to have acidosis, then we should think of other causes of acidosis rather than only ketoacidosis.
So thank you, ma'am. And after 28 hours, his blood sugar stabilized, which went to 170 milligram per deciliter, and his acidosis also improved with a base axis of 4, and he also regained consciousness, and he was taking on fluids and was allowed orally, and he was started with regular insulin of 0.3 unit per kg subcutaneously, and its fluid and insulin were stopped. So how do you taper the insulin, and how do you shift the patient to subcutaneous insulin, Dr. Hema? And we also found that the sugar after 2 hours were found to be very high with 560 milligram per deciliter. So what could have went wrong? So how do you actually shift the patient from IV insulin to subcutaneous, and what are the precautions necessary to be taken before the transition?
Whenever there is a resolution of acidosis and ketosis and child is conscious and now ready to accept orally, we are planning to shift the child on subcutaneous insulin. So I will allow the child to take orally, and as soon as he had meal, I will stop fluid, but I will not stop insulin. Just before meal, I will give definitely subcutaneous insulin, but I will keep insulin drip for half an hour to 1 hour continue, so that there will be a good overlap between the subcutaneous insulin and insulin infusion, and it will not result in the hyperglycemia laterwards. So
thank you. And we need to continue insulin, as you actually mentioned, and the patient was started on subcutaneous appropriately after then. And post DKA, he was actually managed on a sliding scale of 2 units per kg per day, and his sugars were extremely fluctuating. So what could be the cause of extremely fluctuating sugars, Dr. Vikas?
Thank you, Dr. Naveen. Basically, what went wrong with this child is that this child is post DKA, so the requirement is very high, and often sliding scales are not very helpful. We have to shift the patient from on basal bolus regime, and you have to give the basal insulin around 12 hours before starting your subcutaneous insulin. So if you overlap and give coverage of a basal insulin around 1 night before the stopping of IV infusion, this will help to maintain the sugars in a reasonable range. Secondly, to start with the subcutaneous insulin, try to have a basal bolus regime rather than a sliding scale insulin. And as the requirement is high, it can be as high as 2.5 unit per kg from 2 unit per kg. So this will take care of fluctuating sugars. always load with the basal insulin prior to stoppage of your subcutaneous insulin. And secondly, whenever you are calculating basal bolus regime, always try to give at least 40 to 50% in terms of basal insulin, which should be started around one night before switching over the basal bolus regime as compared to the insulin infusion. This is very, very important. Secondly, whenever you are planning the discharge, I would like to add around one or two things, which is very, very important. Always try to explore what was the reason for DKA in this child. Whether sick days management has been given, I'm going a bit extra, whether sick days management has been given or not, because I've been seeing the sick days management has not been discussed in many of the endocrine clinics. Always try to spend 1 minute about the sick days management of a child. We should see whether the child was on pump. So talk about the pump malfunction. Try to find out what lead to this episode of DKA. This will help in a long way to prevent further episode and recurrent admissions of the child with DKA. This is very, very important to explore the factor which will lead to DKA, and sick day management protocol should be discussed with the before discharge. Am I right, Dr. Vajpayee? Agree with me?
Absolutely perfect. And that was a wonderful conclusion to this wonderful session. Just a quick word about the overview in terms of DKA management. When we are managing a child with DKA, we are walking a tightrope. We have an option of doing too much. We can give less fluid. We will cause dehydration. If we give more, we will cause cerebral edema. If we give too little insulin, we will wait for a few more hours. If we give too much insulin, we may cause death because of hypokalemia. Now, everybody will agree that it is always better to do little, causing less complications, even if it takes there is more time. We should not go ahead with too much fluid, too much insulin, because that can cause a lot of problem and it can actually be fatal. So I think this was a wonderful session. I have to thank all the panelists who were part of this session, Dr. Vikas, Dr. Vijay Jaiswal, Dr. Hemang, and Dr. Prema for this wonderful discussion. Dr. Naveen discussed it very nicely. So I think this was a very, very interesting and a very, very important emergency to discuss from that regards. I think there is one question which we'll take now, flushing the tubes with using insulin. Now, there is a bit of a confusion. We will still say that better would be to flush the tubings, because why leave a doubt? Because if you have a doubt, some people say that it is not going to make a huge difference. Yes, if you are using a high dose of infusion, but if you have a low dose of infusion in young children, it may cause confusion. So better to flush it. What is the harm in flushing? It is always better not to err in the side in which you can later on, you could have easily done that. So I think that's an important point from Dr. Robert Hamilton. We'll now move forward to the last session. And after that, we'll have the interesting quiz, which is going to happen. So this last session is about too little. We talked about too much, which was DKA. Now this will be more of hypoglycemia. So this is going to be a very interesting session, and it will again will be lastly a case-based session. And in this session, we've got three eminent panelists who will join us, and we'll have Dr. Manoj, who will be our fellow, who will be working in terms of the oral discussion points in that regards. So for this session, we have got three eminent panels. So we'll just share the screen. I think it's going to be shared now. We have got three eminent speakers. Dr. Riaz, who is a close friend of mine for the last 10-15 years. He is the associate professor in pediatrics at Government Medical College, Trivandrum. Dr. Modita Dhingra, eminent pediatric endocrinologist from Haryana in Kurukshetra, and Dr. Deepak Gupta, who was actually my junior at AIMS when I was a senior resident, and he is now doing a very nice job in terms of the pediatric endocrine as well as pediatric practice in Janakpur, Nepal, as well as working in the Janki Medical College. We will also have Dr. Manoj, who will discuss about the few cases, but we'll start off basically with a few words about hypoglycemia. Now, we know that glucose is the major source of energy, and the three most energy gulping organs in the body are the brain, the muscle, and the heart. Now, glucose is the major source for all of this. There are alternate sources of energy which are also available, like ketones, which the brain can use. So if you have got less glucose, ketones will work. In conditions where ketones are also gone, the brain will have a severe damage. So if you have somebody who has hyperinsulinism, your ketones will be low. At the same level of hypoglycemia, let's say 30 milligrams per DL, they will be much worse off if we compare them to somebody who has got a glycogen storage disease in which the ketone levels are high. So ketosis is an important defense mechanism. In that regards, fatty acid is more for muscle and heart is not there for brain. We are mainly talking about brain because that's where the most glucose is used. Now, glucose homeostasis is very easy to understand if we consider it in the form of how we manage our finances. So we get money. So glucose is like money. We get the money, we take it, and then we tend to spend it maybe on the brain, some other functions. We are buying some things, and remaining, we start to deposit that in that perspective. And the most important bank that we are depositing is actually the liver. Now, liver is a readily available glucose source. You put the money in your savings account, you take it out. So it's like a very quick transaction. You just need an ATM or maybe a UPI or whatever, and you will get your glucose out. Now, if you have got too much of glucose, you will start storing in other places. You will go and store in the kidneys, which will basically be in the form of proteins. And from there, you will need to have gluconeogenesis to get that. And finally, too much glucose will go into your fat. And then finally, you will have it in your muscle. This is your last store in that regards. Now, in conditions where you are eating, you will basically store it, but when you are not, body will start giving you. So your first resource will be your ATM card. Liver will give you out the money, and this glucose you can use. Now, once you exhaust that part, you will start acting at the level of the kidneys, wherein you will have the gluconeogenesis, which is going to happen. This happens typically around 12 hours and beyond. Glycogenolysis happens 6 hours and beyond. So anybody who is eating every 2 to 4 hours is not going to develop hypoglycemia because of this glycogen defects. And these defects typically present when the gap increases from around 6 hours. That is typically around 6 to 12 months of life. So if you have got a neonate with hypoglycemia and hepatomegaly, do not think a possibility of GST. It may be hyperinsulinism. It may be a real possibility of galactosemia. Secondly, the fructose defects will present later because now the gap will be like 12 hours and more. So they will present beyond 1 year of age. And after that, you have got compensation in the form of ketones. And finally, you will have compensation in the form of the muscles, which are the last to burn in that perspective. Now, we have got very important hormones which control that. We have got insulin, which is produced by the beta cells, which causes everything to decrease glucose, right from causing more synthesis to less release, to inhibiting gluconeogenesis, to inhibiting lipolysis, to inhibiting the ketogenesis. And then you have got 4 counter-regulatory hormones who have got different actions. We have got glucagon, which is going to cause glycogenolysis. So glucagon is always active if you have hypoglycemia. What it means is that if you have hypoglycemia and you give extra glucagon, there should be no response. But there could be one condition in which you will still have a glucagon response, and that would be, so if your insulin is high, glucagon will respond. So this is a diagnostic test for hyperinsulinism. You also have growth hormone, which is a lipolytic hormone, which will allow fat to burn. You also have got adrenal producing cortisol, which causes gluconeogenesis, and epinephrine, which causes glycogenolysis. So there are 4 hormones which are counteracting the effect of insulin, which means that if you have deficiency of one, you are not going to have hypoglycemia, and therefore there is a redundancy. You need to have a multiple hormone deficiency in which then only you will have hypoglycemia, while insulin excess will cause hypoglycemia immediately in that perspective. And this is very important to understand. So now when you are assessing a child with regards to hypoglycemia, you have to look at what will happen in the setting of hypoglycemia. The first thing which should happen is you shut down your insulin. Insulin should be 0 in a child who has got hypoglycemia. If you have a detectable insulin, that is significant. Number 2, cortisol and growth hormone should be maximal. So as we were discussing, if cortisol is less than 550, growth hormone is less than 10, it is inappropriately low for the context of hypoglycemia. Everybody with hypoglycemia should produce ketones unless there is high insulin, there is a fatty acid oxidation defect, or there is galactosemia. So ketones, we talked about phosphorus being most important in hypocalcemia, potassium being most important in hyponatremia, blood gas being most important in hypokalemia, ketones is the most important investigation in the setting of hypoglycemia. So endocrinology is easy. Pick your one investigation, which will guide you, classify you in that perspective. So if you go now, hyperinsulinism means very high glucose requirement and low levels of ketones. Fatty acid oxidation defect would mean intermittent presentation, late onset, low ketones. GSD will present after 6 months of life, which will be a ketotic hypoglycemia with or without lactic acidosis. There will be hepatomegaly. Endocrine deficiency will cause ketotic hypoglycemia without lactate, while ketotic hypoglycemia is the diagnosis of exclusion. Organic acidemias are rare in that perspective. So if you now look at ketone is the key investigation. If you have hypoglycemia, ketone should be more than 2. And I am saying ketone, I mean blood ketone. That is better as compared to urine ketone. If ketone is less than 2, think of hyperinsulinism or a fatty acid oxidation defect or rarely galactosemia. Lactate is high specifically in GSD1 and fructose 1,6 bisphosphatase deficiency. pH, as discussed, you will have acidosis in these two settings. Insulin, again, any detectable insulin means hyperinsulinism, and glucagon test will only be positive in the setting of hyperinsulinism. There is one more situation in which glucagon response test will have a role, that is in differentiating GSD1 from a gluconeogenic defect that basically happens in the setting of a fed state. So in a fed state, if you give glucagon, your acidosis will worsen in GSD1, it will improve in gluconeogenic defect in that regard. Now the approach, of course, is very clear. Look at ketones. If ketones are low, you're dealing with 3 conditions. Look at urine reducing substance, positive, galactosemia. Reducing substance negative, look at insulin. If it is undetectable, it is fatty acid oxidation defect. If it's detectable, it's hyperinsulinism. If ketosis is present, lactate will diagnose GSD1. If lactate is normal, go for organomegaly GSD3 and 6. And very importantly, measure growth hormone and cortisol before you diagnose ketotic hypoglycemia. So like we said, when you diagnose SIADH, do a cortisol and thyroid. When you diagnose accelerated starvation or ketotic hypoglycemia, do a GH and cortisol. So we'll now start off with right in the first case, Dr. Manoj.
Thank you, sir. Let's move to the our first case. 6-hour boy referred from the NICU. Patient having blood sugar of 36 milligram per deciliter. Dr. Riaz, what do you think? It is hypoglycemia or not?
A neonate with low sugar is always something very alarming to the neonatologist or the pediatrician. And we all know that there are a lot of controversies regarding what is hypoglycemia or what is low sugar in a neonate. And before going on for the actual cutoffs, we should be aware of the settings where we can have these low sugars. Babies who are having some insult at birth, like birth asphyxia, a baby already had some amount of intrauterine growth restriction, a baby who is born to a mother who was diabetic, a preterm baby. So such babies are taken as babies who are having risk factors. And when we look at the values, we know the operation thresholds, that is the points where we should act or where we should correct the hypoglycemia, is actually related to the age of the baby in hours. So we can see that up to 2 hours or up to 3 hours, even 25 is enough. And from around 4 hours to the first day, it is actually less than 35 is considered as hypoglycemia. And above that, less than 50 is considered as hypoglycemia. And after 48 hours, we actually need to maintain the sugars more than 60. And when we say this, do all babies who are having this low sugars need a workup? No. These babies need action when they have a low sugar, but they need extensive workup if the hypoglycemia persists beyond 48 hours, or if the baby needs a high GAR. Usually we know the GAR will be somewhere near 8, but if we are seeing that it is rising, then we need to act. And I have enumerated some risk factors. If we see that these babies are having hypoglycemia without any of these risk factors, That means we need to find out what is happening. So these are the babies who we need a detailed workup. And so for this baby, there is no need of a detailed evaluation. This is a case of transitional hypoglycemia, which may improve by its own by feeding properly and encouraging the mother to continue the breastfeed, but keep a watch out for the persistence of the symptoms. Thank you.
Thank you, sir, for guiding us. This is not hypoglycemia. Actually, we have to see for age. What is the glucose value according to age? So next, our next case, 3-week-old boy presented with a seizure. Blood sugar was measured. That was 28 milligram per deciliter. We did genital examination showing micropenis. So Dr. Mudita, is it isolated hypoglycemia or anything we are missing in this case?
Yeah, good evening, everyone. See, so this is a 3-week-old boy with severe symptomatic hypoglycemia, and we have micropenis in the clinical presentation. Other details which we need to see in the clinical picture is any other midline defect, for example, any presence of cleft lip of cleft palate, and eye examination also. So coming to the biochemical workup, at the time of hypoglycemia, which means during the critical sample collection, we first need to see the ketones level and blood ketones level. So here we can see that the ketones are present. It is 2.3. And the next test which is relevant is the lactate level. So Dr. Manoj, the lactate is normal here. And we can see the sodium is lowish. It is 128 with normal potassium. So the next step, as per the approach pathway, we need to see is there any organomegaly?
No.
So
no, there is no.
We do not have any organomegaly. And in the critical sample, later on the reports came out to be growth hormone of 4 nanogram per ml and serum cortisol of 125 nanomole per liter. So these are definitely low in the setting of stress, which is hypoglycemia. And therefore, we have two hormonal deficiencies, growth hormone and cortisol. So this is a case of multiple pituitary hormone deficiency. So moving on to the management of this case, we also need to look for other hormonal deficiency, for example, free T4 level and prolactin level, and manage accordingly. The first hormone to be replaced in this case will be hydrocortisone for cortisol deficiency. And if there is associated thyroid hormone deficiency, we need to add up Thyronorm a couple of days later. And the key message here would be any newborn presenting with micropenis with hypoglycemia, we should keep in mind the diagnosis of multiple pituitary hormone deficiency. And in this child, although the cortisol was normal as per the lab range, but when we interpret it as per the clinical condition or in the critical sample, it is definitely low. So this is a newborn baby with multiple pituitary hormone deficiency and managed.
Thank you, ma'am.
So most of these babies will not require growth hormone in the initial newborn period, and later on we will be adding growth hormone.
Thank you, ma'am, for guiding us. It is not isolated hypoglycemia. It is due to the MPHD. Now, third case, we have 10-day-old girl presented with the hypoglycemia. Patient was on glucose infusion rate that was higher side, 40 milligram per kg per minute, and that was non-ketotic hypoglycemia. Ketone is 0.1 millimole per liter, and patient having reducing substance negative. So we are ruling out galactosemia in these cases. So Dr. Deepak sir, what is your opinion regarding this patient?
Okay, good evening, everyone. So may I know some bit of details about the history? What is the birth weight, gestation, any perinatal events?
Okay. Patient having normal birth weight.
Okay. Any other maternal problems like diabetes?
No family history of diabetes is there.
Okay. On examination, is the baby macrosomic or any hepatomegaly?
No, birth weight is normal.
Okay, so clearly we can see this this newborn is requiring very high glucose infusion rate along with low ketones. So straight away it points towards either this child is having hyperinsulinism or galactosemia or fatty acid oxidation defect. But galactosemia is very unlikely because urine reducing substance is negative. So probably we are dealing with hyperinsulinism. So we can do further investigation. The best will be bedside glucagon response tests. In that we can give 1 milligram per kg IM or subcutaneous glucagon and see the response. If the blood glucose rises more than 30 milligram per deciliter after 30 minutes, this confirms probably this child is having hyperinsulinism. So there are other. Yes, please go ahead.
What could be the criteria for diagnosis?
Okay, so basically any child who is having hypoglycemia, along with that any detectable insulin or above insulin level more than 2 microunits per ml or C-peptide above 0.5 nanogram per ml, basically indicating high insulin or low ketones. Ideally, we should have ketone in any hypoglycemia, but in hyperinsulinism, because of the decrease in the fatty acid oxidation, ketone will be low and there will be high glycogen storage in the liver. So if you give the glucagon, there will be high glucose output from the liver. So there will be positive response. So any child, any neonate who is having hypoglycemia with high insulin, detectable insulin with positive glucagon response, so probably we are dealing with hyperinsulinism, and we'll need further investigation to type the type of hyperinsulinism.
And key message from this case?
Okay, so any infant or newborn who is having hypoglycemia, there is no business of insulin to be there in the blood. If insulin is detectable, we are straight away dealing with hyperinsulinism, other than galactosemia and rarely fatty oxidation defect.
Okay, thank you, sir.
Thank
so we have another case. 6-day-old girl presented because of the hypoglycemia. Birth weight is 3.4 kg and ketone was negative 0.6 millimole per liter and GIR was high 12 milligram per kg per minutes, and we did reducing substance that was negative. Insulin detected 3, growth hormone is lower side 3, and cortisol is 120.
So I think this is a very, very common and interesting presentation, Dr. Riyaz. We have got a child with non-ketotic hypoglycemia, high GIR. Insulin is also detectable and cortisol is low. Now the question that Dr. Manoj is asking is it hyperinsulinism or is it predominantly cortisol deficiency? That's the billion-dollar question here.
Yeah. This is a very, very interesting case scenario. Like we have a probably a baby with a higher side of weight and ketones are low. So these two are pointing, and high GAR, all these are pointing towards a hyperinsulinism. And we know that the reducing substance is negative, so that rules out galactosemia. So we are thinking that this could be a hyperinsulinism. But when we are looking down, we can see that the insulin is only 3. So is that 3 enough? So that is one question will comes to our mind. But any level of detectable insulin when there is hypoglycemia is abnormal. So we should take that message very clearly. When there is hypoglycemia, there should not be any insulin at all. So a detectable insulin directly points towards hyperinsulinism. But we are again confused. Our Mudida madam had already explained that when there is multiple pituitary hormone deficiency, there can be hypoglycemia. And you are seeing that the cortisol is low and GH is also low. So is it possible that way? But we should also know it is not a rule always. We usually expect a high cortisol in any child with hypoglycemia as a part of the stress response. We know the counter-regulatory hormone should be active when there is hypoglycemia. And if the hypoglycemia, if the cortisol is not rising, we should again think about a multiple pituitary hormone deficiency. But here what happens is because of the continuous exhaustion, continuous hypoglycemia, there can be exhaustion of the adrenals and the cortisol can still remain low. And here comes the help of our glucagon response, because glucagon response is something very particular to our hyperinsulinism. If you are giving glucagon and you are getting a rise of 30 milligram of glucose, that gives us the answer that it is hyperinsulinism and nothing else. Next slide, please.
Yeah. So the key message, I think this was a very important message of exhaustion response which have happened. So Dr. Riyaz, I think the key message is that high GIR is more important in this setting. And cortisol exhaustion may happen in this regard. Very nicely put by Dr. Riaz here.
Thank you, sir. So we have another case, 2-day-old girl presented because of the seizure, and at that time blood glucose was lower side, 24 milligram per deciliter. It was a non-ketonic hypoglycemia. Ketone is 0.1, and reducing substance is negative. So galactosemia is out. Insulin was detectable. That was 6. And Dr. Mudita, how you will proceed for this case?
So as we can see, this is only a 2-day-old girl with severe symptomatic hypoglycemia and which is non-ketotic. So in this case, we need to ask detailed birth history and maternal history. So the first and foremost important thing is to ask the birth weight of the baby. So here, Dr. Manoj, can you specify the birth weight of the child?
Yes, birth weight is 4.4 kg.
Okay, so this is an LGA baby. So in LGA baby with hypoketotic hypoglycemia with detectable insulin level, this is definitely a case of hyperinsulinemic hypoglycemia, but we need to look into the etiology in detail and ask for maternal details. So yes, we have come up here with maternal HbA1c, which is 8%. So the mother was diabetic, and this baby has transient hypoglycemia because of being an infant of diabetic mother. So in this baby, we need to look for other complications in an IDM baby. For example, from endocrine perspective, we need to look for hypocalcemia, hypomagnesemia, and hypoglycemia. And we also need to look into other malformations. For example, the heart malformations, we'll do a 2D echo, and renal malformation, small left colon syndrome, and we will look for the neural tube defects. So comprehensive examination and detailed clinical history is very important in interpreting any baby with hypoglycemia. So this baby will probably not require any permanent treatment because this baby is an infant of diabetic mother with early onset of hypoglycemia and will probably improve within a week after birth.
Thank you, ma'am. So we have another case, 40-day-old child presented referred to us because of the patient having birth asphyxia, and patient admitted in ICU, and blood sugar was 28, and GIR requirement was high, that was 14 milligram per kg. Ketone was negative. Insulin is detectable at that time, that was 4.2, and child having birth weight is low, 1.6 kg. So Dr. Deepak sir, how you will proceed for this case?
Okay, again, this newborn is having investigation suggesting hyperinsulinism. Can you go back this? Can you please? Okay, again, this newborn is having high glucose requirement and low ketones along with detectable insulin. All these suggesting this child newborn is having hyperinsulinemia, but the point is the birth weight is only 1.6 kg. So some may wonder why this newborn who is having only birth weight of 1.6 kg should have hyperinsulinism. Generally, we think that hypoglycemia is because of the low store. So this newborn is having basically 3 hits. One hit is because he is SGA and is having low store. Second is he is having birth asphyxia, which can transiently lead to hyperinsulinism. And third, he is having I assume he is term baby, so he is a small for gestational age baby, which again itself can lead to prolonged hyperinsulinism. So all these 3 mechanisms can easily explain the hyperinsulinism is in this newborn. So can you tell me what is this child having, lactate and other things, any other issues?
Lactate was negative, sir.
Okay, so this child is this newborn is basically having hyperinsulinism, persistent hyperinsulinism because of the SGN, not because of the low store, because low store will explain hypoglycemia only within the 7 days. He is already around 14 days, so basically he is having hyperinsulinism because of the small for gestational age.
On follow-up, this child came after 2 weeks. Patient was on diazoxide 10 milligram per kg per minute, and we reduced GIR. Patient having complaint of weight gain and edema is there. So I want to ask to Dr. Riaz how you will manage this patient regarding the edema with diazoxides.
So we should all know that diazoxide can sometimes cause salt and water retention. And especially in newborns, it is always better to add with the diazoxide a dose of thiazide because that can avoid this fluid overload. And diazoxide also has other side effects like hypertrichosis, which is very common. We should alert the parents regarding the hypertrichosis because it will be very worrisome for them if you don't tell them initially. And it is always better if you continue diazoxide for longer time in children who are having persistent hyperinsulinism to look at uric acid levels, as well as to watch them for neutropenia as well as thrombocytopenia. And furosemide should be avoided in this case. So the key messages in this case is this prolonged hyperinsulinism is very well known in SGA. Usually, we may be able to taper off diazoxide in a period of 3 to 4 months. But diazoxide for a short term will be very helpful in managing hypoglycemia in this cohort of children.
Okay, thank you, sir, for guiding us. We have another case, 15-day-old girl presented with the hypoglycemia. Birth weight is 3.2 kilogram, a high GIR requirement that was 14 milligram per kg per minute, and ketone was detectable 1.1 millimole per liter. Insulin is detectable 3.3. And Dr. Mudita, how you will evaluate this case?
Yeah, so this is a 2-week-old baby girl with hypoglycemia and a normal birth weight. The next more important point here is the GIR requirement. The GIR requirement in this baby is 14 mg per kg per minute, which is very high, and which suggests the diagnosis of hyperinsulinism. And also we have detectable serum insulin level in the critical sample. So this baby was started on with what treatment, Dr. Manoj?
Diazoxide.
Yeah, so the response to the diazoxide was seen in this baby, and we also checked ammonia level, which gave us the diagnosis of hyperammonemia and hyperinsulinism syndrome, which is because of the mutation of glutamate dehydrogenase enzyme. And we can see here that these cases are usually mild cases of hyperinsulinism. And we also must keep into mind that the serum insulin level does not guide us that this is the case of mild or severe hyperinsulinism. Any detectable insulin will give us the diagnosis of hyperinsulinism. And it is the response to drug which gives us the diagnosis that it is a mild case or severe case. So diazoxide response is the key in these cases, and usually they do well. And it is also important to measure ammonia level in the milder forms because it will guide us in the genetic tests.
Let's move to the another case. We have 6-month-old boy presented with the lethargy, and blood sugar was 36 milligram per deciliter. Dr. Deepak sir, will you guide for this patient?
Okay, so can you briefly mention whether this is the first episode or this is the recurrent, whether this occurs only in the early morning or it occurs any time of the day? Can you please explain
yes,
a
this is
little
the
bit?
first episode. There is no significant NICU history. There is no neonatal hypoglycemia.
It occurs any time of the day.
Okay, so basically now we are dealing with post-neonatal hypoglycemia. So any hypoglycemia which occurs during or after the neonatal period is significant. We should not neglect, though during this age accelerated fasting could present, but we should work up this child to find out what is the cause. So can you tell me what is the ketone level so that we can proceed further?
2.4. Ketone
Okay,
is 2.4.
so basically now we are dealing with ketotic hypoglycemia. So what is the next lactate level?
We did lactate, that was 10, higher side.
Oh, okay. So now we are dealing with ketotic hypoglycemia with hyperlactatemia. So what is the appearance of the child? Any organomegaly, any cherubic
On examination, child having hepatomegaly is there.
Okay, so this straight away points us towards either this child is having GSD or fructose 1,6-bisphosphate deficiency.
So what will be the key message regarding this case?
So any child who presents after the neonatal period should be taken seriously, and all efforts should be taken to rule out organic cause before we label this child as having idiopathic ketotic hypoglycemia. And particularly if there is hepatomegaly, moon-like faces, we should not miss that.
Thank you, sir. We have another case, 3-week-old boy presented because of the failure to thrive. Blood glucose is 30 milligram per deciliter. GIR requirement is 6. Patient having hepatomegaly. So, Dr. Riaz sir, how you will evaluate this patient?
Yes, for any pediatrician, when such a baby is coming, our diagnosis is a failure to thrive, and it can be due to a feeding problem. That is what we think of first. And whenever we see hepatomegaly, also we think that in malnutrition also hepatomegaly can be there. But it is always better to do a ketone level when we are seeing a hypoglycemic baby, even though it is part of a malnutrition or a failure to thrive. And also to do basic screens, like just doing a reducing substance. Here we are having an answer because reducing substance is positive in this case. So from our algorithm, it goes to the ketones are actually low, and when ketones are low, there are only 2 or 3 DDs we have, and when the reducing substance is positive, we directly go for galactosemia. So galactosemia is something which is worth understanding or worth finding out early in life, because we can substitute the diet and we can have a better life for the baby. Otherwise, it can be very devastating. Here, the hepatomegaly is one clue, and reducing substance, the presence of reducing substance is the next clue. And as we know, if we feed these babies with lactose again and again, the hepatomegaly will increase, the failure to thrive will become more severe, there can be cataract, jaundice, and eventually the baby will lose its life. So identifying a galactosemia from this hypoglycemia is very, very important. Thank you.
Okay. Thank you. So one patient referred from the pediatrician, a child having 1 year of age, and patient is not able to walk in the morning. Blood sugar is lower side, 24 milligram per deciliter. There is no any hepatosplenomegaly. So Dr. Mudita ma'am, what you will think about this patient?
So this child is presenting at 1 year of age. So at this age, usually the gap of feeds is increased from around 8 to 12 hours. As you have already mentioned that the child does not have any hepatomegaly. So the glycogen storage disorders are ruled out. So the next key investigations are the ketones and the lactate. So here we can see ketones are present and the lactate level is normal. And there is no organomegaly as already mentioned. So in the critical sample, as we can see here, there is appropriate response to growth hormone and cortisol. So cortisol is more than 550 nanomole per liter and growth hormone level is more than 10 nanogram per ml. So this is probably a case of accelerated starvation, which is usually seen in children who are SGA at birth and thin and lean children. So usually they present with the symptomatic hypoglycemia in the morning hours when the fasting is prolonged and around 1 to 5 years of age. Usually it recovers at around 5 to 9 years of age automatically, and the only treatment which is required is supplementation of extra snack given at night time and avoiding prolonged fasting. So we also need to keep in mind that accelerated starvation is the diagnosis of exclusion. So all the investigations have to be done before labeling the child with accelerated starvation. And yes, as we have mentioned here, that the key message here is that the child had ketosis with normal lactate, and we have already excluded growth hormone and cortisol deficiency in this child.
Thank you, ma'am, for your outputs. So our last case, 2-year-old boy presented because of the failure to thrive. Patient having vomiting, lethargy, and RBS is 28 milligram. Ketone was detectable 3.2 and lactate was normal 1 millimole per liter. Patient having accelerated starvation. So Dr. Deepak, how you will proceed for this patient?
Do you agree that this is also ketotic hypoglycemia in this case, or there's some confusion here?
Sir, there is some confusion because this child is having very low blood sugar and there is ketosis. But before labeling accelerated starvation, we should do the thorough history, physical examination, and investigation to label this child. as we did the examination in this child, we found that there was some pigmentation and cortisol was very low. That was 150 only. So if we label accelerated starvation without doing investigation, we will miss this important diagnosis and child will die in near future. So before labeling any child who is having accelerated starvation, we should do thorough history, physical examination and investigation.
So what will be the key message regarding these cases?
So before labeling any child who is having ketotic hypoglycemia as accelerated starvation, we'll miss many important causes, particularly endocrinopathies and milder form of GSD. So we should do the thorough investigation before labeling any child who is having ketotic hypoglycemia as accelerated starvation.
Thank you, sir, for your output.
Thanks a lot, all of you, for this wonderful discussion, which was there on this very difficult and complicated topic. Thanks a lot, Dr. Riaz, Dr. Deepak, Dr. Mudita, and Dr. Manoj for making this really very interesting and intriguing. So now we are exactly heading towards the most exciting part of the day. We are going towards the quiz that is going to happen now. And this quiz was something which was very interesting for me to both plan, execute, and implement. And we've got 6 finalists who are there with us. So before we really go on to quiz, we'll probably ask them to introduce themselves. Dr. Savar Agarwal, a lot of us know you. Please introduce yourself, sir.
I am Dr. Savar Agarwal, a senior pediatrician in Ekta Institute of Child Health, Raipur. I have done my PG from PGI Chandigarh way back in 1980. And since 1983, I'm in practice. Our institute is a unique group practice model, which was unique when it started. We have been in, to this for last 20 years now. And we have a DNB program, which is running for last 18 to 20 years.
Thank you, sir. And it's really inspiring to see you here and continuously learning different aspects of life and helping others by that. Thank you, sir. We have got Dr. Ahmed, who is from Banaras Hindu University, Varanasi. Dr. Ahmed, please introduce yourself.
Good evening, sir. Myself, Dr. Ahmed. I did my MBBS and MD from Aligarh Muslim University. At present, I am doing my DM from Banaras Hindu University. I feel privileged to be part of quiz.
Thanks. And we really appreciate your participation in the program. We've got Dr. Ramiz, who is with us from Madurai. Dr. Ramiz, please introduce yourself.
Sir, I am Dr. Ramiz Raja. So I am from Madurai. I completed my MBBS and MD General Medicine from Madurai Medical College. I am also doing DM Endocrinology from the same institute, Madurai Medical College. Thank you.
Okay. Thank you, Dr. Ramiz. We've got Dr. Devaditya Das, who is from Kolkata. Dr. Devaditya, please introduce yourself.
Hello, everyone. I'm Dr. Devaditya Das. I'm from Kolkata. I did my MBBS from Calcutta National Medical College. Subsequently completed my DNB in Pediatrics from Apollo Gleneagles Hospital, Kolkata. Currently, I'm in 3rd year pursuing my DM Endocrinology in Institute of Postgraduate Medical Education and Research. I have a keen interest in Pediatric Endocrinology. And I really feel honored to be in the finals in this quiz with my friends Ramiz Ahmed and respected sirs like Savar sir. So yeah, really excited.
Thank you, Dr. Devaditya. We've got Dr. Arun George, who is from CMC Vellore. Dr. Arun, please introduce yourself.
Good evening, sir. I'm Dr. Arun George. I did my MBBS and MD in CMC Vellore and currently working as senior resident in pediatrics in CMC Vellore. I'm really privileged to be part of the finals of this quiz. I've learned so much of pediatric endocrinology from you, sir, over multiple programs that you have organized. I'm very privileged to be part of this competition with such stalwarts competing against me. I'm probably the junior-most and the weakest of them all.
No, I think everybody will be going to be a very good quiz. It was very competitive. We'll talk about that a bit later. Dr. Arun, welcome. We've got Dr. Sanju Joseph from Kerala. Dr. Sanju has been part of our team as well. So Dr. Sanju, please go ahead.
Good evening, sir. In the onset, let me thank you, sir. You've been the guiding point, actually. You taught me a lot about pediatric endocrinology. I completed my MD from Government Medical College, Kottayam. And after that, I've joined as a consultant in pediatrics in St. Thomas Hospital, Changanasheri. since I'm working in this hospital. I'm really interested in study endocrinology, and you're really a great teacher, sir.
Thank you, Dr. Sanju. And we'll start off with the details about the quiz, and then we'll start directly with the quiz from there. So just to share a bit details as to how this quiz was planned and how it came out. So this quiz actually happened at 2 steps. First for the prelims round, which happened a couple of days ago. We had 120 participants from 12 countries, highly competitive quiz. There was a tie at 2nd and 3rd spot. And if you can see, this was the normal distribution, which we saw as far as the histogram is concerned for the quiz in that perspective. I'll request all the people to please keep their mic on mute unless they are on the specific question is being asked to them, so that it becomes easy for us from that perspective. Now, finalists, we all know we got Dr. Devaditya Das, who actually scored, I think, 20 points out of 25. So he deserves a big round of applause. We got 3 people who got Dr. Ramiz and Dr. Ahmed scored 19. And then we have got Dr. Savar, Dr. Sanju, and Dr. Arun all got 18. So it's a very, very close. Within 2 marks, we have got a huge separation out of 25. So this was a very good, it was a tough quiz, but it was really cracked very nicely by the individual. So the first prize for this quiz is actually a complete subscription of our advanced pediatric endocrine course, both online and on-site, which comes with our advanced combo of books and complimentary application, which is available for the 2-year period. This is worth 60,000 rupees. The second prize is the subscription for basic pediatric endocrinology online on-site, which also comes with the basic combo of books, the pediatrics application worth of 30,000. And we've got the prize for all the other finalists as well, our subscription to the adolescent endocrinology course, which has 25 modules, along with the mobile application for a period of a year from there. Very importantly, we got a lot of audience and participation across the country, and there were 3 major groups from which participation happened. We have got the postgraduate trainees, the endocrine trainees, and the pediatricians. And of course, the experience level and the level at which they were working was different. So we have also shortlisted the prizes for the best performing postgraduates. We'll give the list at the end of the quiz, who will get 30% discount in a postgraduate course, which is a 3-year course. This is quite helpful for the postgraduates. For the best performing pediatricians, we have a special discount on pediatric endocrinology course, as well as for endocrine training. So there are 3 groups which we'll announce at the end of the group. So just wait and hold on to that. So I think before we just start off with the quiz, we just have a quick rules which are there in that regards. And the rules basically are that we will have 5 rounds in total. There will be 4 rounds in which direct question will be asked, and 1 would be the buzzer round. We'll talk about the buzzer round a bit later. Every question, direct asked question, will be 10 marks, and 5 will be for the pass. And from there, 15 seconds will be there for answer, and only 1 answer can be given. So you think about it and then answer. If you can't change your answer from there. Now, the quiz master's decision, of course, and quiz master is me, so my decision will be final. That's pretty much it. Can I have a list so that I can use the sequencing in terms of the questions? What we'll do is that we will use a reverse cycle. So we'll go 1 to 6 and then 6 to 1. This is the way we'll go. So we'll start off with Dr. Devaditya, Dr. Ramiz, Dr. Syed, Dr. Samvar, Dr. Sanju, and Dr. Arun, and then go back from Dr. Arun to the back. This is how the rounds will go forward. So I think everybody is ready. Is everybody ready?
Yes, sir.
Yeah. So the first question would be to Dr. Devaditya. So Dr. Devaditya, your question is, there is a 1-year-old boy. So listen to the question carefully. They're all clinical questions, and we will ask a specific answer. 1-year-old boy with failure to thrive in polyuria. Weight is less, length is less. Blood pressure is on the higher side for the age. There is hypokalemia. You can see potassium is 2.1, and there is alkalosis. So there is hypokalemic alkalosis. ACTH is normal. Cortisol is normal. The question is, and you got the reports also, more help. PRA is undetectable, aldosterone is undetectable. So hypokalemic alkalosis with no PRA, no aldosterone. The question is, response to which drug can help you establish the diagnosis? Dr. Devaditya.
I would say the diagnosis is Liddle syndrome. So giving amiloride and seeing response will establish this diagnosis.
Okay, amiloride. Any other drug?
Trimterine. also can help.
Yes, yes. So I think, yeah, so the differential diagnosis here basically is 11 beta HSD deficiency versus Riddle syndrome. So your answer is absolutely right. You can use amiloride, or we thought of spironolactone, either or drugs will give you the elimination. So perfectly right answer, 10 marks to Dr. Devaditya. And this was a correct answer from there. Thank you. We'll move forward to the next question to Dr. Ramiz. Are you ready, Dr. Ramiz? We'll start with this question.
Yes, sir.
This is a 15-year-old girl with weakness and lethargy. Now, she was diagnosed with central hypothyroidism and growth hormone deficiency at 5 years of age. She had delayed puberty and was found to have a low LH, and FSH was also lowish in that perspective. And then now she presented with lethargy, was found to have hyponatremia and low cortisol. So we have got early onset central hypothyroidism, growth hormone deficiency, delayed puberty, low cortisol, low sodium, and MRI shows a pituitary mass. The question is, what is the most likely diagnosis in this case, Dr. Ramiz?
Sir, that is look like panhypopituitarism, sir. So
Yeah. So what is the cause of panhypopituitarism? We want a more precise diagnosis there, like in this case, which will explain everything in this case.
Then it is some craniopharyngioma, sir.
Okay, so we'll pass on to the next person. So Dr. Syed Ahmed, what do you think in this child? You've got only one chance and you can give in 5 seconds only. Yeah. Dr. Syed? If you're not answering,
I pass.
Okay, thank you. Dr. Samar, what do you think about this case?
This child has developed ACTH deficiency, probably secondarily, and secondary cortisol deficiency that is causing hyponatremia.
Yeah, but what is the cause of MPHD? There is GHD, there is hypothyroidism, there is pubertal delay, everything. There's all pituitary hormones are gone, which is what Dr. Rami said. But what is the cause with a pituitary mass? So I think we'll move forward. Dr. Arun, do you have a diagnosis?
Pituitary adenoma.
No, too early onset. The onset was very early, GHD at 5 years of age. Dr. Devaditya, your diagnosis? This is a tough
some
one.
non-functioning pituitary adenoma, I would say, causing pituitary destruction.
So I think this was a bit of a tricky case, but what is important from this perspective is that this child had a very early onset hypothyroidism and GHD, and then evolving deficiencies happened, and there was a cortisol deficiency which was there in that perspective, and MRI showed a mass. Now this mass is basically an enlarged pituitary, and if we go very closely, you will understand that this was a congenital form of MPHD because of a prop1 defect. So this was basically a difficult question, I know, but this is the answer. So I think we'll keep, nobody got an answer to marks for this question. The next direct question is for Dr. Syed Ahmed. And we've got this 6-year-old boy with on and off swelling. And the overnight dexamethasone suppression showed a non-suppressible response. The cortisol was very high despite giving dexamethasone. ACTH was absolutely low. Abdominal imaging was normal. And then this child developed a sudden onset cardiac failure. Now the question is, what is the cause of cardiac failure in this child who has an ACTH independent Cushing syndrome with a normal
Carney's complex?
And the cause of cardiac failure?
PPNAD, sir.
Pardon?
PPNAD, atrial myxoma, sir. Atrial myxoma.
Atrial myxoma. Yeah, that's what we are looking for, more precise answer, but absolutely perfect. This is a classical case of Carney's complex, PPNAD, and atrial myxoma is there. So 10 marks to Dr. Syed. I think that's a good response on that. We'll move to the next question, the third question in the round, to Dr. Samar Agrawal. A 2-year-old girl with early puberty and vaginal bleeding, stage 3 breast development with no pubic hair, LH and FSH are low and estrogen are high. So this is clearly, we've discussed this a lot. We're talking about peripheral precocious puberty in that setting, very classical case that we are seeing. Now, what we are really looking at in this perspective is the question, just one second. Yeah. So the question basically is, this child also had ovarian cyst, and cafe au lait spots. Now the diagnosis is very evident. I'm not asking the diagnosis. The question now is that which is the most specific and the most effective therapy for this condition? The diagnosis is very easy, but which is the most effective drug? Or I would say the latest drug which is available for this treatment, Dr. Sawar?
Tamoxifen. Estrogen receptor modifying agent.
Yes, but they have been used for a long time. We'll go forward on the next person in the list. Dr. Devaditya, is there anything else you have for this?
Sir,
sorry. It will be Dr. Sanju Joseph to answer the question. Your number will come a bit later. Yeah.
I'll pass, sir.
Pass. Okay, Dr. Arun?
Pass, sir.
Dr. Devaditya?
Sir, aromatase inhibitors like letrozole can be given, and also metroxyprogesterone is also effective in these cases.
Okay, we'll move forward and see whether you have a better answer. Otherwise, we'll give some partial marks to Dr. Sawar. Dr. Ramesh, anything better than SERMs or aromatase inhibitors?
Anastrozole, sir.
Aromatase inhibitor has already been discussed. Dr. Syed?
Sir, estrogen receptor blockers.
Exactly. Name? Okay, anyway, so we'll give the marks to you. So this is clearly McCune-Albright syndrome. This is a girl with peripheral precocious puberty and cafe au lait spots. Tamoxifen and aromatase inhibitors have been used, but the most effective therapy is fulvestrant, which is our estrogen receptor antagonist. So Dr. Syed has got 5 marks for this question from that perspective. So we'll now move forward towards the fourth, I think we were 5th question to Dr. Sanju Joseph. And Dr. Sanju, your question is 17-year-old girl with secondary amenorrhea. Prolactin is 600. LH and FSH are low. Estradiol is 400, which is high. One test gave the diagnosis. So this is this girl with hyperprolactinemia, hypogonadotropism, high estrogen. Which single test gave the diagnosis? Dr. Sanju.
TFT, thyroid function test.
Thyroid function test. Okay, let's go forward to the next person. Arun, what do you think?
TSH.
TSH, again the same answer. Dr. Devaditya, anything else you have to offer?
Sir, yeah, MRI of the HP axis.
Okay, next, Dr. Ramesh.
Pass.
Pass. Dr. Syed. So, Dr. Syed, no response. Then we'll go to Dr. Sawar. Dr. Sawar, what do you think?
Pituitary stalk tumor, germinoma of some kind.
Okay. So again, this is a very, very easy answer, but it's a bit confused. People get confused on that. If you talk about what is the commonest cause of secondary amenorrhea, if you ask what is the commonest cause of galactorrhea, what is the commonest cause of hyperprolactinemia?
Pregnancy.
Pregnancy. So this is a very, very tricky question. The answer lied in that you had a very high estrogen level, which is there. Usually estrogen will not be very high. If you have hyperprolactinemia, it should be 0. So this is a trick question. Again, people have been tricked. So HCG would have been a very easy and a simple answer. Of course, hypothyroidism could be a close differential, but I'm not going to give it because estrogen of 400 is a bit very high for that. So I think no marks for that one. I think we have the last question of this round, direct question to Dr. Arun. 8-year-old boy with precocious puberty. Height is 132, weight is 28. Blood pressure is high, SPL is 9 centimeters, and pubic hair is stage 4. There is no palpable gonad. So I think this was discussed yesterday. This boy with precocious puberty, with pubic hair stage 4, no palpable gonad, and this is what it's seen on adrenal. Which is the diagnostic test? I want a very specific test, not anything other than that, which will help you establish the diagnosis in this child, I would say, quote unquote child. Dr. Arun?
Deoxycorticosterone.
Okay, yes. So we'll give 10 marks. That's absolutely right. So this is actually an interesting case of a girl, or let's say a XX individual who has been reared as a boy because of virilization, and now we see hypertension, and this has to be 11 hydroxylase, so 11 DOC has to be done. So we are now closing on the first round, and I think scorers should not get confused and tell me what is the exact score. So Dr. Naveen, you can come up and tell the score.
At the end of first round, we have Syed Ahmed leading with 15 points, followed by Devatia and Arun Jaj, who are equal with 10 points, and the rest are yet to open their account.
So this is an interesting, so again, a tough fight going on. And so again, the questions are going to be very, very clinical, and most of them would have been discussed in last couple of days, but just more of application is required. So this was DOC, which was rightly done. So now we know the scores. Dr. Syed is leading with 15, and we have got Dr. Debaditya and Dr. Arun at 10. That's the score. We'll move forward to the second round, and we'll start with Dr. Arun. The other way around will go now this time. 3-year-old boy with polyuria. Urinary osmolality is 50. Sodium is 156. Post DDAVP, the osmolality went up to 150. Diagnosis was established only by looking at the child. You don't do anything, no imaging, nothing. Diagnosis was established on imaging. On clinical examination, what do you think was looked at in this case, which really clinched the diagnosis in this case? Dr. Arun?
Diagnosis central diabetes insipidus. On clinical examination, one finding would be look for midline defects.
No. So let's make this question clear. This child has central diabetes insipidus, and just by looking at the child, a diagnosis was made which was final at the basis of that. And 3-year-old boy, otherwise looking healthy, no development is normal, everything else is normal. But on examination, one thing was found, and it really made the diagnosis absolutely clear. Maybe try again. Yeah. Okay. So Dr. Arun,
cleft palate.
Cleft palate. Okay. We'll pass on first and see how other answers come from there. Dr. Sanju Joseph, what do you think in central DI? Which finding will give you direct diagnosis immediately? In a young child, 3-year-old?
Features of Langerhans histiocytosis, LCH.
Like?
Seborrhea, thrombocytopenia.
Yes. So this is the answer was looking for. So this child actually had a seborrhea and a skin rash. So we'll give 5 points to Dr. Sanju for the correct answer on pass. We did mention the child had a later onset. This was an acquired form of DI. It was not happening right from birth. So that's why cleft palate will become less likely, because it will have onset very early. And usually you will have many more defects in those cases. They will not present like this at this age, Dr. Arun. So we'll move forward to the next direct question, which is again for Dr. Sanju. 3-year-old boy with failure to thrive. Height is 80 and weight is 8 kg. So again, severe failure to thrive. Blood pressure is on the higher side. Serum sodium is 153 and serum potassium is 6.2. I think this was discussed today. So there's no clue, nothing. What is the diagnosis, and which I want the specific genetic defect as well. So half point for diagnosis, and if you give the genetic defect also, you will get full. So failure to thrive, hypertension, high sodium, high potassium. Diagnosis.
I'll pass, sir.
Okay, Dr. Samvar. Dr. Samvar, are you attempting this? Yeah. Please go ahead.
Pass, sir.
Okay. Dr. Syed. I think we'll pass then to Dr. Ramiz.
17.
Pardon?
So congenital hyperplasia.
No. Why will you have a hypernatremia there? So it's a bit different. Dr. Debaditya, your guess?
Yes, the diagnosis is Gordon syndrome. Genetic defect is WNK4 mutation.
Very good. So this is actually, we just discussed now that if you have hypernatremia and hyperkalemia, you need to think of Gordon syndrome. So this is a very good answer. So 5 points to Dr. Debaditya for getting it right in that perspective. So now we have a direct question for Dr. Savar. This 2-month-old boy with failure to thrive was found to have recurrent vomiting and steatorrhea. Blood sugar was low, hyponatremia was there, hyperkalemia was there, and cortisol level was low, 17 OHP was normal. So we have a primary adrenal insufficiency with a normal 17 OHP. Now, there was also another finding of large hepatosplenomegaly. The question is that a simple test, a very, very simple test, I'm not talking about genetic analysis or anything, just a simple lab test helped to reach the diagnosis in this case. So what do you think would have been that test which would have reached this diagnosis? Dr. Savar.
Yeah, I'm just thinking, sir.
Yes, please. So we have a child who has got adrenal insufficiency. This is not 21 hydroxylate deficiency, hepatosplenomegaly. Any answers, Dr. Savar, or we'll move forward?
Pass, sir.
Dr. Syed?
The serum cholesterol levels.
And why?
Sir, DHC, Smith-Lemli-Optic syndrome.
We'll give you that. Smith-Lemli-Optic syndrome or Wolfram syndrome, both of them will present. But if you look at hepatosplenomegaly, but lipid profile is what we are looking at. So absolutely wonderful answer, Dr. Syed. So this is one condition which presents to us with steatorrhea, vomiting, adrenal insufficiency, hepatosplenomegaly, and lipid profile was what we are looking at. So 5 marks to Dr. Syed for that right answer. Now, this is a direct question to Dr. Syed, a very simple question. You see a device. What is unique about this device? If you read it on top of it, there's something also written which will help you out find what it could be doing. Dr. Syed.
So don't.
Okay.
Sir, pass.
Next. Yeah, Dr. Ramesh.
Sir, exactly I don't know, but I guess it is probably automatic continuous glucose monitoring.
Okay. Next one, Dr. Debaditya.
I would guess that this is a artificial pancreas or a bionic pancreas, which will give both insulin and glucagon and to maintain the level. And the islet brand is basically pointing to that.
Absolute perfect, because if you look at it, it says islet, which means it is like an islet of Langerhans, and it causes both insulin as well as glucagon. Very wonderful answer. So 5 points again to Dr. Debaditya for that. Next direct question is basically for Dr. Ramesh. The question is 15-day-old girl with preterm, 28 weeks of gestation, again discussed just now, on total parental nutrition, has hypercalcemia, phosphorus is low, PTH is undetectable. So this is a newborn, a preterm who has hypercalcemia, hypophosphatemia, but PTH is low, and vitamin D is low, calcitriol is high. So if you think of it, this is a bit confusing picture. You have hypercalcemia, hypophosphatemia, low PTH, and calcitriol is high. Now the question is, what therapeutic strategy could have prevented this from happening, or how you could have improved this from happening? Preterm on TPN. This is all things you have to consider. So this is
phosphate supplementation.
Exactly. So why do you think phosphate deficiency causes hypercalcemia?
Sir, phosphate deficiency excessively activates 1-alpha hydroxylase. There is excessive conversion of these two calcium.
Absolutely perfect. So this is a wonderful answer. 10 marks to Dr. Ramesh, and that's perfect. Yeah. So we'll move forward to the last question of this round. We have got for Dr. Debaditya. This is a 12-year-old girl. I'm not asking what are the diagnosis. I think that's very, very evident. Height is low. There is no breast development. Brachymetacarpia, webbing. The diagnosis is absolutely clear. The question is, the cause of short stature in this condition causes tall stature in which disorder? Dr. Devaditya.
The cause of short stature are multiple, but the main cause is basically SHOX deficiency, which can cause tall stature in Klinefelter syndrome in boys and also in girls having more than 2 X chromosomes.
Perfect answer. So 10 marks again to Dr. Devaditya. So SHOX deficiency in this case, and if you have got more SHOX, you will grow more. That's how it works from that perspective. So Klinefelter or supernumerary X chromosome in girls. So Dr. Manoj, you've got the answer, the latest scores. Yeah. So you can read the scores.
At the end of the second round, we have Dr. Devatia leading with 30 points. He is followed by Dr. Syed with 20 points. And there's a tie on the third spot with Dr. Arun Jha and Ramesh Raja with 10 points. And Dr. Sanju is at the 5th position with 5 points.
Don't worry, it's just early days. Only 2 rounds have been there. And then we have a buzzer round, which has got a lot of huge number of points, positive and negative, which you can gain from that perspective. So we'll now move forward towards the third round, and we'll start again with Dr. Devaditya. Now, this is a case again discussed today. 12-year-old girl with multiple fractures, and I think diagnosis is clear: failure to thrive, polyuria, and myopathy. Hypokalemia is there, hypophosphatemia is there. There is metabolic acidosis, and urinary pH is 7.4. So you have a child with rickets, with fractures, with failure to thrive, polyuria, hypokalemia, metabolic acidosis. Now the question is, what do you expect to happen to the potassium after you start bicarb in this setting? Will it remain the same, increase, or decrease, Dr. Devaditya?
If we give only bicarb without supplementing potassium, the potassium will decrease because of the alkalosis.
Decrease. Okay. Next one, Dr. Arun. So I think obviously if the answer decrease is wrong, the answer will be increase.
Potassium would increase.
But how will it happen? If you can just tell me this. First of all, what is the diagnosis? We all know this is distal RTA. Distal RTA. So why do you think after giving bicarb, does the potassium increase in distal RTA?
Sir, if sodium bicarbonate is given, then the potassium will decrease only. Only if potassium bicarbonate is given, then it can increase.
No. In this, there is a. So we have not finished this question. So let us continue on that one. Yeah. So Arun, can you give the answer?
Because it's involving the H plus K plus channel, and if we give bicarbonate, that will reduce the potassium excretion in the distal tubule.
Okay. So I think that is our right answer. Now the confusion, Dr. Devaditya, basically is that when you give soda bicarbonate, there is usually an exchange between sodium and potassium. That is mainly for proximal RTA. In distal RTA, the major cause of caliuresis is actually because of intracellular acidosis. If you correct the intracellular acidosis, the potassium levels improve even if you give sodium bicarbonate. So there will be marks given to Dr. Arun. 5 marks will be there in that perspective because the mechanism was explained from that perspective. The next question is to Dr. Ramesh Raja. The question is 1-year-old boy with developmental delay and spasticity. Diagnosed as hypothyroidism at 2 weeks of life, on thyroxine with good compliance. T3 is high, TSH is low, FT4 is normal. Now, I'll give you half marks if you give the diagnosis, and if you give the correct treatment also, I'll give full. This is a tough question. So, hypothyroidism diagnosis at 2 weeks, despite good therapy, severe spasticity and developmental delay is there, and you've got an unusual report of a high T3, low TSH, FT4 being normal. What is the most effective therapy in this situation, Dr. Ramesh? And what is the diagnosis? So, diagnosis is 5. You tell treatment, will give another 5.
Sir, probably monoiodinase
MDI
mutations.
Okay. Yeah, we'll go on to the next one. We'll come back to you again later on. Dr. Syed?
Sir, MCT8 defects.
Good.
Allen-Dudley syndrome.
Yeah, and what are the treatment?
Diiodopropionate acid.
Yeah, I'll give 5 marks to you. This is perfectly fine. This is a very, very unusual situation in which you've got T3. It cannot enter the cells. So you use a T3 analog. triac is what is used, but this is perfect answer from Dr. Sayed, 5 marks to him. And this was a very difficult question, but good answer, I would say. Now, direct question to Dr. Sayed, again, 2-year-old girl with precocious puberty. We can see very clearly stage 3 breast and pubic hairs. LH is high. So this is central precocious puberty. MRI is normal. There are 3 family members who also have got precocious puberty. Now, the question is, which genetic diagnosis is most likely in this case? Familial case of precocious puberty, central precocious puberty.
MRKN3 mutation, sir.
Perfect answer. Dr. Ahmed, 10 marks to you. So MRKN3 is the condition which is associated with precocious puberty, which is familial. So 10 marks to Dr. Sayed in that perspective. Now, direct question to Dr. Samar. 2-month-old boy with failure to thrive and polyuria. Blood pressure is 60/40, dehydrated child. There is metabolic alkalosis, which is there. There is hypokalemia. So I think again, we discussed probably this case today. Urinary calcium to creatinine ratio is high. Magnesium is all right. So you have got a child with failure to thrive polyuria who has got normal blood pressure. There is metabolic alkalosis and hypokalemia. The question is, which is the molecular defect? So first you can tell us the diagnosis and then the molecular defect that we're dealing with.
Bartter syndrome?
Yeah, 5 marks for that. Diagnose the defect.
The sodium channel in the loop of Hanley.
Perfect. So sodium potassium fluoride channel, there are multiple defects, but we'll give, because this is the most common and the most severe form. So we'll give 10 marks to Dr. Samar. Please note for that. The next question is from Dr. Sanju Joseph, a 10-year-old boy with seizures who has got a hypocalcemia and a hyperphosphatemia. Low calcium, high phosphorus. And you can see that there is this finding on examination. This is on CT scan. This is again, I think this case again was presented today. The question is not what is the diagnosis, what is the pattern of inheritance of this disorder. So no points for diagnosis. It's mainly the pattern of inheritance we're looking at. Yeah, yes, and you're muted. Yeah.
Autosomal dominant.
Anything beyond that? Okay, Dr. Arun.
Sporadic.
No, Dr. Devaditya.
This is basically an imprinting disorder. So only one gene is activated. If the maternal gene is mutated, only then the disease is expressed as PHP type 1A. And if only the paternal gene is defected, then there is pseudo-hypoparathyroidism, only the phenotype.
So 5 marks to Dr. Devaditya for this wonderful answer. This is pseudo-hypoparathyroidism, which is an imprinting disorder. From the mother, if you have mother is affected, you will get the problems of hypocalcemia. If the father is affected, you will only get pseudo-hypoparathyroidism. So that was a good answer there. There's a direct question now to Dr. Arun. 3-year-old boy with hypoglycemia and pigmentation. Sodium is 132, potassium is 3.2, and ketones are 2.4. So there is a ketotic hypoglycemia. Cortisol is 220 during the episode of hypoglycemia, and the ACTH is 2000. Now the question is, diagnosis was made on eye examination alone. And the question again is, which is the gene which is affected? You have to tell me the gene, no points for guessing the diagnosis, because that will be relatively easy, I would say. Or if nobody guesses the diagnosis, we'll give you half marks for that. But I think you should be able to answer this. This child with hypoglycemia, pigmentation, low cortisol, high ACTH, and eye will give you the diagnosis. Yeah, Dr. Arun.
The eye examination, so probably this is alacrimia, AAA syndrome. Gene mutation would be AALS mutation.
We'll give it to you. So 10 marks for this correct answer. So this is the aladine of the gene product, and AAAS is the gene which is defective. So 10 marks to Dr. Arun. I think we have finished the 3rd round. You've got the scores, Dr. Naveen.
The competition is going really tight. We have Dr. Devatia and Dr. Syed leading with the 35 points. And we have Arun John in 2nd place with 25 points. And we have Dr. Samdar and Ramesh Raja on the third place with 10 points. And,
No. Pradeep, you have got the, I think there's some issue.
So 10 plus 10, yeah, 35.
Yeah.
20.
Okay.
So first he got 10 points there, then he got 15 here.
Yeah.
25.
So I think there's
This
some
is correct,
confusion.
sir.
So we'll use, yeah. So so we'll go one by one. Dr. Devaditya is on 35. Dr. Ramiz Raja is on
10 points.
10 points. Dr. Saeed Ahmad is also on 35. Dr. Savar is on 10. Dr. Sanju Joseph is on 5. And Dr. Arun George is on 25. So we have got Dr. Devaditya and Dr. Syed neck to neck at 35 and Arun at 25. You got one more round. So I think let's be more consistent because then there will be confusions there. So I think everybody is clear from the scores. Dr. Devaditya and Dr. Syed are at 35 points. Arun is at 25 points. And we'll go forward on the next round. This is the last round, I think. Yeah, round 4. So this round will again start from Arun again, going back from that perspective. Okay. So this is a 3-year-old boy with 21 hydroxylase deficiency, Dr. Arun. Hydrocort of 25 milligram per meter square per day. Fludrocortisone of 0.05 milligram per day. 17 OHP is 30. So you've got somebody who is CH, 17 OHP is uncontrolled. The question is which diagnostic test will help improve your management? What is missing in the whole picture? Dr. Arun.
I would do a ultrasound to look for TART.
Okay. Next, doctor, we are going reverse. Dr. Sanju. Dr. Sanju, what do you think? This child on CH, high dose of hydrocort, 17 OHP high, what should have been done? What test will help you diagnose that?
Growth and assessment, growth and bonage.
Growth and bonage will tell you whether you're going up or down. We'll go on to one specific test we want. We'll come back if there's no other answer. Dr. Samvar?
Is it PRA assessment?
Absolutely correct. And how will PRA help, Dr. Samvar?
Sir, I looked at this question. I could not find the answer, but I remember the answer.
That's very, very honest answer to that. So basically, this question is an interesting one. So this is from a management of a child with CAH. Essentially, what happens is that in CAH, if you're giving less dose of mineralocorticoid, which is happening in this case, which is 0.05, you would actually cause hypovolemia, and that hypovolemia cause increased AVP, and that AVP increases the secretion of ACTH and your 17-OHP. So if your 17-OHP is uncontrolled, you should look at plasma renin activity, and that's the correct answer. Hope you now understand this complex. So 5 marks to Dr. Samvar on that. The next question is to Dr. Sanju Joseph. 14-day-old.
Why not full marks, sir, for the correct answer? I mean, explanation was not asked in the question.
No, sir, this was 5 marks because it was a past question to you. It was not a direct question.
Oh, sorry. That's
Direct
right.
question.
Okay, thank you.
Yeah. So 14-day girl with persistent hyperinsulinism. Birth weight was 1800. Apgar score was 3 at 5 minutes. So there was birth asphyxia. I think just discussed right now. GIR 14, ketones negative. Insulin is 3 and diazoxide is 10 milligram per kg per day. So this is a typical case that we discussed about hyperinsulinism. Now started with edema was started on furosemide. Now the quick question is, what do you expect with the addition of furosemide to diazoxide? Because we know that edema is very common and somebody thought we'll give furosemide. So what do you think will happen here, Dr. Sanju? So shall we pass to Dr. Samvar then, Dr. Sanju?
Okay, sir, pass it.
Yeah, Dr. Samvar?
It will improve the response.
It will improve the response. It will potentiate the response. True. And that may actually not be always good because I have seen cases of decay happening also because of that. So furosemide potentiates the response. Thiazide does not. So that's why we talked about in the discussion that avoid furosemide, give thiazide. So again, 5 marks on pass to Dr. Samvar. Now the next question is directly to you. So this is the option for you to get a direct, sir. Full 10 points here.
Yeah.
3-year-old boy with hypoparathyroidism, abdominal pain, polyuria and vomiting, calcium is now 16. Hypoparathyroidism, but now the calcium is 16. Calcium is high. Now we decrease the dose of calcitriol, calcium remained high. What is the most likely cause of this increase in calcium in this child? Again discussed today.
Unfortunately, I missed the discussion today totally. I was away.
So anyway, what do you think will cause hypercalcemia in somebody who has got hypoparathyroidism, who presented with abdominal pain, polyuria, and vomiting? Shall we pass on?
Yes, sir.
Yeah, Dr. Syed, what do you think is happening here?
Probably the patient has developed tertiary hyperparathyroidism or secondary or tertiary hyperparathyroidism.
No, because he's already 0 in terms of hypo, so he won't develop now. So we'll go forward. Dr. Ramiz, what do you think? Hypercalcemia in the setting of somebody who has got this situation? In hypercalcemia? Yeah, Dr. Ramiz?
Sir, probably the diagnosis, sir.
No, I'm saying that this child was managed as hypoparathyroidism. Now suddenly he's developing hypercalcemia. What can explain what disease has happened or what has happened to this child? How can you explain this? Because earlier we were, yeah.
Sir, ectoparathyroidism, sir.
No, he doesn't have any parathyroid anyway. So let's go further. Dr. Debaditya, what do you think?
Basically, the child had APS1 and has developed adrenal insufficiency subsequently, and that has caused the hypercalcemia.
Perfect answer. So 5 points to Dr. Debaditya on that. So next question will go to Dr. Syed, direct question, which is there. This is an 11-year-old boy with refractory rickets, and you can see the pattern. Phosphorus is low, very low. There is no metabolic acidosis. There is normal calcium and normal PTH. Now he has received multiple doses of vitamin D, not improving. The question is, what novel therapy which targets pathophysiology of this condition? Dr. Syed.
So he is having hypophosphatemia. That's it.
Yes.
With normal calcium and normal PTH.
Yeah. So what's the diagnosis?
Most likely it's a hypophosphatemic rickets.
Yes.
Sir, the monoclonal antibody against FK23 burosumab.
Perfect answer. 10 points. Absolutely right. That is the standard treatment of choice. It's unfortunately not easily available here, but that's the treatment of choice. So 10 marks to Dr. Syed there on the direct question. The next question is basically to Dr. Ramiz now. A 2-week-old girl with dehydration. Blood sugar is 450. DKA was present. So this child presented with diabetic ketoacidosis, managed with insulin infusion. The question is, which clinical finding in this girl will predict a transient form and not a permanent form of diabetes? So you look at this child, you find something and you say this is transient. That's it.
Sir, macrosomia.
Macrosomia.
Oh, sorry.
Okay. Let's move forward. Dr. Debaditya.
This can happen with GSD type 11. So hepatomegaly, if it is there, it can be a transient finding.
I'm looking about TNDM actually. So let's go forward. Dr. Arun, you come forward. So which clinical marker suggests a transient neonatal diabetes? Dr. Arun.
If he was SGA, small for gestational age baby.
That is there for permanent also. Dr. Sanju. Okay, Dr. Samar.
Features of ear crease and umbilical hernia.
Absolutely right answer. So yeah, that's perfect answer. This is an imprinting disorder. So if you have ear creases, omphaloscopy that looks like Beckwith-Wiesmann, think of a transient diabetes. So again, Dr. Samar is actually scoring a lot on pass. That's why he's getting 5 marks again.
That gives me more time to think, I think.
Yes. So I think we are heading toward the last question of this session round. And this question goes to Dr. Debaditya. And the question is, a 7-year-old boy with precocious puberty. Penile length is 10 centimeter. And this is an interesting question. Think over it. Testis is 4 ml. LH and FSH are low. Testosterone is very high. The question is, somebody did a bedside test. that investigation immediately gave the diagnosis. You have to tell me what test could tell the diagnosis in this case within 2 minutes.
Urinary pregnancy test.
Perfect. And how would you like to explain this like?
This is basically the test is in intermediate size. So most likely this is HCG secreting tumor is there. And a bedside test is to check for urinary HCG, which can clinch the clue. And a penile rate is rather very high compared to the testicular.
So this is a classical presentation. And this is one case I saw 20 years ago at AIMS, and we made a diagnosis during a urine pregnancy test because HCG at that time took a long time. So this was a case who had got a peripheral precocious puberty, but intermediate size testis was there, and testo is high, and that's why HCG is likely, and UPT gave the diagnosis. So by the time there is a consensus which is developed between our scorers who seem to have a lot of controversies within them, we'll just talk about how do we go in forward with regards to the buzzer round. So the buzzer round is going to be very, very interesting. Now this is going to be a make or break round. Can you have the scores? Yeah. And these are perfect final recommendations. Yeah. Okay. So after the fourth round, we have got a tough competition which is there between Dr. Debaditya, who is at 50 points, Dr. Syed Ahmad, who is at 45, Dr. Savar has got 25, Dr. Arun George has got 25, Dr. Ramesh has got 10, and Dr. Sanju has got 5. But mind you, this round can change everything because this round is so interesting, it can really change. You've got 6 questions. And what will happen is that be very careful with regards to your chat option, which is there. And for this, what I'll do is that I'll stop the sharing of screen so you won't see unless there is a case which is there. If there is a case, we will show that. I'll just see if there is any case or something. No case is there. So it will be like a direct screen. I'll just be reading out. The last question maybe has a photograph. We'll show that at that time. Now, how it will work is that, and one of you will have to open the chat option from there. Or maybe I can do that from my side. Is that I will write N, and N will basically reset. So this is the question starts. Then I'll start reading the questions. And if you think you can answer the question, press Y. And the first person who presses Y, I'll stop at that and we will ask the question. The question will stop there. Immediate answer, no pass. You have to answer immediately. You can't think about that. And maybe if I'm in the middle of question and you are stopping me, I might actually not even complete the question and you have to answer. So think over the complete question before you put that. There are 15 points plus for a correct answer and minus 15 for a wrong answer.
My God.
I think this round is going to change the whole thing. So if you play well, anybody can win from here. So I think what we'll do is that to make it easier, we'll go stop the share.
We have to type Y on the chat box.
Yes. So everybody is there for the chat box. So we'll have a quick dry run also. So in the chat box, what I'll do is that I'll say N. When I say N, it means that now the question is reset. You can write. Now all of you can put your Y and see whether your Y button is working or not. Let's have a quick test on that. Devaditya is working. Dr. Arun is working. Dr. Usaid is working. Dr. Rami is working. Dr. Devaditya again is working. Dr. Sanju. Dr. Samvar and Dr. Sanju, please press the Y button.
I did, but
it is now come. Yeah. So don't put a direct message. Put as a for everybody.
Okay.
And Dr. Sanju, yours has not come.
Okay, sir. I'm trying to do that, sir.
Everybody is not visible in this.
Okay, I'll make it like this.
Okay, sir.
So now everybody is visible?
It's right, sir.
Okay. So I think everybody is visible from here. So we'll do a quick. He's there, no? He's there. We'll have another trial. I'll put an N. So that means this is reset. Now everybody put Y quickly. Yeah.
Can you see mine? Mine is going direct message.
You are giving a direct message, I think. Anyway, so I'll have a look at it. You can change the option, a host and panelist you can put.
No, it is not showing in my list.
Okay. So anyway, we'll have a look at it. So Dr. Sanju, your answer is not coming. Otherwise, everybody's answer is coming.
So just explain once more, sir.
Yes. So what we'll be doing is that we'll be asking a question and I'll put N. So now I put N. Nobody should put a Y now, because if you put Y, you have to answer the question from there. Now, as soon as you feel you are confident enough to answer the question, you put a Y. Our people are monitoring. As soon as the first Y will get a chance to answer that question. Now, it may also happen that I'll stop just at the point you put Y. I may not even ask any further, and you have to give whatever you say, if it is correct or not. So be patient. Don't be too overzealous in that perspective, because
so you will type. So you will type the question in the chat box.
No. I'll read out the question. So I'll read out
You
the
will
question.
read out.
So you have to listen. Yeah,
Because
I'll read out. Yeah.
When the chat box is opening, so your figure is not visible, sir. When we are opening the chat box,
okay,
so the screen is not visible, sir.
Screen is not required.
So you have to just listen.
Fine.
You just have to listen. I'm not showing. I'm not displaying anything. I'm just having a direct.
Question slides will be there. No question slides will be there.
No question slides. I'll read the slide directly from my side.
How?
This is
I mean, if two persons press at the same time, why it will?
Whoever will show on the chat first to me.
Okay.
It won't happen that both will come simultaneously. That's it's
Okay.
like the best buzzer you can ever find out, actually.
So how many questions in this round?
There are 6 questions, so it can change. Somebody can get 90 points, and the whole quiz is won from that 90 points.
And some can
Or
get
somebody
minus
become
90 also.
minus 90 also. So be careful. So Dr. Sanju, I'm not seeing you. Is Dr. Sanju there?
Yes, sir. Yes, sir, I'm here.
So, yeah, can you try Y once, because we didn't
Yes,
get
I'm-
response.
Is it coming, sir? No. Is it to all panelists or?
It is
to all
to
panelists?
all. Are you sending to any particular person, actually? So there's
No,
the
it's
option
actually, I've sent it to all panelists.
to host and panelists. Yeah.
Mine
To
is
host
not
and
showing the list. It's showing only the name, not all pan.
Okay,
Somehow it
please
is.
use to everyone. You can use to everyone so that there's no confusion.
Mine is showing only your name.
You can change that by drop down. You can change.
I can't see the.
Okay. So anyway, so I think let's start without much discussion from there. So the first question is basically there. Everybody is ready. I'll set N so that it's reset, and we'll ask the first question. There is a 3-month-old girl with seizures. Calcium is 6.4, phosphorus is 8.2, hypocalcemia, hyperphosphatemia, PTH is 150, it's high, creatinine is 0.4, it's normal. What is the most important next investigation? So hypocalcemia, hyperphosphatemia, high PTH, creatinine is. So we have got first to answer is Dr. Ahmed. Dr. Ahmed, what is your answer?
So magnesium and vitamin D levels.
Magnesium and vitamin D levels. We'll give 15 marks on that because that's important. Those are absolutely important. We were looking at vitamin D, but magnesium also, of course, is relevant from that perspective. 15 marks to Dr. Ahmed from there. So I'll now reset it again. There are 5 more questions to go. The next question. Okay, 1 second. So now it is reset. It's the N is there. The next question which is there is again now coming. So listen quickly, carefully. 12-month-old boy with hypoglycemia. There is hypotonia and hepatomegaly. On fasting state, blood sugar is 32. Cortisol is 650. It is high. Insulin is low. There is ketone and lactate is high. 12-month-old boy with hypoglycemia. Already Dr. Devaditya is there. Now, I haven't asked the question, but since you have pressed yes, I'll ask the question. What is the next step to establish the diagnosis? Quick answer, Dr. Devaditya.
Sir, basically diagnosis is GSD type 1. So we can do a glucagon stimulation and see whether the lactate is rising or not.
Perfect. 15 marks. So this is GSD1 versus a gluconeogenic defect. Just the case we discussed now. So this is where you can do a glucagon test. Perfect, plus 15 to Dr. Devaditya. So we'll go now to reset it again. we are heading towards the third question, which is there. And this question is again a buzzer question. Huh? Achha, everyone. Okay. So I have reset now again. Yeah. So we'll now ask the third question. And this question is a 16-year-old girl with primary amenorrhea, stage 4 breast development, stage 1 pubic hair development, normal growth. Let me finish the question because otherwise I'll stop. High LH and FSH, infertility in maternal aunts. The question is most likely result on karyotype. Dr. Devaditya.
Karyotype will be 46XY. This is a case of complete androgen insensivity syndrome.
Perfect. So again, a classical case of AIS, you've got another 15 points, which is there. So now in the middle of this round, what is the current score, Dr. Naveen?
सर मेरा वाई पहुंच नहीं रहा है लगता है सर.
आपका वाई जस्ट बाद में पहुंच रहा है, immediately डॉक्टर देवादित्य का बहुत पहले आ जाता है. So Dr. Devaditya has gone up to 80 points. Dr. Syed is at 60 points, again in the striking distance. Dr. Rami is at 10, Dr. Samar is 25, Dr. Sanju Joseph at 5, and Dr. Arun at 25. So there are still 45 marks to be grabbed. So 45 marks would mean that a lot of changes can happen here as well. So the last 3 questions are there. 2 would be on direct buzzer and 1 would basically be on the imaging part of it. Yeah. So next question, I'll reset it. So now this is the 4th question. A 10-year-old boy with head trauma and seizures. Sodium is 118, potassium is 3.8, creatinine is normal, urinary sodium is 80, uric acid is 1.8. What is the most likely diagnosis? So the first answer is Dr. Savar Agarwal. He is
SIADH.
SIADH. Perfectly right. 15 marks to Dr. Samar. So your answer is also being recorded. It is direct message, but it came to me. But that was the first one. So this was SIADH because the uric acid is low. Again, we have discussed that. We've got, so I'll reset it again. So this is the reset. Now the next question is 28-day-old boy with reduced feeding and lethargy. There is sudden deterioration and shock, hyponatremia, hyperkalemia, normal genitalia, no pigmentation. There is gross. Dr. Samar, you answered. Diagnosis?
Pseudohypoaldosteronism type 1 recessive variety.
You haven't actually waited for the answer, minus 15 on that one. Actually, I was saying gross hematuria is there. This was actually a renal vein thrombosis with secondary adrenal hemorrhage. So this is like an acute adrenal crisis with hematuria. So again, minus 15 to Dr. Savar. So you're back to the original score. Yeah. So now we've got the final question. And this will actually be, because there is an image, so we'll again show the image there. So what is, just before we go to the final question, can the scores change, Dr. Naveen? So there is, at this stage, there is a tough fight between Dr. Devaditya and Dr. Syed, 60 and 80. So I think pretty much they are pretty secure in that perspective. So they can't touch with each other.
Devaditya should retire now. He should give opportunities.
I think the scores are pretty okay, but we'll go for the last question anyways. And this will be a visual question. So I think we'll have a visual round on that. So this doesn't make a huge difference with the outcome. So anyway, we can have this visual question there. So just 1 second, we have put the chat. Okay, so this will be a bit of an issue. Yeah. So this is the question. So I'll reset it. Now, this is a 6-year-old girl with hypothyroidism. FT4 is low, TSH is 2.2, cortisol is low, growth hormone stimulation is low. MRI shows a finding, diagnosis. So what do you think is the MRI finding? Anybody can come in. Now, this is not going to make a huge difference in the outcome. Everybody can see the
नहीं दिख रहा सर, enlarge करिए ना उसको.
Yes. Now it's very enlarged. Nobody is wanting to take a risk at the last question.
So FT4 level, can you show once again?
FT4 is low. Everything is low. This is MPHD, classical MPHD, and an early onset MPHD, and you can see this finding on the MRI. So I think Dr. Arun has now put in his. Dr. Arun, what's the answer?
Is it a pituitary stalk defect?
No, it's actually it's actually a rat.
Complete pituitary.
It's not an interruption. It's actually a rat case cyst, which is there, which is a cause of congenital MPHD. So anyway, we'll probably have the final part of this. We've got the scores ready, Dr. Naveen. So the scores clearly show that we have got a clear winner, Dr. Debaditya, who was also the winner of the prelims round, and he gets the first prize with 80 points. The second prize is to Dr. Syed Ahmad, who is with 60 points. But all of you have done really well to have come here. So all of you are also winners in this perspective. So it's been a wonderful quiz. Again, congratulations to the winners. And also, it's important that we need to appreciate everybody who's been part of this. So Dr. Devaditya is the winner, and Dr. Syed is the runner-up in this situation. So, and we'll discuss about the prices. And now what about the best performing postgraduates? We had got very good participation from postgraduates. The candidates who are there in the top 6 list are Dr. Savita H. from Government Medical College, Thiruvananthapuram, Dr. Sai Pratyusha from Kachi Kamakoti Child's Hospital, Chennai, Dr. Abhilasha Ghetia from MP Shah Medical College, Jamnagar, Dr. Mitsu Vithalani from MP Shah Medical College, Jamnagar, Dr. Fatima Nilofer from Stanley Medical College, Chennai, and Dr. Swati Dokania from AIMS Bhopal. So all of these are going to get a special discount in terms of their postgraduate course, which is there in that perspective. The next group of was with regards to the practicing pediatricians, and this is a special 30% discount on our course from that perspective. The candidate, Dr. Anirban Ghoshal from Belfast, UK, has won the first situation. Dr. Nilay Nirupam from Dubai, UAE. The second, Dr. Nitya T from Trishur, Kerala. Dr. Sanjay Kumar from Sitamarhi, Bihar. And Dr. Veenu Vasani from Jamnagar, Gujarat. And finally, we have got Dr. Serva Bonsu from Ghana. So we had got multiple countries here from UK, UAE, Ghana, and different parts of India in this part. They will be getting special discounts there. What about endocrine trainees? We had around 20 endocrine trainees from the country who were part of this. Again, we've got a special discount on the Pediatric Endocrine for Fellows course. The top candidates here were Dr. Afsar Fatima Ghoshal from Nellore, Dr. Rashi Agarwal from Amrita Institute of Medical Sciences, Kochi, Dr. Kochurani Abraham from Wadia Hospital, Mumbai, Dr. Anshika from Manipal Hospital, Bangalore, Dr. Nischinta from Vaidehi Medical College, Bangalore, and Dr. Anish Kar from SSKM, Kolkata. So we had got a wonderful participation. I'd like to thank all of you for participating, and congratulations again. Dr. Debaditya, we'd like to have a few words from you. You performed really nicely.
Thank you, sir. First of all, I would like to say that it was an absolute honor. I'm literally a fan of you since my postgraduate days. I've been following you since then, and today I could interact with you and play in this amazing quiz. The questions were brilliant. I would like to dedicate this to my pediatrics teacher, Dr. Shubhrata De, who actually introduced me into the field of pediatric endocrinology, and also my current teacher and my guide, Dr. Shubhankar Chaudhary. And to play in this arena with sirs like Sawar Agarwal sir, whom I respect a lot from long back, and also with my friends Ramiz and Ahmad. It was a brilliant experience, and I thoroughly enjoyed it.
Thank you, and best wishes for your wonderful future. Dr. Syed Ahmad, your thoughts? I think Dr. Syed is not there. Dr. Sawar?
Yeah, I at the beginning, I realized that I am a no runner in this quiz competition with so many stalwarts who are doing specialized training in the endocrine arena. But it was a very pleasant experience for me to be able to be on the board in this competition, and I enjoyed thoroughly. And hats off to you, Dr. Anurag, for framing such brilliant questions. I think only you can do that. Thanks a lot.
Thank you, Dr. Savar. Dr. Ramesh, your experience, please. Yeah.
Sir, it was a wonderful experience, sir. Actually, I thoroughly enjoyed it. Thank you, sir.
Thank you. Thank you, Dr. Arun.
It was truly a wonderful experience, sir. I never expected to qualify with such difficult competition. Finals, I didn't expect to even be able to answer even one question. That was what I was worried about. I was glad that the questions were all very clinical, and I could at least put my mind into it and try and answer a few questions at least. The questions were really brilliant questions, very wonderfully framed, and so much of what I was able to answer was from the videos and the modules that you have shared on YouTube and all your from your textbooks. Thank you very much, sir, for this great opportunity. Thank you, sir, once again.
We have got a big honor of Dr. Raghupati being there in the actually in the panelist group. Dr. Raghupati, sir, are you there?
Yes.
It will be your blessings will be great for all the students. And Dr. Raghupati, we all know, is the father figure of pediatric endocrinology in the country. Yes, sir. Please.
Hearty congratulations once again. I don't think I can say enough to congratulate you. You've been doing so well, and as I said, I have converted myself into a student again, and I'm going through all these sessions and really enjoying them. Thank you very much.
Thank you, sir. So I think that was a wonderful blessing. I think we've got a couple of more of our panelists there. Dr. Deepak, can you just share your experience before we close this session? I think this has been a wonderful session. I'd like to thank all of you for this wonderful program, the quiz. We'd like to thank the entire team. I'll invite Dr. Prateek, kindly come up, Dr. Naveen, Dr. Sayan, Dr. Manoj, please come up, and they all deserve a round of applause because it's been really wonderful. And all of you will be receiving intimations with the certificates for the quiz, as well as for the prizes we'll discuss and how we'll go on to that. So I think this is a wonderful team that we have. Thanks all of you. And it has been a pleasure, and thank all the persons to participate at that point of time as well. So I think we'll thank all of you, and we'll close the session at that point of time. And thank you. Thanks all.